Good morning, everyone. Thank you for attending the Japan Sports Orthopedic Association 2025. The conference will begin at 7:20 a.m. Please refrain from taking photos or recording audio or video during the sessions. We appreciate your patience as we prepare to begin.
自分一人では全世界の人を直さなきゃいけないです。自分の技術を提供する世界全体がハッピーになる。
患者さんからの感謝の言葉はすごい聞きます。どこ行っても治らなくて大体治っていると思います。
スタッフ同士のコミュニケーションが密だったり、連携が取りやすかったり、いい方向へ切り替えられる。リハビリテーション、理学療師を高く評価してくださってですね、非常にやりがいがある。
どのスポーツもね、復帰できたら本当嬉しいです。完璧です。
Jsoa は2020年に北池袋に設立。トップアスリートを含む多くのスポーツ選手、スポーツ愛好家など年間2万人以上の患者様の肩、肘および膝疾患に対応してきました。2025年1月には外来リハビリ機能に加え入院手術機能も備えた手術センターを東京都心の渋谷区北参道に新設。そして国内外の多くの医師をフェローやビジターとして迎え、世界の患者様を笑顔にと技術継承にも力を入れています。患者様の不安をなくすためのコミュニケーションを欠かさない。
外来、入院、そして手術の流れが本番という施設なので、スタッフ同士のコミュニケーションが密だったり、水生の意思が下に伝わって、すぐいい方向へ切り替えられるっていうのがすごくメリットであると思います。
何か所か医療機関に行ったけど診断つかずにすごい不安な状況でいたっていう選手はよくいますね。それはスポーツ選手アスリートに限らず他の人もやはりこうあちこち行ってできて「これパパ」って言うと「すごい安心しました」っつって涙がする人もいるんですよね。ずっと過去30年追求してきたんで自信はありますよね。
日本にとどまらず世界中の患者様を幸せに。
それこそ小笠原諸島とか沖縄、海外に住んでる日本人の方帰ってきて治療を受けて帰るっていう方もいらっしゃるし、
日本に住んでる外国の方もそうですし、海外から、日程を調整して入院手術をしに来る方もいらっしゃいます。
競技に復帰するところまで責任を持って伴走するリハビリテーション。
リハビリテーション、理学療師を非常に高く
評価してくださってですね、医師と同じプレイヤー扱いなんです。つまり治療の結果を出す責任はあるんですけども、非常にやりがいがあるアスレティックトレーナーにいますので、運動までしっかり方法まで実際に教えてもらえるんですよね。競技に復帰するところまでサポートできるのは最大のメリット、そういう声がよく聞けますので、
日本そして世界へ継承されていく T ソックイズム。
世界的にもすごい先生なんですけど、でもすごい話しかけやすいし、フレンドリーだし、怖くないです。優しいです。怒んないと思います。私たちも結構伸び伸びできるような環境を作ってくれてるというか。
全国から見学が、あと海外からも来られるんで、それが地方に広がっていけば、日本全国どこでも継承していくんじゃないかと思ってます。
患者さんも痛みが改善されて、みんなが幸せになれればいいかなって思ってます。
患者さんの幸せが一番なんで。
自分一人では全世界の人を治すわけにいかないですよね。自分の技術を継承する人間が増えれば世界全体がハッピーになる。
Thank you for your patience. We will now begin the opening remarks of the Japan Sports Orthopedic Association 2025. First, let us introduce Dr. Hiroyuki Sugaya from Tokyo Sports and Orthopedic Clinic, who is the president of Jsoa 2025. Dr. Sugaya.
Good morning, everybody. Yesterday, we had a big party, but because of the rain, the big problem, so we missed the several important guests. But from today, weather doesn't matter because it's inside a hotel, and also I set up everything in this one floor, this B2 floor in this hotel. And also the very nice sessions, and room number 1 and number 2 is only English session. And we have we have 9 rooms, everything. And also we covers everything, and not just shoulder and elbow, and also we have knees, and also hip, and also foot and ankle, and spine. So Japanese session is also very nice, very well organized because of the help of the committee. So I'm really proud of the preparation of this meeting. So that's why I want you guys enjoy the meeting. So next 2 days, it should be the great. And also tonight, we have, this evening, after today's session, we have the banquet. So banquet, you guys can enjoy, you guys can participate, everybody can participate. And the banquet happens in the exhibition hall in this floor. So that's why you guys can enjoy this. And also after the banquet, we have the special party, of course, for the faculties. So, and today's meeting, this is a very compact meeting, but I want you to enjoy this meeting. Thank you very much.
Thank you very much. We will now continue our program with the Isakos JSOA Combined Symposium, Shoulder Instability. This session will be moderated by Dr. Rachel Frank and Dr. Teresa Mihata. Now we are preparing, so please patient with me.
ฮ้ยบอสห้องที่พรีเซนต์คือห้อง5ใช่การบัญชาผู้พรุ่งนี้วันนี้จริงๆก็จบแล้วนะแต่เดี๋ยวอาจารย์มาไม่เขาน่าจะให้ซัพพอร์ตเฉพาะบางคนก็เลยตัวน่าจะแพงเราที่มาส่วนใหญ่การออกให้การออกเองที่มาใช่ปกติผู้แทนออกบ้างออกให้แบบเหมือนแบบต้องขอหลายคนดีนะของบอยมาดูออกเองเลยใช่ผู้แทนบอกไม่ร่วมเพราะว่ามันเป็นสมิธของที่นี่ก็เลยใช้ของอะไรวะสุดยอดฟิล์มคุณหมอบอลดูฟิล์มวันนี้เข้าห้องไหนน่าจะห้องนี้แบบยาวเลยไปดูเพลงอยู่ดูตลาดคุณน่าจะอยู่มีเพลงทำไม
We will now begin the Isagos Jsoa Combined Symposium, Shoulder Instability. This session will be moderated by Dr. Rachel Frank and Dr. Teresa Mihata. Dr. Frank and Dr. Mihata, please begin the session.
Thank you very much. Good morning, everyone. Now, this is the very first session of Dr. Hirosugai's Jsoa meeting. So it should be very hot topic here.
โคตรแบบกิ๊กก๊อกเลยไม่มีแอนิเมชันอะไรเลยสุภาพยืนพูด5 นาทีแล้วก็ลงไม่มีแอนิเมชันอะไรเลยใช่ครับแล้วก็เริ่มเนี่ยผมเห็นมีชุนยันเทียแล้วก็โฟเวนเชอร์มานั่งกันรวมกลุ่มกันอยู่ข้างหน้าเริ่มอีสคอร์ดเซสชั่นที่ยังไม่เจอเลยครับอาจารย์ผมอยู่ห้องหนึ่งที่มีภาษาอังกฤษโนบุยุกิยามาโมโตะใช่ครับมีแบ่งเป็นภาษาอังกฤษ2 ห้องแรกแล้วก็ห้องอื่นภาษาญี่ปุ่นได้ครับอาจารย์อีกสัก20 นาทีใช่ไหมครับ
The attachment of the IJ chair is moved freely like this.
ใช่ครับแป๊บเดียว
And in this basement, IJ chair is very thick.
ได้ครับเดี๋ยวอาจารย์ถึง
In
แล้ว
the
เดี๋ยว
medial
ผมไป
lateral
รอแถว
direction
ประตู
and the
ครับ
superior inferior direction, it can
นะครับ
move
จับเจอกันครับ
very
อาจารย์
So let's look at the historical finding of the intact flesh cadaver. 67 years female. This is the IJ bone, the glenoid side and the femoral side. Let's take a closer look at the glenoid side. the labrum, the articular cartilage, and the IGHL band here, and it's very thick, and it has a uniform fiber orientation. So there is a loose connective tissue between the labrum and the IGHL, and it has an irregular fiber orientation. And let's closer look of the mid substance and the humeral side also. Glenoid side, mid substance, and humeral side. Mid substance, it has a high fiber density and uniform fiber orientation. On the other hand, the low fiber density in the glenoid side and the irregular fiber orientation. Humeral side also the same tendency. It has a low fiber density and irregular fiber orientation. In the mid substance, fiber is a uniform fiber orientation. On the other hand, the attachment to the labrum, it's an irregular fiber orientation. That's why the IGHL attachment can move freely like this. So what happened after the shoulder joint dislocated? During the dislocation, IGHL is elongated, and then finally buccal lesion is created. I had one question: how much is the IGHL elongated? Began early investigate the IGHL elongation using 16 caloric shoulder, and they reported strain of the ligament was 11%. But in his study, the ligament was pulled out in the superior inferior direction. It's totally different from the actual situation. Then we performed the biomechanical study simulating the shoulder dislocation. To measure the ligament strain, we use a DVRT. It's very accurate, and the resolution is 2.0 micrometer. And DVRT was placed in the IGHL anterior band and the axial pouch. The shoulder was dislocated manually in this study. Here is our data. Blue line shows the IGHL anterior band, orange line axial pouch. Here is the exact dislocation moment. This is a stress strain curve. First lesion called the 2 lesion. The ligament is lax. Second lesion called the elastic lesion, in which the ligament is activated. The third lesion is called the rupture lesion. The ligament is partially torn or completely torn. Look at our data again. The 2 lesion, the elastic lesion, and the rupture lesion. The strain of the ligament IGHL was 20%. And axial pouch 9.5%. How much actually elongated? The strain of the ligament was 20%, which is almost 2 times compared to the beginning data, 11%. Second question was to what extent is the IGHL damaged? So look at the histological finding. In this specimen, he has a bony buccal lesion. The intact shoulder, and after dislocation, the IGHL, the staining decreased like this. Let's look at mid substance and bony attachment. After dislocation, the glenoid, bony the side, and the fibers are partially torn. And there is a space between fibers. In the mid substance, the fibers are not torn, but the staining decreases. Humeral side also has the same tendency. The fibers are partially torn, and there is a space between fibers. If you compare the intact shoulder and the dislocation shoulder, difference is very clear. So our data indicated the bony attachment more severely damaged. So bone attachment might be weaker. The avulsion between the labrum and the IGHL never occurred. Always avulsion occurs from the glenoid side, like a buccal region. So it's mechanically weak. There are many reports performing the Proud test using fresh cadaver, but there are no detailed description about the avulsion side. Look at the histological finding again. The labrum, and there is a fibrocartilaginous tissue. It's composed of the 4 layers like entasis. It is demonstrated to have a shock absorption and it is mechanically strong. But it is often damaged due to injury pattern of the dislocation. When the humeral head translates anteriorly, being compressed to the glenoid and peeling off the labrum, then finally buccal lesion is created. That's why the fibrocartilaginous tissue is damaged. In summary, IGHL was elongated by 20% and the bone attachment was more severely damaged. The fibrocartilaginous tissue is damaged during dislocation. Thank you for your attention.
Thank you very much. The speaker here, Dr. Mark Provencher from the State Farm Clinic in US. And I told you it's severity anterior versus posterior. What's the difference, please?
Good morning, everyone. Thank you. So this is to talk about the differences between anterior and posterior instability. And when you look at this patient and their pathology, it is actually quite different. They have different mechanism, different examination, different presentation, and different pathoanatomy. Well, what about the mechanism? We know the classic arm coming out, but posterior in the United States or rugby or landing on it or repetitive microtrauma on bench press lifting, you get kind of the arm inflection, internal rotation. Posterior load and shift, very classic finding, and you can see how it reproduces clinical issues. So we have a study where we looked at 200 patients, 100 anterior and 100 posterior. As you would expect, anterior instability, they could know when they dislocated. I heard it exactly then. Posterior, it was much harder, unless it was a very traumatic injury. The outcomes were superior after anterior when we looked at all of it, but they had much different findings. Posterior can be missed, can present with pain in young patients, discomfort. Subacromial injections don't help. Many patients come with a young patient with subacromial injection. It doesn't help because they don't have impingement. They have posterior instability. Many can demonstrate the instability, but they don't really like it. Like this patient here, he shakes his shoulder off and really doesn't like to do it, but he can reproduce it. We have many different types of tears, both anteriorly and posteriorly, and we have to identify those, but no, these are also very different. In posteriorly, we have always described it with Professor Kim, the Kim lesion, which was an important finding. We do not get Kim lesions anteriorly. We do not get cracks, buckets, or other things in an anterior dislocation. We only see this posteriorly. So there are more cracks, more buckets, and more flaps posteriorly. Anterior and posterior have different MRI findings as well. They also have different types of bone loss and different types of Hill sacks. The traditional Hill sacks anteriorly, very high in the humeral head. It's almost all bone unless it gets very big and then it becomes cartilage. Reverse Hill sacks is much lower, but it involves almost 100% cartilage. So reverse Hill sacks, very different in its finding. How about on the glenoid side? Much different as well. We looked at a lot of this, and if you look at the anterior dislocations, we know that bone loss occurs in the front parallel to the long axis of the shoulder, or pretty close. Posteriorly, much different. We have a different slope at about 38 degrees to 35 degrees, and you get much different type of bone loss morphology different. And when you look at all of this from a three-dimensional imaging, you have more obtuse slope of the defect, greater retroversion, steeper slope of the anteriorly. So you had almost 80 degrees anterior, where posterior was about 40 degrees. The ligaments are also not the same, and the muscles are not the same. We know that recurrent posteriorly, the defect is much different. It's higher in the clock face than it is anteriorly. The orientation is more acute versus more obtuse posteriorly. And so you can see, as you change percent of bone loss, you get different widths and different lengths, but the orientation overall is much more obtuse posteriorly. From a recurrence standpoint, anterior has a bad recurrence, as well does posterior. When we looked at our outcomes in posterior, you had a 10-time failure rate if you had 10% glenoid bone loss. If you had 15% posterior bone loss, you had 25-time failure rate. So posterior bone is very important. It may even be more important than anterior bone as we start looking at it. We also know these are probably a different surgical solution if you need bone graft. So if you need bone graft, Latarjet, we know, is like a rectangle. It's a square. Posteriorly, it's more trapezoidal. And so this is a very important configuration. We're starting to define how we do bone procedures. This is a classic example. The average is about 85 degrees anteriorly of that angle relative to the glenoid, whereas posteriorly it's about 40 degrees off the glenoid axis. And you can see when we compared hundreds of CT scans, this is the biggest difference in our bone loss configurations. Here's a 35-year-old patient who fell on a mountain bike, had a big posterior labrum tear plus a posterior dislocation, had very bad tissue here, more crack and flaps, much different than an anterior tear. An anterior tear just does not present like this. Also had a posterior glad lesion, but had a very large amount of bone loss, and here we're preparing for a glenoid bone graft in the back. We're using measurement tools, but you can see the angle we're dealing with here, and there's the angle of the glenoid. You can certainly make this more acute with a high-speed burr or other configuration, but then we're going to put in a fresh distal tibia graft and fix this very bad defect from dislocation. Thank you very much.
Thank you, Mark. The next speaker here from Japan, Nori Takahashi. So he's talked here anterior instability, our rationale. No, he changed. Both and morphology-based surgical strategy. Please.
Thank you, Chairman. And I'm happy to be here. So I would like to present our rationale based on sports and morphology. Is my disclosure. Traumatic anterior shoulder instability is common in athletes. Collision and contact sports such as rugby and American football show particularly high recurrence risk. In contrast, baseball players, especially pitchers, require both stability and preserved range of motion. Therefore, one single procedure cannot cover all athletes. Our strategy is too individualized, surgical indication based on sports type and bone morphology. From 2004 to 2015, we performed more than 1,500 arthroscopic stabilization, and over 80% of these patients were athletes. We found that collision contact athletes showed a high incidence of associated interarticular lesions such as bony bunkers, strap, and capsular tear. Regarding of recurrence rate, collision sports had significantly higher rate of recurrence. Contact sports also demonstrated a higher trend in recurrence. Based on this experience, since 2012, we have applied a sports and morphology-based algorithm. For example, glenoid defect greater than 25% were treated with iliac bone grafting. For moderate bone loss in high-demand athletes, we used arthroscopic Bankert repair with ramp research, with or without rotator interval closure. In young collision athlete, ramp research was also considered even without critical bone loss. To summarize, our first line procedure is arthroscopic Bankert repair. We then selectively add augmentations. For collision athlete, ABR plus rotator interval closure, sometimes with ramp research. For baseball throwing shoulder, ABR only to preserve range of motion. For high-risk young patient, rotator interval closure. For glenoid defect over 25% rear bone graft. This tailored approach aims to balance stability and function according to demand of each sport. This is revision case. 17 years old soccer player was dislocated after ABR. He showed small bony and heel sacks. We can see the Bankert region and large heel sacks region. We created posterolateral corner portal to insert anchor in heel sacks region. Suture is placed infraspinatus tendon and teres minor tendon. After finish Bankert repair and RI closure, ramp research is completed. In our HSM report, we evaluated 113 shoulders in rugby and American football players, mean age 20 years old. We underwent ABR with either RI closure or RI closure plus ramp research. Functional outcome improved significantly, low score from 36 to 96, and the subjective shoulder value from 22 to 92. At an average 44 months follow-up, dislocation occurred in only 3.5%. Recurrence was observed in 4 teenager athletes. Return to play at the pre-injury level was achieved in 93% of athletes. These results demonstrate that soft tissue stabilization with selective augmentation can provide reliable stability and allow high-level return to collision sports without risks associated with bony procedure like bandaging. We also studied 119 baseball players with at least 2-year follow-up. They included 67 throwing shoulders and 52 non-throwing shoulders. Mean age at the shoulder at the surgery was 21 years old. All patients underwent arthroscopic Bankert repair. Rotator interval closure was indicated for a few throwing shoulder and most of non-throwing shoulder. In throwing shoulder, the return to play rate was 72%. Time to return was approximately 12 months, which is longer compared to the other athletes. In non-throwing shoulder, the return to play was higher, 83%, and recovery was faster, around 6 to 9 months. Recurrence was all about 6% in both groups. Thus, arthroscopic Bankert repair achieved acceptable outcomes, but the rehabilitation was notably prolonged in throwing shoulders, reflecting the unique functional demands of baseball. These findings emphasize that surgical precision should not be uniform. For collision athletes, selective augmentation such as rotator interval closure and ramp research successfully reduced recurrence and achieved high-level return to play. For baseball players, functional preservation is prioritized, even if return takes longer. Bony morphology, including glenoid bone loss and heel sacks region, also guides the choice of algorithm augmentations. Overall individualized strategy based on both sports type and pathology result in better and safer outcomes. In conclusion, soft tissue pancreas repair is our main procedure. By applying sports and morphology-based selective augmentations, we achieve excellent clinical outcomes. For collision sports, stability was reliable with low recurrence and high return rate. For baseball players, shoulder function was preserved with acceptable return to play. This approach provides safe and reproducible outcome across the diverse accelerated population. Thank you for your attention.
Thank you very much. So next year from Korea, JCU, Professor JCU, how can we improve our result in arthroscopic pancreas repair in 2025?
Okay, thank you very much. Thanks for the invitation. That's amazing results, just previous talk. I have nothing to disclose. You're welcome to KSCS 2006 in March, end of March in Busan. And you're also welcome to the APCAS in 2026, which is in September. So these are the lectures that was given to me or was presented recently in Europe. It seems that since 2022, arthroscopic pancreas seems to be diminishing. And if you look at the long-term results of isolated, the redislocation is from their hands is almost 30%, and for under 20, they're almost 50%. If I look at my series, which was 2007 to 13, where there was no replicage, no non-tying, mild bump, edge anchors, at this time I was doing very, very little ladder J at that time, very limited surgeons doing ladder J in Korea. Even 25% bone loss were done with pancreas repair, and still have 20% redislocation rate with 20% about apprehension. That adds up to be about 40%. I just had visitors from the French, and they said they never do pancreas, all ladder J, because they cannot accept this 20% redislocation rate. So if I look at my series, I'm doing more ladder J and less pancreas, and I'll tell you why. And because I think we need additional 10-year follow-up, 2016 or 17, when there was remplissage. Now we understand better anchors, better technology, better soft tissue procedures, better indication, and maybe we can lower it to 10% or lower. Maury's results of 5% or less is amazing. So why do we fail? I think it's indication problem. Previously, we did pancreas on these patients. This was one of our senior doctors did pancreas twice in this patient 15 years ago, failed right away, wrong indication. So I think bone loss, I think we have to be a little bit more strict. Maybe 15% might be the key number. And so I think we need to reduce down. If there is a glenoid bone loss, we have to deal with the bone. If these patients are under 20 or maybe even 25 doing these crazy sports, or lovely sports, excuse me, but because I love ice hockey, and probably some people here love rugby, like where is our rugby player, Tomo. And I did this 16-year-old rugby ice hockey player, arthroscopic pancreas. And 6 months later, he has a game and he just tears everything off. So I did a ladder J. And secondly, I think many people are doing, some of them are doing a wrong procedure because this is their 4 o'clock. This is their first anchor. This is their first anchor in US and Europe. This is their first anchor in Korea, right there. So I think you're not really addressing the pathology properly. You need that 5:30, 6 o'clock anchor to shift your inferior 5:30 to 6:30 tissues, to shift that tissue way back. And we're doing a soft tissue procedure, so if you really want to stretch them out really early, I think we should do a very, very slow mobilization. This is my patient at 3 months. They're very, very stiff because I kind of repair everything at 21-year-old. I tried to repair everything, maybe even RI closure. But if you look at them at 2 years, they're too lax sometimes. So I kind of worry about dislocation. So I really don't worry about stiffness. So how can we improve? We can't control any of these factors, age, bone loss, or activity. The only thing we can control is surgical technique. So I recommend doing a lateral decubitus position because this is much better in instability. You need to mobilize that 7 o'clock tissue. The 7 o'clock tissue is a little bit difficult because it's most tethered at the 530 right there, and you need to really release that final tissue. First you release here and then you release there. You will hear the final pop, and that will just, if you feel that finer tethering tissue, and you can still see it's kind of hindering but you see that, and then it will just go, everything will just go up after that last pop. You can see that it goes up. You need to mobilize that much. I recommend you to do a mattress repair at 6 o'clock so you can get the both hemlock type repair. You can do this by using a posterior portal. It's easy. One of the things that I changed was from using a suture hook to using a scorpion type of get a maximum bite from the posterior at 5:30 o'clock. This works very well. I've been doing this for 10 years, and my fellows love it. You can get the big bumps. You can just cover the entire glenoid as much as you want. And we published this. There's a publication saying that the isolated Bankart is not enough. You need the remplissage. And if I look at my series, I'm doing more than 60% of all my cases with remplissage. I'm sometimes doing rotator into a closure because Jsoa keep insisting me to do this because it's much better. But I'm not doing it in all the cases. So I've been doing knotless since 10 years ago, and this knotless seems to works very well and our results show the same as or even better with knot tying. And if we've been putting this knotless bioabsorbable anchors on the glenoid surface, and right next about 3 or 4 millimeters medial from the edge. And you can see that you can get, depending on the tissue you can grasp, you can cover almost half of the glenoid to about 1/3. And we try to look at these if there is any problem with the stiffness and stuff. But so far our results, less than 5-year follow-up, is around 3.4 dislocation, which is okay, but you still need like 10-year follow-up because that even people with 7 or 8, 9 years, they come back with dislocation. So we concluded that knotless is very nice and low recurrence rate on the glenoid surface. Another thing that you really have to think about is that when you're doing a ladder J, everybody knows your screws and your bones, but when you're looking at these ladder J's, everybody and with a good X-ray and CT, everybody can kind of evaluate what you're doing. Whereas if you're saying I did a good Bankart repair, but I don't know if that's really a good Bankart repair. So I don't know if we're on the same page. So this is my current, I don't want to go crazy with this algorithm. It's just that the key factor that I'm looking at is, for the first time dislocated, is glenoid bone loss, age under 25, contact sports. For recurrent shoulder dislocation, it's the glenoid bone loss, same thing, age, and the current contact sports. So in summary, let's reduce urgency factor, and let's make it on the same page. And then I kind of recommend you to do knotless Bankart repairs. And finally, the question, is there a role for isolated Bankart repair? I think it's very rarely. You can see from the Maurice paper also that we need to add at least remplissage and maybe rotator closure in many cases. Thank you very much.
Thank you, Jsoa. speaker, Sanjit Shin from Korea again. He's talking the arthroscopic bony buccal repair based on the size of bony fragment, please.
Okay. For successful back repair, I think that we need to manage the glenoid bone loss. So when I review my patient, objective surgical failure is closely related with the glenoid bone defect size. Everybody knows in this room that there are two different kinds of glenoid defect. Bony bankcut, which can be treated by arthroscopic bone fixation. But glenoid erosion, the other one is glenoid erosion, which can be treated by bone graft when glenoid erosion is more than subcritical bone loss. When I do the biomechanical test, I found that dislocation force decreased proportionally from the 2 millimeter defect. So the conclusion of this biomechanical test is bony restoration is recommended when a bone loss exists, even though the fragment is small. But I want to know the clinical differences. So I divided my patient into two groups, bony bankcut group and then glenoid erosion group. The clinical result was somewhat different from biomechanical test. Less than 20% of differences, glenoid differences between the two groups, more than 20% of glenoid bone loss. There are differences. The bony fixation is much more, the clinical outcome superior to the bony erosion. What makes the differences? Because if you see this the graph, when the bone fragment is smaller, the absorption rate is higher. So higher fragment absorption can be observed in the smaller bony fragment. That's why the differences between those two. So also in bony bankcut repair, we need to restore the bony concavity. So based on this test and then the results, I repair differently based on the size of bony fragment. So for small fragment, I repair just like the bankcut repair. Medium fragment, I use modified masonry repair. Larger fragment, I use the double row bridge repair. How big it is? I roughly divided an anterior defect into 3 parts. So fragment is within the 1/3 area, I call it small. The fragment within 2/3 area, I call it medium. The fragment larger than 2/3 area, I call it large. So small bony fragment is same as bankcut repair because the small fragment has high possibility to be observed and lose its role to decrease the bone defect area. This is my operating theater, and then this is summary of my portals I used for the glenohumeral instability surgery. So I like to use old suture anchors. Here is this is typical bony bankcut lesion. So when I release it, and here's a bony fragment, which is small. So I put all the suture, and then pass the sutures just inferior or superior to the bony bankcut lesion. But the different thing is, I tied from top to bottom after all past the sutures to the labrum. The reason why I do this is that I want to give a maximum tension on the most inferior part. So medium-sized fragment, I think that we need to fix strongly. So one double-loaded suture anchors, I inserted the medial side of glenoid, and then which is double-loaded suture anchors. So one pair of sutures, I make it horizontal matrix suture, which compress the fragment to the glenoid strongly, and then one simple vertical sutures, it prevents tilt to the glenoid. So when I insert this medial anchors, I try to insert as parallel to the glenoid surface and then prevent to this kind of tilt over the glenoid. For the insertion of medial glenoid to the parallel of the glenoid surface, I use a transsubscapula like this. So this is medium-sized bony fragment. When you are not familiar with the medial transsubscapula, I recommend you to put the medial anchor first before the shoulder is swollen. So once you decide the location of retracted bony fragment, that's transsubscapula, which can be, we can insert the glenoid anchor parallel to the glenoid surface. Then inferior to that, It's the same as a normal band cut repair. And that's the inferior horizontal mattress sutures. And then that's a single vertical sutures. And this is superior horizontal mattress sutures. So when I tie this horizontal mattress suture, it compresses fragment on the glenoid defect side, and that single vertical sutures, it prevents the tilt of the glenoid. And then finally, the large bony fragment, I use the double row bridge repair, which fix the fragment to the glenoid so this is glenoid fracture. Always troublesome is the past sutures below the fragment. There are 3 ways. So you can use the curved suture hook through the anterior inferior portal, and then you release the shorter delay between the outside of fragment and then the inside of subscap area. There is a small space there. When you release a shorter delay, shorter delays will be bounced back from the subscap or the defect area. And then you can use the crescent hook from the transsubscap portal, and then you can use the antegrade suture pattern. This is glenoid fracture. Usually, you cannot use the screws for that kind of fractures. So inferior to that, the band cut repair using all suture anchors. And then this fragment size is too big, so I decided to put 2 medial anchors. One is single rodic, and then pass the sutures below the fragment. One more the outside of fragment through the labrum. One more double rodic suture anchors and put medial to the glenoid. So parallel directions. And then I passed all the sutures, 6 sutures outside the fragment. Then I put 1 more suture anchors. So I tied the most inferior one and the most superior one, and then tied the lateral part. And then using those sutures, I put the double row bridge repair using the nutless suture anchors on the glenoid surface. And you can get form fixation. So this is the order of anchor insertion, but I tie the most inferior one, superior, and then medial one. And just the foyer is good. So when I reviewed those patients, I found that 18% have osteoarthritis, but which is very low, grade 1. So summary, when I compare the groups among those 3s, the group 3, the large bony bone cut patients are older and the size are bigger. When I repair differently, the clinical outcomes are all the same, and then absorption was higher in the smaller fragment. So bony restoration is recommended whenever you find the bone loss, and then I would recommend that different type of repair based on the fragment size. Thank you for your attention.
Thank you, Sanjun. So, last speaker from US Colorado University, Dr. Rachel Funk. So she speaks about the anterior shoulder disability again and soft tissue repair and bone loss strategy, please.
Thank you very much. It's my absolute honor to be here, and thank you to Professor Sugaya for the kind invitation and to ISACOS for supporting this combined session. My speech or my talk here will be a little bit of a summary of what you just heard from some amazing surgeons and researchers over the last hour. My disclosures are all available online, nothing relevant to this discussion. We all know that anterior shoulder instability is common. That's why we're all here, and our goal is to figure out the best way to individualize the approach to fix the patient. The treatment options range from non-surgical management to soft tissue repair, either open or arthroscopic, and bony reconstruction, again, which can be performed open or arthroscopic. So how do we choose? We have to choose based on the patient, your own skill set as the surgeon, and the tools available to you with respect to grafts, implants, anchors, etc. And certainly the patient is the most important factor here with respect to their age, their sex, their sports, and their timing with respect to being an in-season versus an off-season athlete. My preferred approach whenever I can is to do an arthroscopic soft tissue repair, as you've seen previously in this session and as I'll demonstrate here. And I echo many of the tools and pearls that have been discussed already. First, mobilizing all the way to 7 o'clock and feeling that pop. Remember, this is an inferior injury as much as it is an anterior injury. Second, using knotless all suture anchors has become my anchor of choice simply due to the ease of use, the ability to retention, and the lack of the knot stack irritating the potential cartilage. And then we can work with a number of different portals in the lateral decubitus position to make sure that we can get our repair shifted superior as we're working from inferior to superior. We typically employ a minimum of 3 anchors below 3 o'clock, and I always apply a 7 o'clock anchor in every single case, even if the labral tear does not extend posteriorly, because again, this is an inferior pathology in addition to being an anterior inferior pathology. And you can get a nice shift, as you see here, with the capsule and the labrum, really nicely restoring the anatomy. And then typically we're adding a remplissage for most patients now, at least in the United States, regardless of bone loss, but in particular in the setting of bone loss. And that's because we've learned that the outcomes following isolated Bankart repair are simply not as good as we'd like, even with improved technology and techniques. And so the order of events for this is to do the diagnostic scope first, identify your pathology, prepare the labrum, prepare the Hill-Sachs defect. I like to place my anchors for the remplissage first before my Bankart repair, but I don't tension them down so that I don't close the joint space and allow a more difficult working space for the Bankart repair. We'll then go do the Bankart repair, and then finally at the end, tension the remplissage anchors in a knotless linked fashion. Now, despite all of these advances in techniques and technologies, when you look at the literature, even in the best surgeons' hands, the highest volume surgeons' hands, and excellent surgical technique and rehabilitation, we're still having failures following isolated soft tissue repair. Why is that? Many factors are at play, but the number one common factor is bone loss, either on the glenoid or the humeral head side. So how do we understand bone loss? This is something some of my mentors, including Dr. Preventure, have taught me, and I really think about this during each and every case. Just a few millimeters of glenoid bone loss, much less than what you see on this video here, can account for up to a fourth to even a third of the surface area of the glenoid inferior circle. And so when you have just a few millimeters, you have to start shifting your thinking from soft tissue to bone, as remplissage may not be enough. And what about the humeral head? We've learned so much with Professor Yamamoto and others about the glenoid tract and whether lesions are on track, off track, and how we can make lesions less important even without treating them by restoring the anterior glenoid rim or by directly addressing the lesion and doing a remplissage. So it's important to understand the bone loss component. My treatment algorithm in 2025 is constantly evolving. Coming to meetings like this one, as well as many others throughout the world, have really educated me as to this can't be one size fits all. We have to customize our treatment to the patient. I think the biggest take-home point that I've gathered over the last decade is you need to treat bad bone with good bone. And so our options include Latarjet and autograft and allograft bone grafting. Now Latarjet, I'm going to go through this fairly quickly, but we all know that Latarjet is excellent with restoring stability. Christian Gerber and many others have shown us that. High rates of joint stability at over 20 years of follow-up, and failure, recurrent instability, is uncommon. But as one of my mentors would say, there's no free lunch, and there are some potential concerns with Latarjet. It's not anatomic, it's technically very demanding. If you have a complication, that complication is likely to be significant, and there's no clear advantage to the arthroscopic approach for Latarjet. And so Matt Preventure and others have looked at alternative options, including distal tibia allograft, and this has become my treatment of choice for glenoid bone loss. We looked at distal tibia compared to Latarjet in a matched cohort analysis, and we found that in patients of similar age with similar degrees of bone loss, actually slightly higher in the distal tibia group, the patients did quite well with respect to outcomes, equal outcomes with respect to recurrence, just 1 in each group out of 50 in each group, and reoperation rates were also very similar. So distal tibia allograft through an open approach has similar results compared to Latarjet. When we think about applying these outcomes, we have to also think about the potential complications. And certainly with distal tibia allograft, there is also a learning curve with this procedure, and the cost and availability of allograft can be very difficult, even in the US, but certainly throughout the world. And so now, are there other options that we have at our disposal? Other glenoid bone graft options include autograft options, as you see here, but in the US, I will say that most patients prefer not to have their hip violated if they're having a shoulder surgery. And so we do often proceed with allograft in these cases, or a Latarjet, because we're operating in the same area. And certainly don't forget about restoring the humeral head bone loss if a remplissage is not enough. My approach in 2025 has evolved to using the distal tibia allograft in the way that Dr. Preventure taught me and so many others, but through an arthroscopic approach. And so with my last minute here, I'll take you through this video. This is a patient with a failed Bankart repair, lateral decubitus position. We're removing the old sutures and anchors, as you can see here. We're prepping. Now, he has quite a bit amount of good labral tissue here, and some might be tempted to just do a revision Bankart repair with one remplissage, but when you calculate the glenoid bone loss, you have to be cautious with respect to a soft tissue only procedure. So here we're putting a traction stitch in the anterior labrum from anterior. We're viewing from anterior superior lateral. We're prepping the anterior glenoid with a burr, and then we're using a proprietary guide from the posterior portal to drill 2 semi-parallel holes from posterior to anterior at about 4 o'clock on the glenoid. So those anchor holes end up being at about 5 o'clock and about 3 o'clock on the glenoid, which is where you're going to want your bone block. We'll go ahead and measure the dimensions of the bone loss to prepare our allograft on the back table, which I'm not going to show in this video for the sake of time, but you can prepare the allograft quite nicely on the back table. And then we can use a variety of different fixation options. In this case, I've chosen an all suture-based fixation option, so no anchors, no buttons, and no metal screws, but a cerclage with high-strength, non-absorbable suture tape and fiber tape materials to shuttle the graft in, as you'll see here. The graft is going to now come in through the anterior rotator interval portal, and you'll need to finesse the graft in, and for me, this is the, for sure, hardest part of the case, but for the sake of time, I'll skip it just a little bit. Once you finesse it in, you can then choose to repair your labrum either over the top of the graft or onto the native glenoid. And in this case, I elect to fix it over the top of the native glenoid, so at the end, it'll eventually hide the graft. As you'll see on the bottom right picture, that is the actual same patient, but you can't even see the distal tibia allograft, making the graft extra articular as we go through. So in conclusion, in 2020, one more slide before the conclusion. Important to remember that when you look at recent literature, Bankart repair plus Latarjet, even in the setting of significant bone loss up to 25%, with multiple studies across multiple regions across the world, have shown increased or improved outcomes relative to Latarjet. So the all soft tissue approach may be very helpful if you're adding the remplissage to the Bankart repair, even in the setting of bone loss. So finally, in conclusion, my overall approach in 2025, typically if there's minimal glenoid bone loss, I'm doing the Bankart repair plus remplissage. If there's significant glenoid bone loss, I'm adding an arthroscopic distal tibia allograft. Thank you all very much.
We come up with 6 figures, and we actually Dr. Nobu Yamamoto, he presented about the biomechanics, and Dr. Preventure, posterior instability, and other 4 doctors answer disability. So we will discuss about the biomechanics first, then next the posterior instability, and finally anterior instability. So first, I want to ask a question to Nobu about the biomechanics study. Can you find your seat? Yes, Dr. Nobu Yamamoto, actually you showed the elongation, the 20% elongation. I think it includes the plastic and elastic elongation, maybe the permanent and non-permanent. So how much the permanent elongation you study after dislocation?
In our data, just we measure the strain of the ligament. So, and we perform the pathological finding. And so we don't know differentiate the plastic and the permanent the elongation by this study. unfortunately.
Okay, but maybe previous study shows some total already shows. How do you think about your maybe 20% elongation, permanent elongation is too high, I think. Yeah. So how do you think about your impression?
Yeah, and especially the bony attachment, some fibers are partially torn, so that's permanent the damage to the ligament. But resubstance, in many cases, just probably temporarily stretched. It's not permanent damage, so we can reuse the ligament of the IGHL.
And one more question: how much elongation is clinically critical?
From this study, we can say one dislocation make the ligament elongated by 20%. If the patient has a repeated dislocation, elongation is more. So, but now we don't have any data about the repeated dislocation data. Probably not so many, maybe 25% or less than 30%.
Okay, thank you. Any question from floors?
Well, I'd like to ask Dr. Preventure a question. When we compare bone loss, anterior and posterior, it seems that each year we go to meetings and the critical number for anterior bone loss to augment gets lower. We went from 25%, then it changed to 20%, then 15%. Now with JT's study, 12.5%, and it just seems that the threshold for augmenting the glenoid anteriorly is getting lower. What is the threshold for posterior bone loss, especially in light of the morphologic differences of the posterior glenoid bone loss? As you really elegantly described, that angle is different and how it occurs is different. Do we need to be more aggressive, less aggressive? What is the number we should be looking at when we're measuring to say you have to do something to the bone?
Rachel, I think that's a very good question, good observation, and we've traveled on this journey together in a way, in terms of how much bone loss is enough. The feeling I have on this, and the reason this is going on, is we have longer term follow-up, and as the follow-up gets longer and longer, we know that the glenoid does not take a joke. And so as you lose a certain amount of bone loss, maybe it's 12%, 18, 7%, if you look at those differences, that's maybe only 1 or 2 or maybe at most 3 millimeters of glenoid. So it does not take much to add up percentage-wise in terms of glenoid bone loss in general. So when we're looking at posterior, the problem we found is bone loss is probably even much more important in posterior than it is anterior. I think we can cope, we have other ways to deal with it, but posterior bone loss we're finding is much less, and we originally came out with a clinical number that was, say, 15% of posterior bone loss, but it's not probably too accurate, and I think it's much less. I think at even 5-10% of posterior bone loss, can lead to problems. It's much more impactful mechanically than it is anterior.
Okay, any question from floor to Dr. Preventure? Oh yeah, Sanji.
Yeah, so I think that the recurrent posterior instability is very rare in my country because we don't have that kind of collagen sports. So what do you think about what we found a lot of posterior labral tear without instability? What do you think about that kind of concept?
Yeah, no, I think you're from an area that helped us define what extensive labrum tears are, and I think they start anteriorly. It's a circumferential fibers. Terry has taught us so much about the labrum and what it looks like from a histological standpoint, but I think if you start anteriorly, you get the tears that go around the back very quickly with multiple instability events. And we've published on that a lot, as many others, radiographically and also arthroscopically, the findings after multiple anterior dislocation events create more extensive labral tears. There's no question about that. And how do you deal with that? Is it important? It's probably more important just from a detachment standpoint, not necessarily stretching the capsule posteriorly, but more just compromising the labrum.
Any question, Arthur? Dr. Provencher, actually stability, the bone fragment type and erosion type, you can see that in the granite. But posterior instability, do you see some erosion type? Mostly erosion type, I think, but this is sometimes the bone fragment.
Yeah, great question. So, question about bone fragment posteriorly, much different in terms of anterior instability. What is interesting is the fragments heal much differently posteriorly, we found. Many times, if you look closely at the axial CT, you will see in young patient good concavity and then a small depression. You don't really get that anteriorly. You get a much more rounded fragment. It's some really nice talks here looking at attritional bone loss, small, medium, and large. Classification is a good one. Posteriorly, a lot of times you get a fragment and then it heals a little bit medial. It's almost like you had a fracture of the posterior glenoid. But look closely. In a posterior instability patient on the axial CT, you will see a disruption and maybe healing of the glenoid of the posterior 3 or 4 millimeters. Very interesting. Does not happen anteriorly.
One question about the surgical treatment, the surgical technique actually. When you do the bone grafting, then you do the repair of the labrum also, or plication.
Yeah, I think Rachel showed a really nice technique where we do both bone grafting and labrum. The labrum is actually a very nice compression device that is secondary to screws or suture buttons or things like that. So we like using the labrum as an additional compression device and to also improve concavity compression of the glenoid. I think what we found on our bone grafting, whether it's anterior or posterior, very important to restore that concavity, not just put it in flat. The labrum can make up for some of that, but you have to restore concavity. And that's why we cut the bone graft at 10, 15, 20 degrees anteriorly, so you can tilt it up. Much harder to do with Latarjet versus free bone block.
Okay, any question? Okay, Professor Ngoli.
I want to ask about the combined lesion. When we do the arthroscope backward repair, sometimes we incidentally find a slab lesion with the posterior inferior labral tear. So before surgery, did you check this slab or the posterior tear? Because the patient has so apprehension with this position. So and then sometimes we do not find out the slab lesion or the posterior inferior labral tear through the physical examination. So did you check this kind of combined bleeding before the surgery?
Doctor? We routinely do arthrogram to check the labrum tear before surgery, but sometimes we cannot clearly evaluate it for posterior labrum tear. But if we see the arthrotic surgery, we can repair. But before surgery, just MR arthrogram.
Thank you. My question is, this slab or the posterior labral tear is symptomatic or the asymptomatic? So do we touch this posterior labral repair or the slab repair? Sometimes I'm wondering that is good for patient or not.
I personally think that for posterior, if it's continued with the anterior to posterior, I think we need to repair. For a slab, maybe it might be a little bit different. I think slab is another spectrum of instability, continuous spectrum, and whether we should repair or not, I think it's still a little bit controversial. But if the patient is very lax, I think it would be better to repair everything to make it a little bit more tighter, although he's going to stretch it out anyway.
So how can you know that is a symptomatic?
I don't think that's a good question, but I don't think in a physical examination we know, because it's already apprehensive at 90 degrees. So I'm not sure if we can do like slap tests or other posterior tests. We can do posterior jerk tests, but I'm not sure if that's kind of overlapping. Matt, do you have any?
It's a good question. I'm not sure we know how to fully diagnose complex findings, meaning more than 2 or 3 things going on in the shoulder. Posterior jerk test and is positive. Is the slap test positive also? Is inferior sulcus, AJ sign positive? There's a lot of things to put together. I think JC said we have to be, just really treat the patient. And a young patient that has an anatomic lesion of the labrum, a young patient with instability, if they have SLAP, I generally repair it. The reason for that is when we look at mechanics of the labrum, it's important. And we studied it in a robot model with and without the long head of the biceps on. Long head biceps didn't matter too much, interesting, because we didn't have loaded. But we found anywhere from 3 to 10 millimeters of translation loss if we did not repair that SLAP area. Now we don't want to do it in 40, 50-year-olds, 60-year-olds, no, but in young patients, I think it matters.
Yeah, I think you're right. The physical examination, we can't discriminate because anterior operation is too strong. But I found that pain, the posterior labral tear causes pain, so I try to repair. But cautious is not too tight, make it too tight. So I try to repair every pathologist when I do the surgery.
So that even patients has a strong operation test positive, I do the compression rotation test for the SLAP and the posterior compression test with this adduction for the posterior inferior labral tear. Sometimes patients complain pain. I look at the inside very carefully. So if there's a tear, I try to repair. Thank you.
Even the preoperatory, you found the posterior labral lesion, but if they have no symptom, the posterior instability, I don't touch. And the clinical result is very stable. You can get a clinical result.
Okay, Jimmy. Yep, thank you. And I think, as Rachel said, it's very true that we got a lot of like a demarcation line for the anterior bone loss, and we have our decision before the surgery based mostly on the anterior glenoid bone defect. My question actually is for all presenters. How often do you meet such kind of patient that what really matters, that make you a hard day in the operating room, is the quality of the capsules? Especially like Matt said, if you got a posterior instability with maybe one part of the NDI, fraction of the whole thing, sometimes you repair it, but this cuts through this very flimsy capsule. I know that this is, in my experience, there will be a retrospective judgment. But I want to know, do we have to get prospective judgment before we go to the OR to judge whether our patient had a healthy capsule? Rachel?
It's such a great question. We see this so much in the revision setting, but when it's most difficult in my practice is the unexpected patulous capsule in the primary setting, where you're intending to go in for Bankart remplissage or even an arthroscopic bone block, but you were hoping to rely on that capsule for your capsulolabral shift, and every time I place my suture passer through it, it just gets thinner and thinner, and then there's a big hole. And I'm thinking, gosh, what could I have done to have predicted this? And that's your question. I don't know that we have an answer in 2025 yet, but I'm presuming that we will in the next couple of years with big data studies looking at MRI tissue quality. I do think that looking at the patient's Baton score and overall laxity appearance can be helpful, but I have not found, and I'm curious if the panel has found, I don't find that my hyperlax individuals necessarily have less robust capsules. It's just more stretched out, but still of good quality when we're doing the capsular plication. So that's a long-winded way of saying I don't have a way to predict that. That's where I'm very thankful pre-surgically that if I'm doing a bony procedure, I at least know that that should increase my odds of success.
Any comments? Very good question. I think we have to separate anterior from posterior. I think for posterior, most of the cases are not that good tissues, I think. So it's a completely different animal. For anterior, I think, so I'm not sure if we can predict posterior. Just predict it's going to be bad in the first place. But for anterior, most of the young patients with less than 5 dislocations, very young, I think we're okay. Even if they have a mid-substance capsular tear, we can just they're kind of robust, so we can repair side to side and do the banker. The only thing that I kind of predict that this patient might have this kind of bad tissue was older age and female. It was around 40, 50 who decided to have a banker repair at that age, and I'm not sure if I want to really.
In my hand is a young female with general laxity.
Okay, so that's a general laxity.
Yeah, we have to also keep in mind the underlying normal anatomy of the shoulder is the anterior inferior capsule, 1.8, 2.5, 2.6 millimeter thick. Posterior, 0.6 to 1.2. We're already starting with something very different. And if they've injured that shoulder posteriorly with stretch, I imagine collagen, much easier to maybe even have different mid-substance tears posteriorly than anteriorly just because of underlying collagen, which did not show much mid-substance.
Can I ask a question? Yeah. I just want to ask Rachel and Matt, just like a technical question.
1 minute.
Okay, just one minute, 2 questions. Technical questions. I started doing just a tibia allograft, and the second case just absorbed completely within 6 months. So that's my first question. And the second question is, I tried that suture tape thing. The guide seems to be always below. It's supposed to be like 7 or 6 millimeters, but it turns out to be like 10 millimeters, and your graft is always below the glenoid. So do you have any tips or any comments or something?
Yeah, very briefly, I've gone through those same challenges, and the resorption is always a killer when you see that. I think in the US we're using mostly fresh distal tibia, and that's not necessarily been shown to have less resorption than the fresh frozen. But I think that remains a problem with allograft, potentially fixation.
Yeah, Ivan Wong did comparison of fresh versus frozen. We compared. He had a higher resorption rate in frozen, of course. So our fresh resorption rate very, very low. And you have to keep in mind we're comparing to Coracoid and Latarjet, where Giovanni has shown us 59.5% of the bone resorbs. Good outcomes still, but it's remodeling. We're getting good interface healing. So we have to be very careful how we define resorption. I mean, if you're getting 100% resorption, it's a different issue. Frozen graft, some mismatch or something going on. In general, we've found minimal rates of resorption, if you will, but very good interface healing for both grafts, both coracoid plus tibia.
Thank you very much. Actually, it's time, unfortunately, but we can discuss later because we have more in some session. Yeah, thank you very much.
Thank you very much, Dr. Frank, Dr. Miyata, and all the speakers of this session. Now we are preparing for the next symposium. We appreciate your patience. We will now begin Symposium 1, Shoulder Instability 1. This session will be moderated by Dr. Yonjil Lee and Dr. Eiji Itoi. Dr. Lee and Dr. Itoi, please begin the session.
Good morning. Welcome to this symposium, One Shoulder Instability. I'm Jsoa, co-moderating this session with young Lee sitting next to me. So we have 6 speakers in this session, and after all the presentations are done, then we start our discussion. So the first speaker is Matt Provencher from the Stedman Clinic, Vail, Colorado. Welcome to Japan.
Richie, thank you very much. A pleasure to be here. So we know the Latarjet is very good. We have very nice overall outcomes in terms of getting a good, honest appraisal of where the Latarjet is. But we have really good problems with Latarjet and any bone graft that may not be placed exactly flush. So why did we come up with distal tibia? Well, I wanted to get glenoid. I wanted to reconstruct glenoid with glenoid. It was very hard to get a glenoid in the United States because of donor concerns, higher infection risk. And then so I asked them what they didn't use, and this was almost 20 years ago now. And they say we make talus bones for our foot and ankle surgeons, but we throw away all the distal tibias. I say, send those to me. We then started looking in magazines and journals such as Nature, and it's really interesting in terms of how the animal kingdom is formed across a very standard radius of curvature. So we found a way to do this. This is one of the earliest cases. You can see a very big graft, probably too big, but you can see the nice fixation you can get, the subscap split. We've then come up with different ways to do it, including a graft workstation. And the beautiful thing is, we got some really good outcomes. We had a good way to manage now the failed Latarjet. Outcomes of revision surgery with the fresh distal tibia. There's not a lot out there. There were small case series. This was about 35 patients. Very challenging case. And we were just asked about lysis. We looked at all of these with CT scan, and what we did was 95% union. But we did get some graft resorption around the edges to help remodel the glenoid. But what we did get was good union, or good what we call interface healing. Well, what about the Hill Sachs? What if this is very large? Well, we said if the distal tibia fits the glenoid, why can't we take the talus from our foot and ankle surgeons and use it for the humerus? And we found that I did a lot of work on this research-wise, mechanics, sizing, cartilage mapping, bone mapping, and you can see that we get very good outcomes with a go-to humeral head graft with a fresh talus. We then started looking at plugs, where we can put a variety of plugs, or what we call the classic lemon wedge or lime wedge, which you put in your margarita or your drink, and this is very important. And I want to thank Fob, you're here from Thailand, appreciate all your great work in our lab, but this is an incredible graft and opportunity for us. Here we can see several plugs in small and medium Hill Sachs, and what we need to do is probably reconstruct just enough of the humeral head lesion, not all of it, because we just have to prevent engagement. We have to lengthen the arc and take this to an on-track lesion, and we found that 3 plugs or 2 plugs, either 8, 10, or even up maybe 12 millimeters, was just enough. It doesn't have to be a perfect fit, because the cylinders will keep the humerus from engaging. The space between the plugs is not important, because the cylinders at the edge will work very well. So with that, we've had a really interesting journey with our distal tibia and talus allograft. Thank you.
Okay, our next speaker is Dr. Tasaki from Nippon Medical School. Dr.
Thank you, Chairman. I'd like to express my gratitude to Dr. Itoi, Dr. Lee, Chairman, and Dr. Sugaya, President, to have an opportunity to speak in this international session. I'd like to talk about the open bristle procedure, combined arthroscopic pancreas repair for collision athletes. Main contributor to the shoulder instability is chest-labral complex lesion, such as ankle lesion. This lesion impairs joint proprioception and may result in osteoarthritis. Another main contributor with bone structure damage, such as the bony buccal region and Hisax region. It is common in Caucasian athlete, and when it resolved, creates a bone defect that contributes to recurrence, then negatively affects the shoulder kinematics. Arthroscopic anatomic repair is essential for restoring critical biomechanical concepts, such as the circle stability concept, vacuum effect, and slack band tension with torque. However, recurrence is not uncommon. The reason of limitation of the buccal repair, portability of IGHL remain unaddressed. Also, native three-dimensional fiber continuity cannot be reproduced, such as the articular fiber system and IGHL continuity with the longer biceps. Proper transfer provides an extra articular augmentation with a swing effect beyond conjoint tendon. It can be considered dynamic bone tendon transfer rather than bone block. Why Bristol not latalgia? We try to reserve coracoacromial ligament as much as possible. CAL provides upward stability and mechanoreceptor. These are very important functions for stability. CAL insert 10 to 20 millimeters from the coracoid tip. Therefore, partial CAL preservation is possible with Bristol. In this procedure, ideal and safe location of transverse coracoid is 4 o'clock position in height. It shouldn't protrude beyond the surface. We believe medial placement can still provide thin effect. Therefore, safe placement is priority. Then place the suture anchors to complete buccal and Bristol procedure. In Caucasian athletes, most patients are large and huge. Standard incision made 4 cm from the tip of coracoid. For huge patients, incision is larger, but try not be without compromising screw angle. To assess to the anterior surface, after coracoid osteotomy, split bluntly along the subscapularis muscle fiber, then expose the anterior surface where coracoid is placed. Coracoid placement is after arthroscopic IGHL mobilization. During arthroscopic mobilization, proper mobilization of the capsular complex is necessary for IGHL retentioning and expose anterior surface where the red color arrow indicated. After peeling off the IGH complex, bone surface shows. Then return to the open procedure using a flexible spatula, 15 mm width, insert into the joint space for proper visualization. Then prepare for proper fixation bone union with the direct visualization using a flat leaner. Following an open fixation using a screw, final fixation is under arthroscopic visualization. We can confirm secure fitting. If placement is not proper, we can redo the same procedure. Then complete buccal repair using the best possible technique, because buccal repair is the most critical procedure. We prefer to use a tough procedure for bony buccal lesion repair. It is noted that inadequate bony repair, buccal repair lead to failure buccal Bristol latalgia procedure. We always repair bony buccal lesion. This is before surgery, and 1 day after surgery, then around a year later. This procedure promotes robust remodeling. Do not remove bone lesion, even if we do a proper transfer, which means do not piss off Dr. Sugaya. He's a bony buccal repair of God. One case I show you a professional boxer, 28 years old. CT scan shows bony buccal lesion. After a procedure, 1 day after surgery, CT scan shows the bony lesion placed above the coracoid, transverse coracoid. Then 5 months later, bone unite together to have a good remodeling. Another case, a rugby player, 90 years old, who has also bony buccal lesion. After a procedure, 1 day after surgery, bony fragment reduced above the transverse coracoid. Then 5 months later, bone unite together. We evaluate the concept 301 collision athlete, minimum 2 years follow-up, up to 2023, divided into 2 groups, 16 cases of non-union and 285 cases of union. Non-union rate was 5.3%. About complication, there is no nerve injury. Then among non-union cases, 2 cases experienced recurrence. The other hand, 1 case among the union cases experienced recurrence. He is a judo player and falling down from the stick arm on the ground. This action creates upward thrust, which results in subluxation. Overall recurrence rate was around 1%, and non-union related to poor outcome. We evaluated the factor related to non-union in various analysis. Shows ratio of aspect contact and height balance, coracoid to grade diameter ratio, a candidate for factor related to non-union. Then, a multivariate analysis shows integrated factor coracoid height and coracoid height to grade diameter ratio. Cutoff value of the coracoid height was around 12 millimeter, and the cutoff value of the ratio is 45.9%. In conclusion, the success of buccal procedure, complete arthroscopic buccal repair with other possible best technique. Always repair bony buccal lesion, never remove bone fragment. Perform this procedure extra-articularly, and finalize fixation under arthroscopic visualization. Thank you very much.
Thank you. The next speaker is Dr. Guoqing Cui from the Peking University, Beijing, China. Professor Cui.
So, thank you for this procedure. So, my topic is inlay bracewell system procedure, it's a technical outcome. And the common surgical procedure requires anterior dislocations, the buccal is related to minor trauma but a higher recovery rate. And the latitude, the recovery is low and higher healing rate but related to large trauma and high complication rate. And bracewell is the recovery rate is low and lower healing rate. How to increase the healing rate and low recovery rate? This is the most important problems. And I just put certain what is connection to the bracewell procedure. I call this Chinese unique delay bracewell. And this structure has 3 advantages of the more stable, the only to inlay, and more bone contact. It's a phase 2 3D contact. And also a completely refreshed for structural matching, so could improve graft healings. And this is animations of the procedures. We have bi-direction guiders, and this is the driller for the hole, and then retrieve the coracoid with the fine, and then we can, this thread, we have a hole, we can pull the suture, pass through the hole, and then push to the hole. So this is what we do, and then the capsule suture is like this. And And we develop a serious instrument for system. And bi-direction guiders make it accurate and safe. As is the tendon multi connection structure is real and fine, make it precise matchings. And the screw and button makes it more convenient. And this is the procedure with screw. You can see we just open the interval and then remove all the soft tissues around the cartilage. And then, so at the base, we remove some cortex. And this is remove the back minors and just close to the cricoid. At the base, remove some cortex. And the big hole is 2 millimeters wide. And this is for just for putting out the cricoid. And then cutting at 17 millimeters. And then prepare the glenoid as same as before. And then I pass subcap, just muscles, and leave the capsule outside, and then with a small hole, and then we pass the PDS sutures and pull out the upper part, and then it's the guider, and we can choose a position about 4 o'clock, and then drill a hole around that, and then we pull out the coracoid and repair, and with a fine about 9 millimeters in depth and 10 millimeters in diameters, and this is the screw, and then we can just pull the screw and get into the hole and drive too tight. And then so we pass the sutures to the glenoid, and so with a bunker repair, make the graft out of the capsules. And this is also we can use buttons, and this is a special design button. We call it double direction and double fixation buttons. And this is we can see we also the same hold the button and then to the hole of the glenoid and fix from the anterior to sutures. And then we also pass the suture to the capsule and make the push lock, also make a bunker repair. And this is a biomechanical experience of higher biomechanical stability with the inlay brace stones. And also the final element analysis shows the more balanced stress distributions. And also the animal model shows inlay structure that speed up healings. And the clinical study is a system with screw fixations, and the graft healing rate was up to 96% at 3 years follow-up. This is part of the GGS. And this also is a suture button fixation, and the healing rate almost the same. And the button or screw, we also have compressions. There is no significant difference in clinical score and level of intensive sports, but only the less cortical graft resorption and no hardware-related complications with buttons. And we also divided a 5-level return to sports criteria. And level 1 stop sports, level 2 is changes stop, changes the type, and level 3 is pre-sports but low level, and level 4 is pre-level, and level 5 forget the shoulders. And our 150 athlete follow-up is 2 years, and a 5-level new classifications for return to sports, all return to sports with 94% pre-sports and 86% return to pre-level, and about 40 can complete forget the shoulders. And also the clinical shoulder complications among these 300 cases, and compared with the larger surgery, system did not increase the incidence of complications, especially neurological complications, only 2.3 last for more than 3 months, and most are muscular cutaneous nerve injury, and followed by axillary injuries. And also there is whole studies, Twistone versus Bristol. We can see that Twistone have early healing times at 3 months or 80%, and Twistone return to sports early after surgeries, and also lower proportion of severe bone absorptions and more bone remodelings. And also there is a Twistone with Lattijet. We could see the Lattijet had a higher rate of moderate and severe OA versus Twistone only 2.5. So this is open or arthroscopic, also said only open, the time is less. And also the Twistone procedure has equivalent clinical outcome but higher bone union rate at 3 months. And then the Bristol growth and the early structure elevated bone union, so early and higher rates of sports. The early structure cause less bone absorption and better mobility and achieve similar graft healing rate to Lattijet, but lower, less OA risk and higher return to sports. Thank you.
Thank you. Our next speaker is Ashish Babulkar from Dinana Mangeshkar Hospital, Pune, India.
Good morning. Thank you, Hiro, for this invitation. Professor Jsoa, Professor, with your permission. I'm from Pune in India, western side of India. And this is our 10-year relentless journey on our experience with the arthrolethargic. And of course, there's a learning curve involved. But this research was about our accuracy and positioning of the graft, and to share with you our learning and insights on how to improvise and fine-tune this procedure, apart from understand the healing and the complication rate. I think there's fair consensus among the surgeons practicing arthrolethargy that there's about 50 cases learning curve and that you can write that out. And it takes time and patience, no doubt about that. So on our protocol, I don't tend to do Lattijet for any bone loss less than 15%. Maybe a revision surgery or a failed Bankart might be an exception, but that's a rare episode. And then we did single surgeon series CT scans between 3 to 6 months, and then follow-ups between 1 to 3 years. And this is what I'll share with you of 400 cases in the last 10 years. So largely about the graft positioning, the healing, the screw positioning, and what have you learned. So about 12% of our placements have been in the middle sector, and the reason for that is we're trying to improvise our alpha angle, and I have shifted my medial portal slightly higher, and that ends up into this issue. It's not such a big problem, but fortunately we had 0 grafts in the superior sector. Most of them have been in the middle, and then lower sector, although 88% have been in the lower sector. On the CT axial graft positioning, I think we've been very good at 92% flush, and a little bit here and there, which is acceptable, I think, largely in these patients. Our biggest bugbear has been the alpha angle, and trying to get this screw aligned to about 10 to 15 degrees. Alex Larkman recommends 10 degrees of alpha angle, but that's been a challenge because of the probably positioning of the medial portal and the way the technique is designed. So almost 61% are between the 15 and 25 degree angle, which is not bad, provided your screw is not too long and not going high into the suprascapular notch. But this is something that we have tend to work on, and I will share with you and dwell on this at the end of the talk. So it's always desirable to have them between 10 and 15 degrees, but so sometimes you have this 33 degree angle. If your screw is not too long and proud, so we've cut down on the size of the screw, the length of the screw to maintain these. On screw symmetry as well, we've been reasonably good with 92% of them parallel, and then some of them have been skewed, some of them have been out, and we've improved on that between the first 50 and the next 350, and I'll share with that. So, a significant number of them have healed, except for about 8 patients, so which is about 2% of the population, and then the ones that went into non-union, 2 of them had to have revision surgery on these patients. So this is desirable to have them in the lower sector and have them parallel. Rarely you've had this misadventure. So comparing the first 50 and the next 350 patients, we found that the angle seem to have improved significantly in our second series on the patients. On the screw direction, we are far better. We're getting more and more better. Our time of surgery is coming down. Our accuracy of the screw fixation getting better. And thereby, we are getting more of them in the lower sector as well. This is a patient who's the doctor himself on antidepressant medicines, probably had a fall in the bathroom and had a seizure at 9 days, and then seemed to do well. The x-rays look good, so we proceeded. He's done well. At 3 months, as was mandatory, we did a CT scan, and screws are perfectly positioned, very impressive there, but the graft is lying anterior, and that's an issue with the seizure in the early post-op period, and that's why the x-rays don't give you enough of the story. You must have a CT scan to really this. 20 patients, so less than 5% of our patients required a screw removal. Some of them for pain and unexplained pain, some of them for infraspine weakness, and we think a weak infraspine is a red flag, and I should warn you that if your screw is high, medial, and long, then you need to work on that and remove them. And probably the 6 to 9 month mark is the right time, because you ought to confirm that the graft has healed well. And 8 of them for osteolysis, just the proximal screw in our patients. This is the direction, because that tends to be, especially in the initial days, you end up putting in the screw much more higher than needed. So I don't think screw removal and osteolysis are complications, but even then we've included them, and still less than 3% complications in our series here. But this is the worry that I want to dwell on, that the redislocation in the seizure patients. So if the patients have a seizure in the early post-op period, they can avulse the graft out. And that's why I'm making a test case here, that if you have a patient who's probably not as compliant, you might want to do an iliac crest bone graft on these patients, because the joint that's intact there is likely to avulse that because of the high muscular violence in these patients. So the French series has also been impressive. It's a large series from the SFA group, almost 1,555 patients, equal, similarly very low rate of complication in these published case series of 2017. This is the Yukon paper, which was a review article comparing Latrages across open and arthroscopic, very similar complication rate of 6 to 7%, largely graft related, and no significant difference between the complication rates between open and lateral. So some of our improvements here, the screw tends to go high because of the medial portal and go towards the suprascapular nerve. So desirable position is we want the screws much more flatter, parallel, for which I think the interesting thing that we did was 3 things. Number one, we place the shoulder and pull it back just when you are going to pass in the screw, push the table down from 60 degrees to 30 degrees, and move that medial portal a little bit higher, which sometimes in 12% patients of series keeps the graft a little high. And the screw length, we stopped using the longer screws, we use screws no more than 30, 32, and that's helped prevent our screw removal rate. So in conclusion, largely hardware issues which can come off, and I think if you work on this and follow these principles, you should reduce your resurgery rate, which has been the largest bugbear of the arthrolephagy series. I think it's a low morbidity surgery, redistribution rates are very low, learning curve probably at 50 patients or thereabouts. Thank you very much for your patient listening.
Thank you. The next speaker is Dr. Chunyan Zhang from Beijing Jishuikan Hospital, Beijing, China.
Thank you, Professor Choi, and good morning. I'm going to talk about the mid to long-term follow-up of my arthroscopic Latraget for the past 15 years. So this is basically the timeline of my history with Latraget. Basically, I learned open Latraget from Jsoa, and in 2007, I learned from Laurent Foss for the arthroscopic approach of Latraget. And then we made a few modifications, but I'll mention a few minutes later. And we published our results, like minimum 2 years follow-up result in 2017, and a comparative study. And now I'm talking about in 2025, report some of the mid to long-term outcome of the arthroscopic Latraget. So basically, our arthroscopic technique is pretty similar with Laurent Foss, with the screw fixation. And our modification is that, number one, we develop the interval of the subsplit, not in the tendinous part, but on the muscle tendinous part, to reduce the damage of the tendinous part of the subscap on the lesser tuberosity. And second, we try to everything to reconstruct the anterior capsule. We do a banker repair after the atherosclerotic J. And that means that with the capsule leaving in place, it will be hard or difficult to develop the interval between the subscaps when we pass our orbital graft through the split of the subscapularis. So this is the patient enrollment. And basically, we enrolled patients from March 2015 and 2017. The minimum follow-up time is 5 years, the average is 7 years. And this is the clinical assessment before and after surgery. We use ASES, constant Murray role, and same for the patient-reported outcome. And for radiographic assessment is pretty thorough. Every patient will have 3 complete sets of CT scan that's pre-op and post-op immediately, and the final follow-up. And we use Samson Pietro classification to evaluate the OA because this is one of the major reasons and major purpose of our study for mid to long term after lateral J. We want to see what happens with whether we have de-risked OA after mid to long terms. And this is the radiographic assessment before the surgery. We use the diameter of the length and the ratio to evaluate the pre-op granite bone loss. And this is Gutalier classification. On the final follow-up, we use this to evaluate the Gutalier fatty filtration of the subscapularis. And this is the graft position. We define that the middle of the coracoid graft points should be between 3 o'clock and 5 o'clock. If it's too high over the equator, it will be considered too high. And the lower part of the tip of the coracoid is lower than the inferior rim of the gland will be too low. So this is we judge the position of our graft from superior to inferior direction. And on the axial view, we measured on a CT scan. This is the medial-lateral position we evaluated. So less than 5 medial or over 3 millimeters lateral will be considered 2 medial or 2 lateral. So in between them will be a proper position for medial-lateral direction. And we measure the rotation of our screws and graft unity on the CT scan. And also we use our published very simple classification system on resorption of the coracoid graft to divide it into 4, 0 to 3. 0, 1 means very mild, and grade 2 and 3 means severe and prominent resorption. So here is the demographic. We finally have 44 patients identified with an average follow-up of 7 years, and most of them females. So this is the clinical outcome. It's pretty good that we have no redislocation. Only 2 patients have a residual apprehension. The sports return rate is pretty good, like 6 to 1 to the same level. And secondary surgery only happened in 1 patient. We do a screw removal due to the prominence and incompetence. And this is the radiographic outcomes. And mostly we have 95% flush, medial lateral, and 2 of them a little bit lateral. And high graft union rate. But from the superior-inferior direction of the graft, we found that we have 18% of the graft is a little bit too high. What about OAs? So this is interesting. And we have found a high prevalence of progression of OA. But the risk of developing moderate to severe OA over like average 7 years is pretty low. So we have no OA, like Samuelson Pietro classification, 0 on pre-op, but we got 9 on the final follow-up. But we only have 2 with over grade 2 at the final follow-up. And this is the evaluation on the CT scan for the Gutalier fat infiltration classification. We found that it is very common and very high prevalence of fat infiltration of subscapularis at long follow-up after subscapularis, like 77%. And these are grade 1 and 2. We don't have a grade 3, but we think that grade 1 and 2 is kind of like a marked fat infiltration of the subscapularis. But all these patients present negative lift-off or belly press. And graft resorption, as Matt said, is pretty high. That it happened 84% using our simple classification system, and major resorption happened in 72% if you use our classification system. But none of them are like symptomatic. I mean, most of them are not symptomatic. We do a correlation analysis according to the age, and we found older age, female gender are correlated with poor constant score, fat infiltration, and osteoarthritis. And fat infiltration of the subscapularis was possibly correlated with OA, our results. And a high grade of OA did have impact on shoulder functions and lower constant scores, but mild OA doesn't have any influence on that. And we do a logistic regression to analyze the risk factor of the OA after arthroscapularis, and fat infiltration of the subscapularis was identified as the only risk factor and mid to long-term follow-up with OA occurrence. So the main finding of this case series is that generally we have satisfactory clinical and radiological outcomes after arthroscopic larynge, and low risk of developing to moderate to severe OA. I mean, OA progression is common, but to moderate to severe OA is pretty low. And we got to be a little bit focused on the high prevalence of fat infiltration of the subscapularis because it's considered to be the only risk factor of OA. So compare with the literatures that are for long-term follow-up. This is systematic review by Huntley. We have a relatively lower percentage of OA progression and also lower percentage of moderate severe progression. Maybe our follow-up is not long enough, it's only 5 to 10 years. Maybe after 10 years we got even more OA occurrence at our long-term follow-up. For fat infiltrations of the subscapularis, we are not the first author to notice that. We have quite a few reports on that, but like Korash reported that only 11% of them have only very mild fat infiltration of subscaps during the follow-up. But there are early follow-up, those only 2 years follow-up. And we had found 77% of fat infiltrations of the subscap. And we have like 5 to 10 years, average 7 years. So maybe this is the reason, as long as with the extension of our follow-up time, we might find something different with the early that we didn't find. And I think the function, although we don't have a clinical, symptomatic expression of the subscapular incompetency, but the fat infiltration did sometimes really influence it. The only 2 severe OAs I have, they all have very severe subscapular fat infiltrations. And one of my patients even was developed a little bit anterior subluxation, and that might be causable with the incompetence of subscaps after surgery. So in conclusion, and with our mid to long-term follow-up, I think arthroscopic is satisfactory and safe procedure, both clinically and radiologically. And although the low risk of severe OA was identified, but the OA progression did happen, and is not uncommon during the mid to long-term follow-up. And we got to, be careful and put more attention on the fat infiltrations of the subscaps after arthroscopic larynge with the long term. Thank you.
Thank you, Chunyang. Our last speaker is Pascal Poirot from ICR Nice, France.
Thank you very much. My topic today is to talk about suture button fixation for Latarjet, arthroscopic Latarjet. We all know the Latarjet procedure, which has a static bony effect and a dynamic tendinous effect, which is the beauty of this procedure. You solve the 2 problems, the bone loss and the capsular insufficiency. And we know from Michel Latarjet that 1 screw is enough, as you can see, and that there is no arthritis to the condition that you put the bone block flush or slightly medial. Gilles Walsh has emphasized the need of 2 screws for fixation of the bone block. But the first thing I would like to share with you is why you should stop using screws in the shoulder. The reason is that even in the best hands, in Gilles Walsh's hands actually, you have about 20% of incorrect bone block positioning when you come from the front and you try to do this operation. And we know that all the complications are related to the screw, with shoulder pain, osteoarthritis, as we have already seen, and impingement with the humeral head. Also, there are some mechanical complications like fracture, non-union, malunion. and finally some halberd failures with screw pull-out, screw bending, etc. Finally, it's very dangerous, especially under arthroscopy, to come from the front and to drill from medial to posterior, to anteromedial to posterior because of the nerves. And it's not acceptable, I think, to have an axillary or musculocutaneous nerve palsy after an operation in a young patient. In addition, with the screws, you can catch the nerve posteriorly and also have some problems. And you see more and more publications showing you how you should remove the screw under arthroscopy, because as we said, it's a cause of complication and of pain. So why you should start using suture button for Latarjet procedure or for bone block procedure? And this started actually with a complication of mine. I was doing one day a Latarjet procedure and I had a fracture of the coracoid. I didn't know how to fix it because the piece of bone was too small to be fixed with a screw, and that's where I get the idea to try the suture button fixation. And of course I was worried. I follow my patients with CT scan, and at 6 months the bone block, although it was very small, was healed to the neck of the glenoid. So I started my experience after this patient. And in fact, I didn't know how to do it initially, but in fact what I wanted to do is to make a bolt, to create a bolt. Because as we know, a bolt is something that allows you to clamp two parts of a process and to fix it completely. And if you look carefully in mechanical studies, and even the first-year engineer know that, when you use a screw to fix something, this is the pressure cone that you get. When you use a bolt, this is the pressure cone that you get. So it's not the same. I mean, the compression and the fixation that you can get from a bolt is much superior to what you can get from a screw. Only orthopedic surgeons still believe that the screw is the best means of fixation. So what we want to do is to create a bolt. And how can we do that with this flexible system? In fact, it's not so difficult. You have to transform your flexible fixation into a rigid fixation. How can you do that? I mean, you go in the lab and you look at the results of button versus screws, and now many mechanical or biomechanical studies are showing that it's equivalent or even better than screws. Although you may say, okay, it doesn't work because this is suture. Sutures are fragile, suture break, suture can elongate. That's not true. If you know sailing boats, you know that everything which is in metal today is replaced with textile. This is 1 century ago, a sailing boat, and this is a sailing boat today. Everything which is in metal, including the cables, everything has been replaced by textile. The resistance of sutures today is as strong as metal. And we know that with two cortical buttons, one in the front, one in the back, you are equivalent or superior to 2 screws. So the question now is, does the clinical experience match what we found? So we start to develop the arthroscopic technique in 2010 and we publish it. Especially we emphasize the fact that we were drilling from posterior to anterior to avoid all the complications related to anterior drilling and tightening of the screws, and to be parallel, strictly parallel to the glenoid surface. We also look carefully at our results, and we were pleased to see that even with more tenuous follow-up, the rate of healing is really high, and the recurrence rate is very low, and return to sport, including collision and contact athlete, is very high. So this is what you get. At 2 weeks you have this positioning, and at 6 months you have this bone block healing and remodeling. So you can see that there is no need to put 4 buttons. Also, what you get from the suture button fixation is that it accepts some bone graft remodeling. You see this case, I was not very good, I put it too lateral. But by following my patient, I see that there is some adaptation and some remodeling of the bone block, and now the bone block is flush. I've never observed this with a screw. Instead, I have observed impingement with the humeral head. The same occurred here. This is the case of a rugby player, and he was tackled after 3 months after surgery. So he had some pain in the shoulder, kind of subluxation. He came back, we did a CT scan, and we showed that there was a gap between the bone block and the glenoid neck at 3 months. I say, okay, you have no pain, go back to sports, go back to rugby, there is no problem. I said, we're going to do a CT scan at 6 months. This is what we did. And you see that there is feeling of bone between the bone rock and the glenoid neck at 6 months. Also, I never observed this with a screw. If you have a non-union with a screw, you keep the non-union, then you have mobilization of the screws, then you have pain, and you have to reoperate the patient. So we didn't know how to do this operation at first, and at first I was tightening by hands. Then I was not happy because at 6 months I have only 65% of bone rock healing. So that's where I get the idea of using a tensioner. And at first I didn't know if I should use from the front or from the back. But in fact, if you use it from the back, you're perfectly aligned with your tensioning force. And what we found is that if you do mechanical tensioning, use our suture tensioner, you have a high rate of bone rock healing compared to manual tensioning. And actually our tensioning protocol is three times 100 Newton. The first time is to remove the crimping of the suture, the pretension. The second time is to get the knot tying, the tension. And the third time is to get the bone compression, which is the overtension. Another question we were asked all the time is, why don't you use 4 buttons? I said, because I don't need. But then I did a study to show if it was better. And in fact, what I found is that 2 buttons was enough. 4 buttons doesn't bring anything in terms of positioning or healing of the bone rock. What it does is that it lengthens the procedure by 20 minutes. Now, the long term have been published, and it's really very nice to see that these patients stay stable over time, and there is no or very little arthritis when you do this operation, open or under arthroscopy. So in summary, I think that using a guided surgical approach with drilling from posterior instead of anterior makes the procedure safe and accurate. And the use of suture button is really a safe alternative to screw fixation without the complications seen with the screw. You see this patient has been operated in the best hands in Lyon with a screw fixation, and like always we observed a superior resorption of the bone. And she asked me to reoperate to remove the screws, which is a pity in a young lady like this, so we had to do it. On the other side, we did the same operation under arthroscopy using suture button. And of course, we avoid this complication that everybody knows, which is the rubbing of the upper screw inside the subscapularis tendon. So next time you come to France, go to Paris, look at the Eiffel Tower, and tell me if you see one screw, one single screw in these monuments. There is no screw, only balls. Thank you for your attention.
Thank you very much. Very convincing lecture.
Yeah, thank you all of you. This is a very interesting session, the bony surgery for the anterior shoulder stabilization. So is there any question or comment? Please.
So all the speakers, please come up to the stage for discussion.
So, Lisa, or media.
Cause for the fatty infiltration. What do you think is the cause for fatty infiltration? Is it surgical insult? Is it some sort of nerve devascularization? Is it that prominent screw that's causing you subscap issues? Why are you seeing that? And what are the consequences of that in the short term?
Well, the general answer is I don't know, but I think it's a bit of everything you have just mentioned. I think the major reason is the surgical development, is the iatrogenic. Because when you develop the interval between the subscapularis, and we all know with this publication, I think by Pascal said the most important, the most difficult part, reflected by the shoulder surgeon, sports surgeon, is the development interval of the subscapularis passing the graft through it. So you need a lot of work to do the split and do it. So sometimes we use a blader or here this kind of a radio frequency things, and sometimes we have to use shaver to do that. And I think that is the #1 reason for the fatty infiltration, #1. development is caused by the surgeon, and that may be combined with some kind of a minor nerve injury within the muscle. That's number one. Number two, I think, is the scrubbing. Not only by the screws, also by the high riding graft. So maybe it's a combination of both. But at ours, average 7 years, I think the fat infiltration rate is like 77% this time. I never expect that kind of
Of course, that has long-term consequences, but what about the short-term consequences? Do you find that your athletes are weaker in their subscap? You're causing some sort of functional...
No.
Nothing at all?
Can I ask Julian? Thank you. Julian, that one case that had arthritis, when you showed on the axial side, that had a lot of subscap infiltration, that patient's graft was also medially sided. So if the head is not supported and shifts the center of rotation anteriorly, then that itself is going to cause arthritis.
Yeah. Exactly. So I cannot explain that. I have 3 in my case in the past 25 years. It's very rare, but it's really stressing. That is a immediate post-op subluxation. It's not by developing. I get 2 is immediate post-op subluxation. I check all the EMGs and I check the MRIs. Right after, like Jsoa said, right after that, you don't find very severe fat infiltration. Because mechanical disruption during the surgery is not fat infiltration. Fat infiltration is a chronic development after some time. So, I don't know. I mean, absolutely, the anterior subluxation will be the major reason for osteoarthritis and the final follow-up. But that subtle anterior subluxation might cause by some kind of innervation or dysfunction of subscap.
Julian, I think I applaud you for your study on the fatty infiltrate and honesty on that. I think it's very important, but it's also consistent with what we know from open Latarjet. Ray Sachs, Marcus Scheibel, others that have shown 30, 40+% with an open subscap split, not even taking it down. In addition, if you take down the top half, that number is even worse. Now, get the graft in the right place is probably more important for visualization to be able to do everything, but the subscap is, we still have not solved that. I agree with Pascal, we were talking last night about the screws, and that can be a factor, but I think just insulting it in the front, even with a knife, is a problem.
Can I ask you something? I think you use the technique described by Laurent Lafosse, which means encapsulectomy with a shaver. Don't you think that can be one of the reasons of the immediate anterior subluxation that you observe in some cases, and the reason for the arthritis as well?
No, actually, our modification is exactly to protect the anterior capsule because we want to do the labroplasty after the corporal fixation. So that means I have to carefully develop the interval intra-articularly with the anterior capsule with the subscapularis behind it. So we develop in the muscle tendinous junction, but we leave the capsule intact, and that causes something because you need to release all the capsules away and flip away to expose the whole muscle fibers intra-articularly to see the split. So we preserve it, which Long didn't give a shit about.
Sorry, I want to ask of the main effect that Matthew Provenza introduced in distal tibial the graft, and Sasaki introduced the wrist operations. What is the main effect? Bone surgery, bone effect, or sling effect?
Bone, meaning bone reconstruction versus the sling effect? Or,
Yeah, so
or free block versus no free block? Yeah. So Professor Yamamoto and others have shown us very well that the sling contributes. It's has some level of importance for stabilization. Clinically, I think it matters, although I don't know. I do think free bone block is a very good procedure. I think especially with migrating more to buttons and sutures, I think is a very good way. It's an easy procedure to do and reconstructs. So the sling effect matters biomechanically, we know that, but I don't know clinically where we're at. I do think on some patients, and I'll show you next talk, that the conjoint tendon can be detrimental on some level. My theory is the eccentric pull in very high contact sports, NFL players And pulling the tendon and bone off is a very bad load on the bone we're trying to get to heal. It's completely opposite. And we get high loads in those players, and I think unique failures with conjoint tendon pull.
Okay, I want to ask you the resorption. Pascal show us the resorption, the upper part, when we do the lateral procedure, we worry about the exposure of the screw, but this resorption is a real problem or not? Because this is an obvious phenomenon, like as a remodeling, so what about your idea?
It's not a problem. It happens in all cases. It happened with the Latarjet, it happened with the free bone grafts, it happened with the allograft. It's not a problem unless you put 2 screws and you have 1 screw superior which is floating in the air and rubbing against the tendon of the subcapularis, as we discussed with my friend Matt Provencher yesterday.
I agree. Every bone block resorbs. It doesn't matter. Every single one. And they show you to your stats and numbers, it's consistent with what Giovanni and Giacomo taught us. 59.5% of the coracoid resorbs, remodels, melts away. What we need to be talking about, and Pascal showed it well, is the healing rate, the interface healing rate, and how we remodel the glenoid. I think that's the most important. And that's really what's happening with all of these bone blocks, for the most part, at the end of the day.
Jsoa showed in the subscapularis and patchy generation after lateral procedure, but we investigate the muscle atrophy of the subscap after lateral procedure, and most of the cases decrease by 30% in volume. And we investigate the muscle atrophy with time, 6 months, 1 year, 2 years, and but the muscle atrophy remain no change. So I think the main reason of the muscle atrophy may cause the string effect, probably. And I like to ask, including the Julia, the surgeon, who performed the Bristol and the Latarjet procedure. So did you measure the muscle atrophy of the subscap?
That's a great question. Actually, our team is looking back for the past 15 years what we've done with the arthroscapularis. So this is a kind of for mid to long term. And actually, we have another series coming out soon that was like 70 or 80 cases that we did to measure. In this case here, like 44 patients. We only found the risk factor only with the regression logistic analysis, only finding the fat infiltration have an impact on that. But when we measured the volume, we did not measure the volume, but we did not find in this series. But in a larger series with like 78 or 80 cases, we found exactly the same thing. The volume, especially at the final follow-up. It doesn't, in the early time stages of after surgery with the volume of subscapularis decreasing. But at final follow-up, we did find the same thing. And that is correlated with the function and some OAs in the long term. So I think we need long time. I mean, when we're talking about the atrophy or fat infiltrations, I think both of them will have an impact long-termly on the result, especially for the osteoarthritis.
In your series, most of the patients are the grade 1, the patchy generation, right?
Yes.
It's very mild.
Only 7 years average. Maybe when you have 15 years with the French Society, if you look at it closely, I might, my postulation would be, it could go a little bit higher with the time. So you have anything? You're asking about your Bristol.
So in my case, now we just start the long-term research follow-up, but I think because Bristol, we just separate the subscap, they're small, so not too much, like Latarjet.
Okay, thank you.
Okay, I have a question. If we have the subcritical bone lesion with very loose joint, which is the best? The bony surgery or the capsular implication with the bankart repair or the lamp research?
Can I take this? Yeah. So that's interesting. I think that's a very good question. As I said in my beginning of my talk, I'm very reluctant to do a Latarjet in subcritical bone loss. And in this situation, I would add a DAS procedure where I use the elongated biceps and swing it around the subscap. And I think that works. We've been using it for the last 4 or 5 years. But if you have a contact athlete, I think the bony procedure will still work because most of the contact athletes have a challenge in the mid-range position. And we know that the Latarjet is much more effective in stability in mid-range. But if I have a overhead athlete, badminton and racket sports, or a tennis player, I think the DAS with the bankard, maybe a repticide works far better in my hands.
A Latarjet is not a good procedure in hyperlaxity type of patient. Ehlers Danlos, tissue hyperlax, very, very high, hyperabduction signs. Latarjet is not a good procedure for that. Much better with arthroscopic or open capsular shift.
I think the important is what kind of laxity is. Is a surveillance positive or just lateral rotation that is loose? So what kind of laxity? If the laxity is an inferior laxity, I think this is a different story. But if the anterior recurrent dislocation with laxity of the shoulder, no sulcus positives, I think this is a very good indication for the Bristol, especially the iliac Bristol.
Yes, I agree. That's different definitions and attributes. By definition, a positive sulcus is sulcus that is the same in neutral plus full external rotation. Plus, you couple that with positive Gauge and other inferior findings. That's classic hyperlaxity.
I have a little bit different ideas here. I think that the general laxity would be my very important indication for Latarjet, even with subcritical. But MDI is a contraindication. So, yeah, so hyperlaxity, I think, for me, I'll definitely do a Latarjet. But MDI, no, I never touched that.
Yeah, MDI very bad.
My questions to you, Matt, for the distal tibia osteochondral allografts. Is your capsule label repair on the allograft or on the tibia? On the glenoid?
Good question. The answer is D, all of the above. I do anchors top and bottom of the graft, and then sutures to the suture washers and screws, or integrating sutures into the butt and the cerclage. So
that would mean that the cartilage is extra-articular.
Cartilage is intra-articular. Intra-articular. Generally, how I do it, there are plenty of people out there doing extra-articular distal tibia and putting anchors on the native glenoid face. With that, you have an issue. You have to watch your capsule because you're posteriorizing the glenoid capsule. You're bringing that capsule very posterior. Probably okay. We looked at the CA ligament and how that works with the Latarjet, or putting the graft in the capsule anterior to the Latarjet, or all the way to the glenoid. There are mechanical differences with how you put the capsule back after any type of bone block. With the distal tibia being cartilage, I have taken the approach of keeping that intra-articular. And so anchors top and bottom, and then fixing it to the front of the graft, the capsule.
And your healing rates of the labrum of the capsule to the allograft is as good as in...
I don't know. I need MRI.
Thank you.
I want to ask about the throwing atlas when we do the bony surgery. Is it working or not, especially the pitcher? So could you answer about that? Baseball player, the pitcher.
I think if the patient have the anterior dislocation, even the picture, I think it's really good for the Bristol procedure.
So your patients can do almost same as pre-injury level after the surgery?
Yes, of course.
In our Major League Baseball cohort, a bony procedure in a throwing Major League Baseball in the United States has been very hard to get back. Visconti, do you agree? Bony procedure, not great. We have taken the approach of anatomic arthroscopic repair, maybe an open through subscap split, but bony procedure in Major League Baseball with throwing shoulder has been very challenging to return.
Yeah.
Right?
Yeah, it's also bony procedures with those athletes cause very severe arthritis in a short period of time. So this is where I would do an open procedure or do a procedure around the spine.
So my question is, even we do the arthroscopic pancreas repair, the pitcher can get back their level or not. So I think the majority should give up after the surgery. No?
Well, if you're making $10 million a year, they really don't want to give that up. So, I think that you have to respect the changes that occur on a throwing shoulder is different than the changes that are occurring in a contact athlete. So balancing that becomes very important because if they lose their external rotation, pitchers will lose their velocity to the plate and therefore will not be as effective as they are before. So you have to be able to do a procedure which provides stability but allows some larger amount of external rotation. But quite honestly, the majority of instability pitchers take care of themselves. And what I mean by that is, if their shoulder continues to have instability, they don't want to have a long pitching career.
Thank you. Question?
I have a question to Dr. Prevention. You talk about TLS outgrowth to Hill-Sachs region is really interesting. But what is your indication?
That's a good question for Hill-Sachs grafting of talus. In general, it's been a large Franceschi 3 or large grade 3 type of Hill-Sachs lesion, significantly off track, bad bipolar lesion. In general, when the Hill-Sachs starts getting very medial and into the cartilage, where it has a very deep injured lemon wedge, a very deep wedge shape, then I'm starting to think about grafting the back of the humerus, and that can be done open, arthroscopically assisted, etc. But the talus provides some nice contoured bone to fit back there very nicely. It's putting it together. Very bad off-track lesion, very big bone loss. It's not a lot of cases. I'm going to show some more cases next one and looking at posterior dislocation, seizures, electricity, posterior dislocation. Those are all cartilage. I generally fix those with a talus for reverse Hill-Sachs.
Okay, I'd like to make one comment to finish this symposium about the sling effect. And people, I think there's a little bit of misunderstanding of the sling effect. Yamamoto's study showed that 60% of the stability is provided by the sling. But in his paper, he used the term sling to refer to both the conjoint tendon and the subscapularis. So if you look at the muscle volume, conjoint tendon is only 1/5. So the contribution of the conjoint tendon is between 1% to 12% at the most. So that's why there's no difference between Latarjet with the sling and the iliac crest bone graft without. No difference in clinical outcome. Because the sling refers to both the subscap and the conjoint, but the real sling, that means the conjoint tendon, contribution is very, very small. So I think there's a misunderstanding of this, mechanics. So with this brief comment, I would like to close this symposium. Thank you very much for the attendance and for the speakers. Thank you.
Thank you very much, Dr. Lee, and all the speakers of this session. Now we would like to take a short break. We will proceed with our program at 10 a.m.
Good morning. How are you? Yeah, I'm fine. Good to see you. Great to see you.
Thank you for attending the Japan Sports Orthopedic Association 2025. Next session will begin at 10 a.m. Please refrain from taking photos or recording audio or video during the session. Thank you. Thank you for your patience. We will now begin live surgery 1, shoulder instability. This session will be moderated by Dr. Matthew T. Provencher and Dr. Eiji Itoi. Dr. Provencher and Dr. Itoi, please begin the session.
Good morning. Welcome to this session, live surgery performed by Hiro Sugaya. So we are very excited to be here, but we don't know what kind of surgery he's going to show us today. Hiro, can you hear us?
Yeah.
Okay, I'm going to show us the reverse.
No.
No?
I'm just starting surgery, shoulder instability.
Okay, good.
Okay, can I explain the patient?
Sure.
Yeah, patient is 17 years old lady, a girl actually, high school student. She's a super karate girl, and she dislocated the left shoulder during karate 1.5 years ago, and developed the like the bone loss like this. He has a very sexy bony fragment, so that I love to use this, and also his region is a medium-sized his region. And also the MR arthrography shows this is the overview of the MR arthrography. This shows the human head translation to the front and the back region and the ideal jerusalem. So let me show the pre-recording. I already performed the represented procedures. So this is the view from the posterior photo. This is the bony fragment. And this is a view from the anterior photo. So no higher region, capsule looks good, and here's the bone gap, and the bone loss is really severe. But she has bony bone gap. Okay?
Okay, looking at the CT scan, I think the bony defect of the glenoid is about 15% or approximately 20.
Yeah.
Is this an on-track lesion patient or?
I think that he had, this is off-track, I think.
Off-track.
I don't know, she has bony fragment. So this is the hip sax region. Now we hip sax research. I place the suit at the posterolateral corner of the chromium. And now, introduce the stick.
So Hiro, you're going to do remplissage first, help recenter the humerus. You like doing that first?
Yes, I always do the remplissage first.
The CT scan shows very interesting finding. You said she had 1.5 years of instability. She had a pretty big attritional fragment, meaning the fragment actually was small, but a lot of attrition of the fragment. Yeah. So not much
the
more
fragment
left.
looks a little bit small, but normally the fragment is viable. So now I introduce the two anchors to the hip sax region from the posterolateral.
What type of anchor is that, Hiro?
And now the incision is down.
Hiro.
Yes?
Matt is asking what type of suture anchor you are using in this case.
Limb research?
Yes.
This is the posterolateral. Bioabsorbable anchor with high strength suture.
So here you insert suture anchors to the hip sacs lesion before Bankard repair, right?
Yes.
But you tie the knots after the Bankard repair, right?
Yes, of course.
Okay.
So now I make another photo, little bit. You guys can see this photo, right? Now I clean up the bursa. And this is axillary nerve, right? So this axillary nerve is a very good landmark of the posterior infraspinatus. No, posterior teres minor, posterior side of teres minor. Oh. Now I clean up the bursa. My research is I do place sutures with direct visualization from the bursa. So first I place the suture grasper from the bursa. Now scope is inside the joint. I retrieve one suture. So I repeated the same procedure 3 times in this case. Next, I penetrate the tissue in between infraspinatus and teres minor. And now I retrieve 2 sutures at the same time. The last B, I insert I penetrate the tissue inferior to the teres minor. Then I place all sutures. So after suture placement, like this, it looks like this. Okay? This is a view inside the joint.
That's very nice, very nice view.
This is a view from the bursa side.
I think what you showed very nicely is the ability to know where your sutures are coming through relative to the muscle tendon junction.
Yeah. Okay, then I will go right now. Show us inside. Okay. This is a view from the posterior photo. Now I proceed to the banquet. I'm removing a little bit of cartridge at the edge of the glenoid to make sure the native glenoid edge here. Last.
You used to remove the cartilage about 5 millimeters or so?
No, maybe
just
two,
1 millimeter.
Less than 5.
Okay. Because these days we know that after removing the cartilage, the subchondral bone disappears.
Okay, so this is this is a bone, right?
Yeah,
so
yeah.
I insert at the native glenoid that make sure the native glenoid edge, to expose the native glenoid edge is very important to perform banquet. Okay. Good. She has small but very nice fragment.
There's very good tissue there to work with. Looks very robust.
And this one.
That mallet technique you just used with elevator or elevator rasp is very, very helpful. And very safe for the nerve.
Yes. Second please.
Hiro, do you use a rasp to remove the soft tissue from the bone? Because using electric cautery is a kind of invasive procedure.
Yeah, I will show you now.
Okay, make a burn of the bone and the soft tissue.
Can I have the scissors? So I think the banker repair, soft tissue banker, the inferior regular release is very extremely important. So that's why I use scissors like this. And the last big rasp. Okay, come on.
Showing really nicely how you get down to 6 o'clock position and even lower, Hiro. You know it's important to get that fixed.
What's the water pressure right now?
Right now, the water pressure?
Yes.
Well, normally I do maybe 70, 80.
Oh, that high. And what's the blood pressure of the patient right now?
Right now, 100, a little bit high.
Okay.
I assume you want to see the complete preparations from the glenoid to the capsule so you can see almost subscapularis muscle fibers. You almost showed it there by having a blood flash as you open up the labrum. You have a little bit of a blood flash there, which means you're getting very close to final preparation.
Matt.
Yes.
I can hear you well. Speak louder.
Louder, or maybe you can
Yes, your preparation for the subscapularis, the capsule to view the subscapularis fibers. We say you basically want to tickle the subscapularis muscle fibers with the elevator.
Over.
Matt is asking what kind of music.
What kind of what?
I think I heard the Doobie Brothers, maybe?
Yes, I love you, Doobie.
Yacht Rock Radio, something? Yeah. Hiro, we did a study looking at how much time surgeons that do a lot of instability arthroscopic repair spend preparing versus fixing. The ones that do a lot was about 50% time preparing, 50% time repairing. So I think there's a lot to be said about how you do your case and making sure you have adequate preparation. You're showing that very nicely here in terms of the amount of time and meticulousness you are doing in the preparation.
Here's a muscle.
And there's your subscap muscle that you just took out. Yeah.
It's very important to see muscles. Okay, shred.
Hiro, how many anchors do you have open to fix this?
4 anchors.
4 already open.
Yes. My first anchor goes to the 6 o'clock at face.
Hiro, it doesn't look too bad here, but if there is a crack in the posterior labrum, do you fix that as well?
Yeah, I will check from the anterior forum.
Hiro, have you mobilized the bone fragment or felt it in the tissue yet? Hiro? He's got the music on.
This is a bone fragment.
Ah, there, you heard me. Yeah. Good. So that's very typical. It's captured in the deeper capsule. It's migrated medially and is healed sometimes in that capsule. It's not very good bone, though, especially 1.5 years out from dislocations.
So here, this is an off-track lesion patient. So is there any possibility that you select the letter J instead of adequate repair plus ground massage? What is your indication for letter J?
Letter J, no bone fragment. So I think this is yes, obviously off-track lesion, but she has a bony fragment. So that's why we can rely on the bony fragment. So after bony buckle repair, this is going to be the on track. So this is my release. Look at this. All the way down to, this is left shoulder to the 5 o'clock, right? Beyond the 6 o'clock. So the Matt, you said the posterior crack right here, but I don't touch this.
Yeah.
No need to touch this, I think.
That's a very nice view. You're in the beach chair, it's very nice. It's what we like to see, and you're very mobilized well beyond 6 o'clock, but it doesn't really extend up the back, so you sort of define the end of your tear there of where you're going to fix it.
I'm like good. Now my first angle goes to the 6 o'clock at the face.
Hiro, what size anchors are you putting in? What millimeter?
This one might be 2.3 millimeter with us. Is that correct? Right. Now I will make the anterior superior photo. Anterior superior photo right behind the bicep tendon. 음악 기다리는 진짜 비싸. 눈은 너무 그러고. 아주 지사스럽다.
So you don't use any cannula, right?
No.
Do you have any problem handling the sutures?
No.
Sometimes sutures may catch the soft tissue in between, so.
Yeah, that's the problem. To me, no problem.
For you, no problem.
Because I'm doing the same thing in the past 25 years.
The crab claw is your friend. Associate the sutures. Tell us about this little nifty device. What is this thing?
This one is a Caspari punch, very old one.
Yeah.
This is very helpful when I place sutures to the inferior capsule.
Can this thing punch through bone or pass suture through bone?
No.
No. Soft
That's
tissue.
only for soft tissue.
Yeah. that makes a small hole in the capsule labrum, and you pass the wire to shuttle.
Yeah, very small.
Yeah. Here's how you get away with no cannula, by using good crab claw.
So that's why
association.
I perform relays inside the joint.
Yes. Crab claw is one of my favorite devices.
Those of you who have any questions to him, then stand up and use the microphone. He can directly listen to your question. So if any one of you have questions, let us know.
You know, it's super interesting not using a cannula. There's a phenomenon called, I call it the skin capsule distress, which is made harder with a rigid cannula or even semi-flexible cannula. By not using cannula here, it's very interesting. You get a lot of freedom of movement inside the shoulder joint, and maybe a very nice way to make sure you're getting all the way to the bottom, because that can be a very hard tissue pass through a cannula. So again, skin capsule distress is what I've called it.
Good. That's very again.
You use the same capsule, Kasperi, for all your punches, all your passes?
No. Just for the inferior two.
Just inferior. Okay. Inferior two. Okay.
Inferior two below the bony fragment.
I'm Dr. Bansha from Thailand. Hi, Hilo.
Yes.
You know, I'm asking you about the anchor. Do you prefer the double-loaded anchor for the first
Basically,
one?
I use single loaded.
Yeah.
But for the body back repair, I use the double loaded suture anchor.
Yeah. And how about the knotless?
I don't like knotless.
Why?
Because knotless anchor cannot insert to the 6 o'clock phase, right?
But you have the curved one, the curve.
Even using curve is very difficult. You know, the insert the anchor to 6 o'clock.
Yeah.
I need to press down the humeral head downwards to obtain the good angle to anchor insertion.
Yes.
Normally knotless anchor is make a hole first, then place suture and insert the anchor, right? This is not the one step, so that's why it's impossible to insert the 6 o'clock position.
Yeah, but that's a new anchor knotless that you can make one step.
Really?
Yeah. Have you tried that?
I didn't know that.
Yeah. Thank you, Hilo. Very nice surgery.
Okay, Hiro, when you put the mattress suture, do you use the horizontal mattress or vertical mattress?
I normally use a simple suture for the back bed.
Okay, no mattress.
No mattress. So now I proceed to the bone, no time. For the inferior capsule.
So now cannula for knot tying obviously makes it easier. Do you have the bone block at all, or the bony fragment at all integrated at this point? Have you gone around it, through it, beside it?
Say again, please.
The bony piece, Hiro, have you done anything with the bony piece?
This is the bone piece.
Yeah.
So first I tied suture below the bone piece.
Yeah.
Okay.
And that's what the CT scan showed. The bony piece was highly attritional, but still in the middle of the glenoid. Those first two anchors are below the bony piece, even from your CT scan, which is good. You're getting down very low.
But here, compared to the bony defect of the glenoid, this fragment is very small. Do you think fixing this small bony fragment will make the Hill-Sachs lesion on track? Do you believe so?
Yeah, I believe so. This is, I think, this is a kind of borderline of the using bony fragment or the bone grafting. But I think this is fragment is viable, so the after repair fragment grows based on our research, based on our study. So that's what I do. I chose the bony marker repair in this case.
What about the patient's activity level or sports level?
Very high, very high.
Yes, she's very high, so still you prefer to do the back.
Yeah, but you know, my limb surge is very strong, and also the interval closure is very strong.
So even the rugby players, you perform?
Rugby player, maybe, I don't know, this is a borderline. Maybe I will do bone grafting.
Okay.
But this is a bony marker, very controversial case. But I want to demonstrate the bony marker repair for you guys.
Thank you.
So you tied second anchor first, is that correct? Yeah, reason for that?
Yes, reason, you know, the tying most inferior anchors. Tying most inferior anchors is a little bit difficult. So the second anchor first with the, and reducing the rayground using the grasper. But the inferior one already I reduced the rayground, right? So now I just tie the knot.
These are probably two of the most important anchors for your repair.
Yeah.
It's good to see how meticulous you are with handling them and doing this properly. You know, it's a beautiful demonstration of knot tying. Our residents and fellows in the United States should take video because knot tying is becoming a lost art in the United States.
I agree.
But it's important. You have to be able to do a slider and both a non-sliding knot. You never know when you're going to need a knot.
I was surprised when I helped the live cadaver lab in an East Coast meeting. My student was, they didn't know how to perform the knot. I was very surprised.
Yeah. You had the wrong anchors for them. It was your fault. Yeah.
Okay, now we proceed to the bone fragment repair. So first, this is okay here.
That's a nice position of the guide on the glenoid to be able to bring the labrum back to its anatomic footprint.
Now, big grasp was coming in under superpolo, and I tried to penetrate the bone using bone suture. This one.
Yes. Hey, where is?
But maybe this fragment is not big enough, so that's why I just pass around the fragment. How much is coming?
Yeah, this is great. Where's Pascal? Pascal, you're king of acronyms. You coined the term TOTS, T-O-T-S. Temporary traction suture, correct? He almost has temporary traction here to fix the labrum and bone. You have a lot of acronyms that taught us well, Pascal. You want to teach us about that a little more? It's a very nice technique here to hold the labrum with a temporary traction or instrument, but Pascal coined the term TOTS. Very, very good.
Instead of struggling going down with the hook or with the suture passer, you put the first suture at, for instance, at 4 o'clock. You put it outside the cannula if you use the cannula, and you pull on the suture capsule, which allows you to go further down with the hooks inside the cannula to put the lower stitch at 5 or 6 o'clock. That's what we call the TOTS, temporary outside traction suture.
So I got the name wrong. Temporary outside traction suture. Very good. But it was close. Very, very, very helpful. Pascal's technique is helping quite a bit with.
So the last time I inserted the double loaded ankle.
Okay, so this is double loaded at
yes,
maybe 3 o'clock. So around there. 9 o'clock, 3 o'clock. This is to help manage the bone fragment as well?
Yes, yes.
Yeah. If you did not have a bone fragment, would you just use single loaded here?
But, you know, I always use it for the top anchor. In the case of bony anchor, I use it double loaded. So I will show you how to do it. So first,
Dr. O'Driscoll.
You know, this is Sean O'Driscoll.
Yes.
Beautiful demonstration. I wanted to ask if there was no bony fragment, would you still tie your inferior anchors first before doing the next ones? Or would you just tie them all? And
yeah, yeah.
Yeah, you can see the small piece of bone right there. In the fragment.
Yes,
underneath it, yeah. It has some blood in the bone, which is a good sign.
Thank you.
Hiro, do you do anything to move the humeral laterally so you can see better, especially as it gets tighter?
Humeral lateral pose.
Move the arm position to see better.
I don't understand your question well. Say again, please.
Yeah, Matt is asking that, do you apply any force to the humerus so that the glenohumeral space would be wider? You can have better view?
No, nothing. Just my assistant
He's
helps
pulling the
me
head?
to a little bit open
Pulling
up.
the head laterally?
No, just a little bit of distraction. So B-shaped is very, we have B-shaped position, the shoulder has freedom. So that's why it's very easy to, kind of distract.
You have a very good assistant.
Yeah. Dr. Uwe is very helpful. Thank you very much. And Dr. Honda, thank you.
So now you switch to needle here, no longer the Kaspari type device. Why switch now?
Because we no need to use Kaspari here.
Easier.
Namaste.
Is that hook you're using a curved hook or a straight crescent hook for the top part?
Little curve, 60-degree curve.
60-degree curved hook.
Yeah.
Thank you.
It's a pink grasper, pink suture grasper, my favorite.
Yeah. Now cannula back in to tie.
Yes.
Again, you have really nice flexibility not having a cannula in the shoulder to move with the hooks.
How many buttons here?
Yeah, so you got 6 limbs of suture, one from the bottom 6 o'clock anchor still, and then the double loaded anchor, which has 4 limbs, through the anterior superior portal, but brought 2 through the cannula to manage. It's a nice technique for suture management, especially when you're tying. Hiro, do you have a favorite knot that you like to use?
Yes, my knot is, we call it navy knot. Very simple knot, easy, small.
Yeah, that's fantastic knot, the navy knot. I love it. Yeah. Yeah. Much harder with the cannula in there.
Too much for this line. Thank you.
Hiro, do you ever come through the subscapularis, transsubscapularis for this case?
Subscap?
Through it at all?
What do you mean?
Transsubscap. In the subscap. Make an incision. You ever need that?
No.
No. Don't touch subscap.
But during my interval closure, I will incorporate the subscap tendon.
Do you do interval closure with all anterior instability?
Not all, but mostly. Especially this kind of the high risk patient, I do. I will show you later.
Yeah. Some people have described a small transsubscapularis portal to put anchors medial on glenoid to wrap the bone fragment.
Okay.
Double row bone fragment type of
I don't think that's necessary.
Yeah. No, you're getting a very nice repair here.
So here, when you fix the bony fragment, do you control the position of the fragment?
No. I control the tension of the ligament, IGHL. So the graft position is automatically decided because of after providing tension to the IGHL. This is I finished the bony banker repair. This is more permanent here, right?
Yes, yes, beautiful.
I will show you from front.
Because sometimes when we tie the knot, the fragment may move, may shift a little bit. So that's why I asked.
Yes, always shift. Always shift, the fragment shifts to the front, cranial side. Okay, this is a view after a bone banker repair.
So a nice bumper you created.
So after bony banker repair, banker repair, I always check the external rotation. Okay, double here, please. Subsponsor. Look at this, no external rotation loss. That's very important. Sometimes in the most supercranial anchor, if you make a little bit bigger pipe, you may restrict the external rotation. That's why in the case you need to release the superior soft tissue, superior IGHL. Okay, now I will show you the internal interval closure. First, I penetrate the subscap tendon itself.
So when you perform interval closure, you close the gap between the subscap and the SGHL, right?
Yes.
But many people.
Okay, now you see, okay, you guys, this is subscap and this is biceps. So if you are the external rotation, external rotation more than 60 degrees, around the 60, 70 degrees, but this structure goes to power like this. So I raise from the anterior colon, I insert the big grasper, and I try to penetrate the capsule, superior capsule, right behind the biceps tendon. Okay, first one, the second one.
So the first one is pretty lateral, close to the
Yes.
subscapularis.
So now a little bit external rotation, and I place the suture through the subscap tendon, like this. Subscap tendon and a little bit of MGHL.
She has a good MGHL in front of that subscap there. I think it's interesting that, and probably good, that you're not going all the way to supraspinatus or over the biceps, but just to
Now
SGHL.
my big suture grasper try to catch the soft tissue, most anchors, superior medial portion of the rotating of soft tissue. Like this.
So we always always want to try to capture the coracohumeral ligament, but the problem is this is a superior-inferior shift, not medial-lateral shift. Professor Jsoa has published on this in terms of CHL imbrication and management.
Okay, now after pressing suture like this, it looks like this. Now arm is 67 degree external rotation. So for the campus, so I will tie the suture inside of anterior pole. This suture is very strong permanent suture. This is a Dynaco.
So here, if you tie the knot with the arm in maximum external rotation,
70 degree, right now 70 degree.
70, okay. Does that cause any problem to the internal rotation? Because some scap slides. So if you fix it in the external rotation, then internal rotation may be deteriorated. That's
so
my
external rotation, a little bit restriction, and then only, maybe a couple of months after the surgery, but no problem at the end.
So here, this procedure decreased the volume of the joint. Do you think that has anything to do with the serviceability?
Say it again, please.
The rotator interval closure decreases the capsular volume, joint volume.
Yeah, decreases, yes.
Do you think that plays a role as a stabilizer?
Yes, the decreasing capsular volume is very important for shoulder stability. So that's why I think this is a very nice, simple, quick augmentation for the backup repair.
So quite similar to capsular imbrication, right?
This is after interval closure and body backup repair. And then lastly, I proceed to the no time of the repression.
Not time massage, yeah. So rotator interval closure, not all are the same, not all are created equal. This is a superior to inferior shift, but
yes,
as Professor Jsoa said, it's a volume decreaser. The best rotator interval closure is one that's probably done with an open Bankart, or open means when you're moving the CHL from medial, imbricating medial to lateral on the rotator interval closure. So it's very good as volume reducer, and I think it helps with the overall stability of this case.
I think that my interval closure is simulated to the open Bankart. I always simulate the open Bankart repair in my arthroscopic Bankart. Big capsular shift and also interval closure. That's very important.
It's one of the big differences between an open and arthroscopic Bankart that we don't talk a lot about is how the rotator interval is handled. But you address it here and have addressed it for a long time without motion losses or other complications.
If we perform the interval closure with the arm maximum external rotation, like a 60 degree or 70 degree, the motion loss or post-op pain never happens. So I always have the question from my foreign friends, but nothing happened. And I think this is much more easy, much more easy augmentation, adjunct procedure for the Bankart.
For remplissage now, how do you know that the tendon is in the bone when you're watching here? How do you know the tendon is reduced? Feel? Is it feel? Pushing it not down, yeah?
Yes, yes.
That's probably
I feel.
That's okay.
Yes, very tight, yes.
Do you feel it's important to watch subacromial space while you're doing
Yeah,
this?
I think this is very important. I think it's very important to see subacromial space. So, we can make sure the suture position and also press up, press up, press up.
You show really good separation too with the tendon, so very low chance for the suture to cut through.
What is this? What is this?
Is that the deltoid muscle we are seeing on the right side?
No, this right side is a rotator cuff muscle.
Yes, you're right on the edge of the muscle there. I think the visualization in subacromial space, sometimes we may be in muscle and not necessarily know it if you don't visualize. You're showing, I think, an important step because you actually passed the sutures exactly where you wanted them in the tendon part.
Yes. Okay.
Beautiful job, Thorough, very nice. All done in about 45 minutes. Well done.
Wow.
It's not a race, but it's fun.
Very good job. Very good job. We really enjoyed this.
Hiro, what is your rehabilitation? Yes, very nice job to you and the team. Very well done. What is your rehabilitation protocol?
Rehabilitation protocol is 3 weeks of immobilization with the strength, and maybe they can start your right exercise 3 months after the surgery, and the return to sports maybe about around 6 months after the surgery.
Okay.
But the important thing is that even during the immobilization, I encourage patients to stimulate the rotator cuff muscles contract. Rotator cuff muscle contraction is very important. Not just after shoulder stability, and also after rotator cuff repair. That's very important.
Scapular engagement, rotator cuff muscles, very, very early. We do the same to engage the muscles very early, like you said. Very important to get that back. 14 muscles around the shoulder need to start working well again together. A lot of muscles. Very well done to the team. Congratulate your team, experts. You have a great assistance.
Thank you very much.
Congratulations.
Thank you, Hiro. Congratulations.
Thank
you.
Thank you very much, Dr. Provenche, Dr. Itoi, and Dr. Sugaya. We are now preparing for the next symposium. We appreciate your patience.
Aber in alles.
Very
We will now begin Symposium 2, Shoulder Instability 2. This session will be moderated by Dr. Brian Bosconi and Dr. Nobuyuki Yamamoto. Dr. Bosconi and Dr. Yamamoto, please begin the session.
All right, everybody, if we could take a seat, please, and sit down, that would be wonderful. I'm honored to be here, and I'm honored to be with Dr. Yamamoto. Thank you very much. We'll talk about shoulder instability, maybe a little bit different techniques and thoughts. I know mine will be. Dr. Prevention, if you would start us off from the Stedman Clinic, been a close friend of mine, a pioneer in shoulder instability surgery. Is Latarjet truly the gold standard, or should we be looking at this closer? Thank you, Matt. Thank you, Brian. Thank you so much. So we're going to talk a little bit about where the Latarjet is, at least from our perspective in the United States, and we have certainly one of the best Latarjet surgeons in the world here in the front row, staring me down, which I love. But we're going to talk about how I think we can make this better. We have to look very carefully at how the Latarjet is truly doing. But like we talked about with Hiro just now, was our treatment decision starts in the clinic and examination room. My procedure is known before I go to the OR. Not all bone loss is the same. We have fractures, we have attritional loss, it's very similar to the case Hiro just did, number 2 type of attrition, and number 3 complete resorption or fully attritional. And we looked at 200 patients, a lot of our patients had attritional loss. So when do I use Latarjet? Well, maybe we should listen to Christian Gerber. He said, why are we arguing about this? If you have more than one instability event, you're getting a Latarjet done. And he says that numerous times. But at least in the United States, we start thinking about it with history of multiple recurrences, instability that's easily reproduced in mid-abduction, their sport, their activity, and then maybe if they have on track. You can also get issues you have to watch out for. We talked about voluntary, multi-directional, and obviously other issues around the shoulder. We have many ways to do this, and whether it's the congruent arc or the traditional Latarjet, both are acceptable. I would say most are most comfortable with doing what we call the traditional Latarjet, where the inferior surface of the coracoid is made to heal to the native glenoid. We talked about the subscapularis split. Chunyan showed us his outcomes with this, but we try to make this about 2/3, 1/3, or 3/5, 2/5, something like that. We have to avoid vessels medially. Vessels are right there as we go medially. Here's our classic and congruent arc. The congruent arc gives us much better curvature versus the classic. And we also have to know the limits. This is a study we did looking at male and female coracoid harvest sizes. Female, until you got to the CC ligaments, you don't want to get into those, is about 22 millimeters. In a male, 28 millimeters. However, everyone's a little different, and we can easily measure this on MRI or CT scan, and you have to know the limits. In addition, we did a lot of work looking at what the conjoint tendon looks like here, what the CA ligament looks like, and then as soon as you take that conjoint tendon down, you have all of these structures right here, which is the plexus, nerves, and vascularity. There's a lot of ways to do the capsular closure in terms of using suture on the coracoid ligament stump, CAL stump. You can use suture washers, you can use anchors. We went back and looked at our Naval Academy midshipmen. This is where I went to school. These patients had their procedure done in the 1970s, believe it or not. They had a Bristow or Latarjet, 1 or 2 screws, so there might have been some differences. But they had we followed these patients at 26 years, and we did have about 15 to 16% recurrent instability at 26 years. Arthritis was around 20% and consistent with Hevelius. But now let's talk about where we truly are with the Latarjet. And if you look at the world's literature, these are the things we worry about. What about weakness? We talked a little bit about this. The L-shaped tenotomy has a weakening effect on the subscap. And we looked at Porcellini's work. Insufficiency of subscap actually can present just like the patient feels like their shoulder's dislocated. It's not doing well. So we call that subscap insufficiency, pseudoparalysis. What about J.P. Warner's work? If the high-risk stages of Latarjet, you get glenoid exposure and the graft placement. Why is that? Because as soon as you take the conjoint down, you have a lot of stuff right there. I call it the naked vessels as soon as you take that down. We did a study looking at the anatomy of shoulder after open Latarjet and defining a safe zone for this, looking at all of the lateral cords, musculocutaneous, and the axillary artery. These are actually very close. If you've been back after Latarjet, this can be quite close. Well, let's now talk about recurrence after the Latarjet. If you look at JP's work in 2012, neurologic injury was 10%, musculocutaneous, axillary, and radial. Recurrent instability was 8%, but some of these took quite some time to develop. So instability at 8%, not perfect, but not too bad. If you look at recurrence associated with graft lysis, Giovanni looked at 59.5%, so the coracoid sort of melted away, but it healed well, and the patients actually did quite well. So just like we talked about earlier today, all bone grafts, doesn't matter what, do melt away. We looked at our recurrence here. We had 15% in 26 years. Ovelius has had about the same, 15%. Tony Miniacci's recurrence rate, 8.7% with non-unions and other complications as known here. What about pain? Christian Gerber has taught us if you're going to deal with a patient that has pain after a Latarjet, pre-op pain has 20 times greater probability of post-operative pain. Go figure, another surgery of doing an instability case in someone with pain after Latarjet is not a good thing, and at 22% with progression of arthritis. We looked at the NFL Combine, where we looked at all the patients that had a Latarjet. So we get high-end imaging on all of these patients that come to us before they get drafted in the NFL. We see about 330 players every February in Indianapolis, Indiana. We reviewed about 6. It was very interesting in that almost half of these patients with a Latarjet had a hardware complication. 100% had degenerative changes in football, graft resorption in 62%, and many of these players went on drafted. Recurrence, 8% with Miniacci due to non-union. If you look at Ovelius's work, he's had subluxations or dislocations in about 18% of patients at 15 years, so longer-term follow-up, but about 18%. When you look at open versus arthroscopic Latarjet, there's a recent meta-analysis, 896 patients, almost 1,000 patients. Total recurrent instability, about 2%, so overall not too bad, but apprehension did persist in quite a few patients when you look at definitional attributes. What about coracoid fracture or other problems or screw issues, nerve injuries? These are all things we are concerned about and have to be very careful of. J.P. Warner had 76% nerve alerts. A lot of those went away, but did have 10% persistent nerve defects and 20% presented with clinical neuropraxia after open Latarjet. So these are all patients that have presented to me, some maybe myself, but cannulated screws, not so good. Partially threaded screws, not good either. Recurrence, resorption, hardware failure, hardware pullout, we've seen it all, and it's an issue. When you look at the non-union rate, it's around maybe 9 to 10% if you're looking at the graft not healing. It's either a yes or a no. Did the graft heal to the glenoid? Maybe about 10% with screws. So maybe Pascal is onto something with buttons. We're going to hear about it a little more. But recurrent instability with this type of large 2,000 patients, 16% with Latarjet, 16%. Outcomes for more severe bone loss, 8%, 12%, 15%. Another studies here with 20% graft failed to unite, 10% had recurrence in the Latarjet group. But from what I can tell here and putting everything together, Latarjet recurrence, or meaning recurrent symptoms of instability, doesn't have to be a dislocation, but recurrent instability, this is from the literature, 8 to 19%. It's real. And this is what we had at the NFL Combine with severe changes. Half went undrafted, it was a big deal. And And so maybe the ladder J and some of our collegiate players may not be the best thing, or at least the way we were doing it in the mid-2000s, looking at 2 screws and the classic. What about Larry Higgins? Can they get back to play? Well, 14% decreased their activity level. Only in his study, only 15% returned to the pre-op sports level. 12% changed sports. 25% stopped altogether. So maybe there's something mentally here we're not looking at. But the issues here with the ladder J are not, it's not all rosy picture. It's not 2% recurrence, it's not 1% recurrence. So we have to evolve, we have to get better. It is a reliable procedure if you get the graft right, if you get the fixation correct. You may want to think about how you do this based on your volume. Meticulous graft position fixation is very important, and you have to be aware of the complications because again and again, these are real, and I think we have to continue to look at this with a very keen eye. Thank you very much.
The next speaker is Dr. Busconi. He talk about the open bunker repair for collision arthritis. Please.
Thank you. And again, I'd like to thank Hiro and the entire group for inviting me. I have nothing to disclose. You know, today we saw an excellent example of fixing something arthroscopically. It's been amazing to watch as we do more and more arthroscopic procedures. We seem to add on more, whether they're remplaçages or Bankart repairs. They're getting more complicated. And you know, quite honestly, what if I could provide you with a procedure that in 70 years of success outperforms arthroscopic stabilization in contact athletes with less than 13.5 bone loss? Easy. All you need is a knife, short OR time, and your night is never disturbed wondering whether you did it good. Would you do that procedure? I think everybody in the wood's shaking their head. Yeah, I'd do that procedure. So, you know, I'm here in Japan, and I'm going to introduce to you the open Bankart. So the evolution of my practice began in 1993, and I really just did open instability. It was a very common procedure in my hospital, averaged more than 150 a year. We then transferred into arthroscopic, and I convinced myself that I did a pretty good job of doing arthroscopic repair in these contact athletes with a failure rate of 14 to 16%. Now with the area of bony enlightenment, we moved now to procedures that are addressing the bone. You know, and historically, we began the critical bone loss was 25%. Now we've dropped down to this 13.5%. And quite honestly, my biggest problem with the literature right now, as you've seen today, is that you can find something that's going to say, hey, what I'm doing is absolutely correct. You want to do arthroscopic procedure with a remplaçage? This literature to support it. You want to do a ladder J? This literature to support it. You want to do an AGR procedure? There's literature to support. So what do we know and what can we find out? Why I'm back to doing more open instability repairs is mainly because of this critical bone loss and problems with soft tissue. The key, however, is the patient selection. We have to make sure that we're talking about the same types of patients. So here we are today. We're now up to A, B, C, D, and E in terms of what we're doing for procedures in the shoulder. Who gets an arthroscopic Bankart? Still very prevalent in my practice, don't get me wrong. 70% of my practice is still dislocation with or without remplaçage. But you know, if you can't do an arthroscopic Bankart, why have we jumped to coracoid transfer? What happened to the B in that, the open Bankart procedure? And if we're going to start talking about open Bankart, we need to make sure that we're still talking about the same patients. Who am I doing an open Bankart in? And it's not that simple, right? Age, younger age, contact collision athlete, poor hypolaxity, all of these, as Matt indicated in the last talk and Rachel had talked about. Again, making sure you understand who the patient is and putting them into the right procedure is very important. Why am I open? Because this is my life. I don't, over 80% of my athletes are contact athletes, Division I football, professional hockey players, wrestlers, MMA. I'm not treating a lot of people come off the street and have instability. I'm treating people that are getting back to high injury sports. I generally am trying to fix somebody after their first dislocation. And in my practice, who's getting an open Bankart again is that minimal bone loss person, collision athlete, potentially capsular core tissue, significantly fewer dislocations, and again, high demand shoulders. It's been a reliable procedure for 70 years. Notice, I'm going to show you all this literature. 97% satisfaction, 5 recurrences. 5 recurrences, 6%, 3%, 2%. A lot of, they're out there, they're showing success rates that far outpace arthroscopic procedures. Here is a follow-up Rotor 2015, 20-year follow-up, 20-year follow-up, okay? 2 revisions, 95% satisfaction rate. Open Bankart looking at a systematic review, markedly much more powerful capsular shift that we've talked about, and the potential for less recurrence, especially in high-risk populations. So that's why they do this procedure, the risk redesign. So here's a typical patient, 21-year-old junior, Division I hockey player, looking to go to the NHL. X-rays look good, not a lot of bony loss, small hill sacs, okay? Here we are, we have some bony involvement, attritional bony involvement we talked about. You know, for an ice hockey player, my contact athletes, if they've dislocated once, they probably come out 3 or 4 times. Again, you see this attritional bone loss that we talked about earlier. You know, you go in arthroscopically, and this is what it looks like. It's subluxing over. You know, are we truly treating this injury correctly with a soft tissue repair, even with a rump massage in a contact athlete? So my solution is the open Bankart. It's very easy. The approach is easy. It's something that is, you do it once and you kind of say, geez, it's not all that difficult. You come down to the conjoint tendon, you find it, you do a release. You know, immediately you come down, you find your vessels. Once that's done, it's very easy to put in a large retractor which will separate this. And once it's done, you're looking down at your subscapularis. At this point in time, you make a decision. If I want to make this really easy, I do a subscapularis tenotomy, or I tenotomize the inferior 2/3. If you want to do a subscapularis split, again, a nice, easy procedure to do. When you want to split this, all you do is locate where the muscle attachment is to the subscap, and you come down. Once you're down, you open up the muscular portion. You put in a sponge into that area. That helps open that up, and what that does is it enables you to see the difference between the subscap and the capsule. You open that up, and then you go. Professor Fukuda created a fantastic retractor for this, the Fukuda retractor, when he was in New York. At that point in time, what you want to do next is that you are seeing this very well, and you put your sutures in. You could use knotless, you could put knotted, you could put tied sutures. Whatever sutures that you want to put in, you put in. It's easy to see the 6 o'clock precision. You're not struggling. You're not worried about where is my drill guide going. Once that's done, you tie, you repair anatomically the labrum. And once that's done, quite honestly, you come out and you're now at the level of the capsule. Here, you can do a powerful shift. I'm not worried about shifting up top. I'm shifting the inferior leaf, superior leaf, inferior lateral, and I'm doing a powerful capsular closure. I do so with about 40, 45 degrees of external rotation in my shoulder when I do that. Once the capsular implication is complete, if you did a subscapularis takedown, you repair it. If not, you just you don't do anything with the scap. You just leave it as it is. So where are we now? Again, I'm looking at this procedure with minimal bone loss. What do patients want with patient selection? They want a better quality of life and a bumper-to-bumper warranty. Do a procedure that's lasted 20 years in the majority of my patients. In fact, ask Professor Sagaya. He gave me 2 thumbs up with an open Bankart procedure. So, anyways, thank you everybody for inviting me, and I look forward to the rest of the talks. Thank you.
Next speaker is Dr. Jsoa. He talk about shoulder instability in badminton players. Please.
Thank you, Nobu. Thank you, Brian. I'm going to talk on anterior shoulder instability in badminton players. and our surgical algorithm based on 67 consecutive cases in elite and competitive players. Badminton is a high-speed sport, very popular in Asia and India, and this sport's particularly interesting because you need athletes who are going to be able to get their full abduction external rotation, so they generate forces in their smashes over 400 kilometers per hour. They also need to dive to retrieve the shuttle, so diving is an important part of badminton. So you need a shoulder that's really stable and capable of taking all these loads when you're diving, but at the same time you need a shoulder that gets into extreme abduction external rotation. In fact, in the doubles players, they're generating forces over 500 kilometers per hour when they're hitting the shuttle down. And so it's important both for singles and doubles, and the women's game is no different. In women too, diving is an important part in elite and competitive badminton. And so this predisposes them to instability, but at the same time they need to get back with shoulders that can go into extreme abduction and external rotation. Our novel algorithm for anterior shoulder instability has been, if you've got no significant bone loss, then we do a Bankart or a Hagel repair arthroscopically. And with significant bone loss, we would divide our glenoid bone loss into subcritical, which means more than 13%. And typically for the last 12 years, we've been doing arthroscopic iliac crest bone grafts with labral repairs for these. And for the critical ones, we've been doing latages. And for humeral bone loss, we've been doing a remplissage. What we wanted to study was this the appropriate approach for competitive badminton players? So we had a retrospective study in which we included 67 competitive badminton players. These were elite and junior level players who had anterior instability in their dominant shoulder, who underwent a surgical stabilization between Jan 2015 to December 2023 with a minimum 1-year follow-up, and the range was 1 to 6 years. And what we studied was different aspects. What were their instability patterns, their clinical outcomes, their smash analysis, return to play capabilities, and recurrence. In the instability patterns, we had 19 which were first-time anterior shoulder dislocations and 48 which were recurrent. In these, we had 32 which were isolated Bankart lesions, 18 which had subcritical glenoid bone loss, 14 with critical glenoid bone loss, 11 with off-track Hill-Sachs, and 2 with combined or bipolar bone loss. We studied their clinical outcomes with their range of motion, instability tests, Oxford Shoulder Instability Score, ROSE score, and the shoulder subjective value for sports. We also analyzed their smash analysis with a biomechanical analysis, visual, video, and with motion analysis to try and see do they get back their original smash. We also analyzed their return to play capabilities. Was this at the same level or a higher level, a lower level, or did they retire from sports? And finally, did they recur with either subluxations or dislocations? And what we had in our group was 32 patients with isolated Bankart, 18 with glenoid bone loss, where we did an iliac crest bone grafting arthroscopically. We had 11 that we had done a Bankart with a remplissage, and 6 that we had done a latage for a critical bone loss or a bipolar bone loss. And what we found, and this is it's a busy slide, but I think I can show you that what we found was basically this, that if you had a patient who had an anatomic repair with just a Bankart or a Bankart with the iliac crest bone graft, their mean loss of external rotation in abduction was minimal, 4 degrees to 6 degrees, something that the players could adapt with. But as soon as you went to a non-anatomical procedure like the remplissage or a latage, then the loss of external rotation in that abduction was significant. And if we see the scores are basically similar, but when we analyzed their smash, we saw that again the anatomic ones had an altered smash analysis biomechanically in a small percentage. But as soon as we went to the remplissage, this half of our patients had an altered smash. Latage, 2/3 of our patients had an altered smash. And this really translates also into their return to play. So if you look at the return to play in the Bankart and the ICBGs, high rates of return to play at the same level or at a higher level, some at a lower level. But as soon as you look at the remplissage and the latages, return to play at the same level is significantly lower, and most of these patients had to return at a lower level. However, concurrently, if you look at the recurrence rates, our recurrence rates were higher with the Bankart, and of course much lower with the remplissage or the Latarjet. So what we had here was patients who had great stability but who just couldn't get back to the sport at the same level. Whereas if we went for an anatomic procedure, then they could get back to the same level or higher level, but you were risking some degree of instability with repeat injuries. So algorithm has changed for badminton players as against the normal patients where we would do exactly what I first discussed. With our patients with badminton, we now have shifted to an arthroscopic repair if there's no significant bone loss. But even if there is significant bone loss in the glenoid, or if there is a humeral bone loss, we're still going to not do a Latarjet, we're going to stick to an arthroscopic iliac crest bone grafting. And I'm going to show you the sort of technique that we use. So for the arthroscopic Bankart repair, typically you want to be identifying the lesion, you want to make sure that you've done an adequate release, you make sure that you've prepared your bony rim out there so that you can get biological healing. And typically in your normal patients, you're going to take a large bite so that you've included the capsule and you've included the inferior glenohumeral ligament. So you call this a capsular labral repair. But in these badminton players, you want to just take the labrum with a little bit of the capsule. As Loku showed, there's some plastic deformation of that capsule, so you want just about a little bit so that you can make this an anatomic procedure. You've got a nice bumper there, so you've got your capsular labral bumper there, and this ensures that these patients get back their original external rotation with hyperadduction, something that they're going to need for their smashes, and especially for their overhead, over-the-shoulder smashes. On the other hand, if a patient has bone loss, and that bone loss is like this, a subcritical bone loss of about 13-15%. I'm going to be doing an iliac crest bone grafting, but remember that this is a Bankart plus procedure. You're going to also do a soft tissue capsular labral repair, and the way we do this is release the capsule as an envelope, make sure that you've got a nice pouch out there, put your jig in, and I fix this with buttons so the jig comes in from the posterior portal. You make your two drill bits there, you put your anchors in the beginning itself, you then put your iliac crest bone graft, and typically we're using a large iliac crest bone graft because we know that there will be some amount of resorption. So this is typically 25 to 30 millimeters in length along the anterior part of the glenoid. Make sure that you've adjusted the position, and normally when I'm doing this, I'm lining up the bone so it's bone to bone and it's not to the cartilage. You then fix it from the back with a button, and then you can do a differential tightening with the tensionometers, and in this way you get your bone there, you fix your labrum on top of that, so you've got a capsular labral repair, and this gets back your stability. So if you look at the CT scans, that's the CT scan that you'll see at the 3-month mark where healing has taken place. We also do this for patients who've got significant bone loss. So as you'll see here, this patient with significant bone loss, we're going to put in a larger 3 centimeter graft because we know that at the 1-year mark, this remodels. You can see that that's the sort of remodeling that will take place. And when you see the actual scans there, that's the healing of the graft, that's remodeled, and now you've got your normal looking glenoid. So all in all, if you've got a player who plays competitive badminton, I think only anatomic restoration works. You could give them stability with restraint, but that's going to prevent them from getting back to their original level of sports. So for competitive badminton, anatomic restoration only. Thank you.
So last speaker is Norimasa Takahashi. He talked about shoulder instability in throwing dominant arm, please.
Thank you, Chairman. I'm honored to be here. Today I will present our study entitled Outcomes of Arthroscopic Bankart Repair in Baseball Player, a subgroup analysis of pitchers. Here is my disclosure. Shoulder instability is common in collision and contact athlete. However, there are relatively few reports on baseball players. In particular, pitchers rely heavily on shoulder mobility and stability, which makes them more vulnerable to instability of throwing shoulders. The instability of throwing shoulder may compromise performance and delay return to play. We reported shoulder instability in baseball players several years ago. The instability in throwing shoulder occurred with head pass sliding and diving catch. Looking at literature, after the first injury of throwing shoulder, 87% of athletes returned with non-operative care. However, 37% had recurrence during the same season, and 53% required off-season surgery. Because the throwing motion is similar to the dislocation position, many players develop apprehension and struggle to pitch. The purpose of this study was twofold. First, to investigate outcome of arthroscopic backhand repair in baseball players overall. Second, to analyze a subgroup of pitchers with throwing shoulder instability. We retrospectively reviewed 229 baseball players, 231 shoulders who underwent arthroscopic backhand repair between 2005 and 2023. All patients were under 40 years old and had at least 1 year follow-up. Outcomes included return to play, clinical outcome, and recurrence. 119 shoulders met inclusion criteria. They include 67 throwing shoulder and 52 non-throwing shoulders. Mean age at surgery was 21 years old. On the throwing shoulder, the most common cause of shoulder dislocation was head pass sliding. On the non-throwing shoulder side, the leading cause was diving catch. All patients underwent arthroscopic backhand repair. Rotator interval closure was indicated for a huge throwing shoulder and most of non-throwing shoulder. The low score demonstrate a significant preoperative improvement, postoperative improvement in both the throwing shoulder and non-throwing shoulder. Return to play was achieved at 11 months in throwing shoulder compared to 6 months in non-throwing shoulder. The recurrence rate was 6% in both throwing shoulder and non-throwing shoulder. Although there was no significant difference between the two groups. 72% of throwing shoulder side group and 83% of non-throwing side group were able to return to game same level. This is a 21 years old college infielder. The first time dislocation occurred at age 21, caused by head pass sliding. After that, he was only able to throw for 27 meters. With half of his usual strength. The second dislocation occurred 6 months later. He eventually underwent surgery after his last game of the season. Preoperative image showed we can see the back eyelid loosening and not critical bone loss. This video Bankard is released until 7 o'clock. So we usually use 4 suture anchor for Bankard repair. So I use the broaded anchor in this case. So after Bankard repair, we usually choose range of external rotation like Hiro showed last live surgery. At 10 months post-operative, he can able to throw 50 meters. At 12 months, he returned to game as a second baseman. At 2 years after surgery, he signed with an independent league team. According to a survey of professional baseball players in the US, pitchers require more advanced shoulder function than field players. Consequently, The overall rate of return to play after shoulder surgery has been reported to be lower in the pitcher compared to the field player. In the pitcher subgroup, we included 13 players with throwing shoulder instability. Mean age was 18 years old with mean follow-up was 21 months. Along with banker repair, five cases require strap repair, 1 case require handle repair, and one case underwent rotator closure. 77% return to baseball and 69% return to pitching. The average time to return to pitching was 12 months. Also, stability was achieved. The return rate and recovery time were clearly less favorable compared to the field player. Regarding surgical outcome for throwing shoulder in pitchers, only the report by Park and colleague has been published, which included 5 cases. In that series, the pitcher were able to pitch in only 1 official game before retirement. In our series, however, 9 out of 13 pitchers were able to return as pitcher. 6 of them returned to the high school level and 3 returned to college level. In conclusion, arthroscopic banker repair provide reliable stability and favorable outcome in baseball player overall. However, pitcher experience delayed recovery and lower complete return rate. These results highlight the importance of special management and prolonged rehabilitation for pitchers with throwing shoulder instability. Thank you for your attention.
We have all the speakers come on up to the panel. And if anybody has any questions, could you please come up to the microphone?
Sometimes it's not easy to treat throwing athlete with anterior instability. Especially they need greater range of motion, especially external rotation and horizontal abduction. So I have a question to all speakers. To prevent the restriction of the external rotation and the horizontal extension, so are there any tips and tricks when performing the lateral procedure, banker repair, please?
Okay. I try to anatomical repair for the especially throwing athlete dominant arm. So I release banker and try to catch by the capsule, but the anterior side of the capsule a little bit less bite compared to the inferior part of the capsule. That's my tip for the prevent external rotation loss.
How about horizontal extension? That's also the very important for throwing athlete. Did you measure the horizontal extension angle?
Not during surgery. Yeah.
But to prevent the restriction of the horizontal extension motion, so are there any tips?
I think just during surgery, maybe a little bit tight, but this kind of patient population maybe gradually perhaps a little bit elongated after surgery. So that's adapt throwing motion, maybe.
For me, I think restoring anatomy as far as possible is the safest way to get back that range. In your normal population, you're introducing some amount of restraint for stability. But any restraint in these competitive players who need to go into this extreme sort of position is not tolerated well at all. So I think for me, unlike your normal guy where you're going to take large bites, you're going to do an inferior to superior sort of shift, here you want to do just a capsular labral repair. I think we need to understand it can't be just a labral repair, exactly as you showed in the morning. There's some amount of plastic deformation of that inferior glenohumeral ligament. So you take some amount of a bite. That 20% is difficult to determine intraoperatively. So you're going to take a little bit of a bite to make sure that you've got a good bumper created. So you've got your cavity compression effect there. You've also got tension in that anterior band of the inferior glenohumeral ligament. And I would say leave it at that. As soon as you start doing rotate interval closures or a remplissage or a latagé, which just disturbs the biomechanics so significantly, I think these players then don't get back to their original level of sport.
Yeah, I think it's important that, again, just to reiterate, I've rarely ever seen a Bankart tear not go long beyond 6 o'clock. And I think that making sure that you do that inferior stitch to rebalance the capsule and come up in an anatomic way in throwing athletes is extraordinarily important. I agree 100%.
Much agree.
Yes. Banchan from Thailand. Asking Jsoa, I enjoy your talk. Jsoa, in case in badminton you have huge stagnation, you say that you will not do anything about remplissage. How can you manage that off-track lesion?
Yeah. So that's exactly what we try to show. You know, in 2015 onwards, when we're doing remplissage, what happens is that your remplissage patients in that position are going to lose some amount of that external rotation. So the question is, do you want to stabilize them and give them a more stable shoulder, but they never get back to their original level of sport? Or stabilize them to some extent, do less, but not too much, let them get back to that original level of sport, but that does predispose them to a slightly higher recurrence rate. And what we saw amongst our players is that at least they'll get back to their original level of sport, and unless they have another diving injury, they're not really predisposed to instability. And so for me now, for a competitive badminton player, a remplissage would be an absolute no-no. I think that's exactly what we saw with the latagé patients too. So significant bone loss, 20% bone loss. As soon as you've done a latagé, you've disturbed that subscap, which is so important for badminton players. You've cut off the pec minor and disturbed his scapula. And that's the whole reason why biomechanically they can't generate that force and that abduction external rotation. Some of them, in fact, have a subtle scapular dyskinesia also. So even if they've got 20% glenoid bone loss, I'm not going to do the latagé. I'd rather do an alia crest bone graft. We don't get distal tibia allograft, so we're going to use alia crest. That alia crest is painful for the first 2 or 3 weeks, but thereafter there's no problem there with these players. And this remodels well, so try and stay as anatomic as possible, at least for these competitive players. That's our message.
Jsoa, how about the bite you make for Bankart? Is make bigger bite or you make like routine Bankart?
No, so exactly. I take a smaller bite for these patients.
Smaller
so
bite.
In routine Bankarts, we're going to take larger bites because we have more interest in stability. Most of our normal patients are not that disturbed by that terminal loss of external rotation in abduction. But for these
How
players
small? You say smaller bite?
Yeah. So typically when we're taking a bite and I use, an antegrade device, I'm going to take a bite of about 12 to 14 millimeters. And that bite also goes into the anterior band of the inferior glenohumeral ligament. Whereas in this case, I'm going to go just a little beyond the labrum, 2 or 3 millimeters beyond the labrum. So I've retensioned that anterior band of the inferior glenohumeral ligament, but I'm not losing any range at all.
Yeah, thank you.
I think your point about the pec minor is very interesting. With the latagé and the pec minor release, we don't really get complaints about the pec per se. Although the only complaints I've had is very interesting. Are very bigger bodybuilders. They're in the military. They did a lot of bench pressing, and I had several patients come in and they complained about the way their upper pec looked. Not many. We're talking 3 or 4 over 20 plus years, but a very interesting finding on that. So maybe there's something there with a heavy, you may want to tell them. The other thing on the pec minor is the scapular dyskinesia and how we can manage things like thoracic outlet and scapular dyskinesia and a lot of too much anterior tilt and too much internal rotation of the scapula. Ben Kidler calls a pec minor that's a kind of a sick pec minor, a diseased pec minor, pathologically tight, that you feel ankles needs to be released. We've written up a lot of these patients on isolated pec minor. It's pretty interesting. And then it's also dovetails into the latter J, but I can see how a very competitive racket sport like badminton could play into the scapular mechanics. So again, nothing's for free in orthopedics.
Yeah, and to that point, Matt, you know, it's very important to have a shared decision process with your patients before going in, indicating to them that, yes, I can do this procedure to help out with your instability. However, it's going to change the carrying angle of your smash playing badminton or your serve playing tennis. You need to have that because managing their post-operative care becomes easier if you've had that discussion pre-operatively about what the results are after surgery. And I think that your study showing the smashing of the badminton player matches tennis, matches other things. The athletes come in, if you tighten them too much, their abduction carrying angle is such that they can't get elevation up, and at that point in time, they lose their velocity on their head when they throw with the racket sports.
And when treating the patient with the instability, we need to consider the laxity, joint laxity, especially the contralateral side. So I have a question to all speakers. How do you evaluate the joint laxity, pre-operative and during the operative? And how do you reflect, how do you change the technique? So according to the joint laxity.
I will usually check the under UN examination under anesthesia, both sides instability check, and also we see the capsule quality during surgery. So if the patient very relax the shoulder and then dominant arm with dominant arm, so some maybe close rotated interval, but very rare case for the throwing athlete.
But you know, that's a really interesting question because especially in the badminton players, if you see their dominant arm versus their non-dominant arm is so different. You know, they're using their dominant arm excessively and it's an acquired capsule laxity that they've got over time. It's not a congenital one. And I think that trying to tighten it too much and trying to get to that normalcy, in fact, makes them less efficient as badminton players. So I think leaving some amount of capsule laxity, keeping that volume intact as close to pre-injury is, I think, important. But it's so difficult. You can, of course, assess this preoperatively. You can also maybe do an EUA in the OR. But it's at the end of the day, I think it's just eyeballing because there's no definite parameter that's going to give you that exact sort of volume that you want post-operatively.
We found that the other shoulder may not be a good surrogate for what's going on in the injured shoulder because of adaptive changes of dominance. And badminton's a good example, baseball's a good example, water polo, throwing, any overhead type of dominant sport. It's not a good surrogate. This is just an aside. We used to do, or at least was advertised, to do the contralateral CT scan for evaluating bone loss. We did a study on that, and there are actually adaptive changes in the glenoid and glenoid side that shows that's actually not a great estimation. It can be off by 10, 15, 20%. If you do a contralateral CT of the uninjured shoulder, when you're looking at the other shoulder, we used to do that back in the day to look at bilateral shoulders, but when you looked at it really closely, the glenoids are different side to side. So those are all the adaptive changes going on.
Yeah, and I think preoperatively, it's a good idea to look at their other joints and look at your Baden scores. Quite honestly, if I have a patient with Baden scores 7, 8, and 9, and I have a belief that I'm going to go in there and find a good capsule, you're crazy because that patient's going to stretch out everything you do. So I will adjust based upon what their other joints look like and are they having problems in other areas as well.
Question?
Yes, question for Dr. Jsoa. Thank you for your presentation. In case of your throwing athlete case, if they have a recurrence on your first procedure, whatever it is, do you use the same procedure for them to keep their level? And can you suggest them that they accept to do again the same surgery and risk recurrence? Or do you change your procedure and make it more aggressive at the risk to lose their initial level?
I think that's a great question, and that's something that we've been debating ourselves. And I think that's where that shared discussion comes in. That's the real problem. So if you saw that group of those elite players, we had about 12% that had a recurrence. So that 12% is a difficult group to deal with. If they're towards the end of their career, we try and see if we can just go non-operative as far as possible. But if we can't, then we're going to tell them, look, you've got two options, because this is what we can do. We can stabilize your shoulder and make sure it doesn't dislocate out again, but you may lose your capability. How are you going to be able to adapt? And for them, you know, as badminton players, it's not so easy to change from a singles to a doubles, etc. So some of our patients have taken the option to go back and do exactly what you did the first time, because that was so great till I got injured, and I don't mind doing it again. Whereas others have been, look, I'd like to probably stabilize it further, and then we'll see how it goes. So it's been both ways. We've done revision time card repairs for some, and then we've done iliac crest bone graft or a Latarjet for some.
Thank you very much for your answer. And for in Funabashi or in United States, in case of recurrence on your first procedure on throwing athletes, do you use the same procedure, or do you augment or make it more aggressive in the second time?
Yeah, good question. For the baseball player, the recurrence case, we change usually. You do change, but we have to say, so maybe you cannot return on same level. But try to stabilize with another procedure.
Well, I'll tell you that after the failure and doing a recurrent procedure, well over 75% of my patients say, I just want to live my life. Thank you very much. And I like my stable shoulder and don't get back to sports. So, you know, I think that if you're dealing with a high-level athlete that's based upon payment as part of their job, or a military person that's trying to get another 3 or 4 years out of their practice, they're willing to do a larger procedure and get back. But my higher return athletes, especially my football players, after that second procedure, just you know, kind of say thank you very much. My shoulder feels great now, and I'm done.
One last question for you, Mr. Jsoa. In case of ineliminated iliac crest bone graft to your strongest players, if you have, unfortunately, a recurrence and you want to be more aggressive, do you do a Latarjet on an iliac bone graft?
Yeah, so we've done that, the step up. So we've done an iliac crest bone graft primarily because he's been either subcritical or critical bone loss. And if you saw in this series, we didn't have a single patient who had a redislocation. In a competitive player, a redislocation following this, we've not had. But we've had some other patients, not in badminton, but other sports, who have had the rare redislocation following an iliac crest bone graft, and those we move up to a Latarjet. But these are typically patients who don't necessarily need that extreme hyperabduction with external rotation, so they can adapt well to a Latarjet.
Thank you very much.
Thank you. Time is running, so we'd like to close this session. Thank you for your cooperation.
Thank you very much, Dr. Pistori, Dr. Yamamoto, and all the speakers of this session. This concludes the morning program. Thank you for your time and participation.
So I put your name. Oh, yeah. Thank you. すいません。なんか連絡？ああ、なんかまあそうなんです。
藤井先生。ああ、先生、ごめんなさい。
Ladies and gentlemen, please be seated. We're going to start the lunch symposium very soon.
Perfect surgery. The pink one, the girl with the pink glass. I noticed and he told me already that I will see you. Actually, all of us here.
Okay, ladies and gentlemen, please be seated. We are going to start the lunch symposium in 1 minute.
Yes. Perfect.
Okay, ladies and gentlemen, good afternoon. Welcome to the lunch symposium supported by Smith and Nephew. So today we have the greatest honor to have two great speakers from Europe and Asia to talk about their work in managing significant energy renewable laws. I'm Patrick Gong from Hong Kong. So today the two speakers are essentially, I think most of you know well about them. So the first one is Professor Pascal Bollet from France, Nice, right? Hope you know him well, and he founded the Institute for Sports and Reconstructive Bone and Joint Surgery, and then he was the president of the European Society of Surgery of the Shoulder and Elbow, and then he founded a lot of advanced technique in shoulder surgery, and wrote a lot of awards and published a lot of papers, and I'm pretty sure a lot of you have attended his courses in these, which is very famous, not just in Europe, and also in Asia. The other speaker is our president of Jsoa 2025, Hiroshi Kaya, good friends. So he's now currently the chairman of the Tokyo Sports and Orthopedic Clinic. I'll introduce them later on. So without further ado, I would like to invite the first speakers, Professor Pascal Bollet. He's going to talk about the arthroscopic guided Bristol lattice procedure with cortical button fixation. Pascal, please.
So you know this operation using suture buttons instead of screws, and we started many years ago, actually 15 years ago, and what we try to do is to make the procedure reproducible. This is why we really make all the steps very clear. And as you see, you start with the coracoid preparation and osteotomy, then you do the glenoid preparation and drilling, then the subscapulary splitting, then you transfer the coracoid and you fix it with the buttons, and then we do a bankart repair systematically. So on this small animation, you see the coracoid preparation and drilling with the anterior button, which is a peg button. then the osteotomy, then you prepare the glenoid neck, you drill from posterior to anterior, which makes very safe the procedure. You put a spreader posteriorly, a spreader anteriorly, you create a window in the muscle of the subscapularis, 2/3, 1/3. You bring the bone block by pulling on the suture posteriorly, you add the posterior button, you tie the sliding locking knot, the disc knot, and then 3 surgeons knot after you put compression using a suture tensioner. So this is very straightforward. The portal that we use are north-south, west-east transpectoral, and north-west to be orthogonal to the coracoid process. And the knot that we use is very simple. It's a disc knot. It's a sliding locking knot that we use. So again, the goal is to transform a flexible system fixation system into a rigid fixation. Basically, our goal is to create a bolt. And for this, we use this tensioning device 3 times 100 newtons. Once for removing the crimping of the suture, once to do the knot tying process, and one to get the real bone compression. So this is a short video to show you the technique here. The north portal is just medial to the coracoid, and the northwest is orthogonal to the coracoid. Then you have the west portal and the east transpectoral portal. So we start posteriorly with the scope. We use a 70-degree scope. You see the Hill-Sachs lesion seen from posteriorly. You see that we start with through the west portal along the subscapularis. Going from lateral to medial, we find the coracoid process, then we find the conjoint tendon. We cut the CA ligament from the lateral side of the coracoid. We pass over the coracoid. Then we reach the pectoralis minor medially. We go under the coracoid. We remove all the soft tissue and make cauterization of the vessels. You see the conjoint tendon, and immediately you see the nerve here, the axillary and the musculocutaneous nerve. We put 3 needles to make sure we're going to get a good orientation. And then we do the north portal to detach the coracoid from the pec minor from the medial side of the coracoid. You see that we are still with the scope posteriorly, looking with a 70-degree scope. Then we put a needle to make sure we are really tangent to the coracoid process. And using a motorized rasp, we make the flat surface for the coracoid here. Now, when this is done, we introduce the coracoid guide from the north portal. We still have the scope posteriorly. We didn't move the scope at all. We are about 45 degrees inclined, and we arrive in the undersurface of the coracoid process. Using a PDS, we make a shadow. This is going to allow us to bring the 4 strand of suture, white suture, with the peg button from the north through the coracoid process. Then we have suture management. We retrieve the blue suture to the south and the white suture to the north before we do the osteotomy of the coracoid process. When this is done, we can start the glenoid preparation and drilling. So first we detach the labrum and the capsule at 3 o'clock, and from there we go down at 4 and 5 o'clock. Once again, the scope is still posterior. We never changed the position of the scope since the beginning because of the 70-degree angle scope. We put 2 anchors, suture anchors, one at 5 o'clock, one at 3 o'clock, and then we introduce the guide, the glenoid guide from posterior to anterior, so we switch the scope entirely. This is a guide very similar to what we were using when we were doing knee surgery. And we are sure that we're going to be parallel to the glenoid surface, and we are sure that we're going to be safe, away from the brachial plexus. So this has solved 2 problems, the safety and the accuracy. You can remove then the glenoid guide, and keeping the track with the half pipe, you introduce the subscap spreader. You go under the labrum at 4 o'clock, you push 1 centimeter through the subscap. Then you bring your scope on the west portal, you look from the anterior to posterior, you make a bursectomy of the subscapularis here with the shaver. You see your subscapularis. You're looking here for your 3 sisters. Here they are. You follow the superior border of your 3 sisters, and you find the 2 brothers, the 2 nerves. You put the nerve protector, and then you push further your posterior spreader from posterior to anterior, and you open it. You can continue the split of the subscapularis tendon and muscle here. Of course, you don't touch the capsule because you're going to use it for the Bankart repair. You introduce 45 degrees angle your long half pipe to the transpectoral portal. This allows you to bring the anterior spreader, and this anterior spreader is very important because it's going to protect you from the brachial plexus. Then you can connect from the nose portal the suture and the coracoid process itself. You play with the spreader to increase the space here. You pull on the suture posteriorly, and you bring the bone block inside the joint between the window of your muscle. Now, you put the posterior button, which is a single hole button. You tie the knee knot, very simple, half inch, and you go through the half inch with the 2 strands of suture. You're going to pull on the suture posteriorly, which is going to bring the button posteriorly against the neck of the scapula. And then you control the rotation of your bone block, of course, and then you can use the tensioner. And as I said, you're going to use 3 times 100 Newton to make sure you put really compression. You can see that it's really flush. It's never overhanging. And once you're happy, you can finish the procedure by tying the suture of your anchors at 3 o'clock and 5 o'clock and make a Bankart repair so that the bone block becomes extra articular. Looking from the front, you see the posterior bone block through the subscap, 2/3, 1/3, you don't have to worry, it's automatic positioning, and you can see the effect here. The only thing you have to do is to put your arm 2 weeks in neutral rotation, not in internal rotation, in order to not limit the external rotation. So basically this is what you want to obtain, and why we like this technique. It's because it's reproducible. We can teach it to the fellows because there is no risk for the brachial plexus because we are drilling from posterior to anterior, number 1. And number 2, we are sure to be accurate. You see the axillary nerve and the musculocutaneous nerve are protected by the anterior spreader. And we have done now almost 1,000 cases and it's really very, very safe. Because it's a guided technique, there is a matching between the coracoid and the glenoid drilling, which makes the positioning very easy. And we have published our results. The positioning is below the equator, it's flush to the glenoid. And this is what you get at 2 weeks, and this is what you get at 6 weeks. So you see, we started many years ago, almost 15 years ago, we published the technique with the glenoid guide to be sure we are safe and accurate. We published the results with the buttons, suture buttons, in 2016, 2019. 2 years ago, we published the 10 years results. We published the use of 4 or 2 buttons, and there is no need to put 4 buttons. 2 buttons is enough. And that's the long-term follow-up, as you can see, with a very high rate of bone block healing and a high rate of return to spawn and a very low rate of recurrence. So in summary, the guided surgical approach improves the safety and the accuracy of the bone block positioning, and the suture button fixation is really, for us, a clear alternative to the screw fixation to avoid all the complications related to the screws with this technique, and this is what we will never come back to the screws for sure. Again, we avoid this problem of pain related to upper screw after resorption of the bone block, and it makes the procedure easier, safer, and faster than with the screws. So just to finish, I will show you that you can also use this technique open, and this is the use of suture buttons for open latarget. This is the case of a professional boxer. You see, 21 years old, he has recurrent dislocation. You see the bone loss of a 3D CT scan. And again, we do the same thing, same steps for the open or the arthroscopic latarget. So this patient has been operated on the other side with this kind of suture, but we make a smaller suture in line with the anterior border of the deltoid. It's a classical dentopectoral approach, because I know that not many surgeons are doing arthroscopic latarget at the moment. I think it's not a problem to do it open, but I think what is important is to realize that all the complications with the latarget procedure are related to the screw. And if you can avoid using the screws, I mean, you prevent and you avoid all these complications. So When we do an open latarget, we like to go medial to the vein, cephalic vein, as you can see. We just split the space between the pec major and the deltoid. We cauterize the branches of the cephalic vein, superiorly, inferiorly. We look for the coracoid process. We put a retractor over the coracoid process. We look for the conjugate tendon. We go as far as we go distally. Here you have a branch that you need to cauterize. Here is the bursa here that you remove. You see the coracoid process, it's the left shoulder. We put the Hohmann retractor over the coracoid process. And what we're going to do now is to make the bursectomy, to see clearly the CL ligament. So we go lateral to the conjugate tendon, the white bar and the red bar of the conjugate tendon here. And what we do is that we put the arm in AB deduction. Why? Because we want to reach the acromion laterally. We go above the CL ligament, we put a small curved Hohmann retractor here, because we're going to harvest the CL ligament to reinforce the capsule. So we go until we reach the acromion here, and we detach, after placing a fork retractor under the acromion, we detach all the CL ligament from the acromion here. We keep now the arm in AD deduction and flexion of the elbow to relax the conjugate tendon, and we detach the pec minor from the middle side of the coracoid. We go medial here. We put the fork retractor medially under the coracoid process, and using a 90 degrees angle saw, we make the osteotomy of the coracoid process. When this is done, we put the arm in full external rotation, and holding the coracoid bone block, we detach all the fibrous tissue here, including the coracohumeral ligament. And we go 1 centimeter distal to the tip of the coracoid, no more. We don't want to kill the branches of the musculocutaneous nerve. We remove the fat tissue under the CL ligament here. We prepare the coracoid process. We make it flat using the saw again. And we prepare a cancellous bed here to heal with the glenoid neck. Here we are. It's clean, it's nice. It's 2 centimeters in length. You don't need more. There is a special grasper here that we use. And we place the center of the drilling system in the middle of the coracoid here, and it's 5 millimeters on each side of the coracoid. We drill from underneath, and what we do is that, as you can see, we keep the CL ligament. Now we can put the self-retractor to expose the glenoid with the arm in full external rotation. We look for the musculotendinous junction of the subscapularis. You see the anterior axillary muscle, the 3 sisters inferiorly. We make the split here, 2/3, 1/3. We use the scissors. We open the legs of the scissors, and exactly like we did under arthroscopy, we make the split of the subscapularis. We don't kill the capsule, we keep the capsule here. And this is what we do here. We keep the legs of the scissors open, and we put a wet sponge between the legs of the scissors to expose the glenoid neck. There is a suture on this sponge, of course. We don't want to forget it at the end of the procedure. Then we put a curved Gelb-B retractor to expose the glenoid. We put a fork retractor on the neck of the scapula on the wet sponge, and you can see the nice exposure of the glenoid. Before we do the capsulotomy, horizontal capsulotomy, we place 2 sutures, one superior, one inferior. And with the arm in full external rotation, we make an horizontal capsulotomy. We remove the self-retractor here. We put the Fukuda retractor inside the joint. We put the fork retractor on the glenoid neck. And what we're going to do now is to detach the labrum from the glenoid rim here. And we're going to remove the piece of bone. There is a fragment here. There is a small fracture that we need to remove. So we keep the labrum. We don't remove the labrum. First, we expose the glenoid by putting a Steinmann pin superiorly. And going at the level of the neck of the glenoid, we detach the piece of bone here, and we keep the labrum. You can see here with the rongeur, we remove the bone fragment. We re-expose the glenoid with the fork retractor here. And you can use a burr or you can use an osteotome to prepare the neck of the scapula. And what you want is a fresh, flat surface here to put the bone block in place. There is nice exposure here, you can see. Now, before we do anything, we're going to put exactly like we do under arthroscopy, 2 anchors, one at 5 o'clock and one at 3 o'clock. So this will be used to make the Bankart repair, but this also gives us the location at 4 o'clock for the bone block. So now we use this kind of offset guide, and I always use the 8mm offset guide because I want to be sure that I'm going to be medial or flush, but never lateral. Whatever the size of the coracoid, it doesn't matter. You put the guide like this on the splenoid surface, and here you bring from anterior to posterior, trying to be as much parallel as you can. You make a small incision posteriorly, and here we're going to show the technique where you tension anteriorly, but I think you can tension posteriorly. It's easier and more in the axis of the loads that you want to create. So here we put the button posteriorly, again the neck of the scapula. You can almost lift up the patient from the table, and then we're going to pass the suture through the coracoid process. Once again, we're going to put the anterior button here, and when this is done, we can tie the Nis knot anteriorly. So it's a half inch, and you pass the free strands in the loop, which gives you a sliding locking knot, going mainly in one direction and not in the other one, so it doesn't back up. You don't forget to remove your wet sponge from inside the joint because you have a suture. And now by just tying the knot, you can use a knot pusher, you bring the bone block inside the joint. And you're going to use the same thing with knot tensioner here from the front, but again, as I said, I think it's maybe easier for people to use it from the back. You make sure you're flush or slightly medial, and you do the same thing 3 times 100 Newton to make sure you have good compression of the bone block. As you can see here, we are perfectly flush. And you still have the C ligament in place here that you're going to use later on to reinforce the capsule. And you are at 4 o'clock. When this is done, you're going to tie 3 knots to lock the construct definitively. As you see, I make sure I have good compression. And we tie the surgeon's knot here to get a definitive construct, a solid construct here. So now we're going to make the labrum repair. We use our suture anchors. The one at 5 o'clock, we go through the labrum. And the one at 3 o'clock, we're going to do a simple stitch. And by doing this, we place the bone block extra-articular. Again, you can use a knot pusher like under arthroscopy, or you can use your finger, it doesn't matter. And now that the labrum is reattached and the capsule reattached, you're going to close the joint. So you remove your self-retractor, you put again you put a retractor, you place your self-retractor, and what you're going to do is that you're going to close the horizontal capsulotomy that you've done. So you don't limit at all the external rotation because you didn't do a vertical capsulotomy, but an horizontal capsulotomy with the arm in full external rotation. And now, if you want, you can use your CL ligament, your coracohumeral ligament, to reinforce your capsule. Once again, full external rotation when you do that in order to avoid any limitation of the motion. This is done. You don't close the subcap. You can see the brachial plexus is there, very close from the collagen tendon, and you see the sling effect in this case. And you see, again, don't put your arm in internal rotation after the surgery, only 2 weeks in neutral external rotation, and you will have no limitation of motion. And then you close the skin in a regular fashion, and you can control with X-ray and CT scan. You have the same thing under arthroscopy. Thank you for your attention.
Thank you very much. Good presentations of using the suture button in both arthroscopic and open technique. Right? We'll leave the discussions later on after Hiro's presentation. Okay. So may I invite the next speaker, our president, Professor Hiro Sugaya. He is currently the president of the Jsoa 2025. He's the president of the Tokyo Sports and Orthopedic Clinic, which he started. And he's also the clinical professor of the Department of Orthopedics of Jsoa University, as well as the professor and also instructor of the John A. Burns School of Medicine of the University of Hawaii, as well as the professor of the Department of Orthopedics, Tokyo Medical University. So today, he is going to talk about his arthroscopic iliac crest grafting using a suture pattern fixation. So, Hiro, thank you.
Thank you, Patrick. I've been doing the iliac crest grafting in the past maybe 25 hours, no, 35 years. So I have a long history of the iliac crest grafting, and I've been a screw rubber. So, but finally I changed my style from screw to Pascal pad. So that's why I will speak about my transition of technology. Okay, balance in shoulder stability is we need to think about the engaging exact region in granule. However, as we show during my lab surgery, and even if the large granule defect, sometimes the patient has good bony fragment. The endoscopic bony fragment repair works very well in this kind of situation. And what about the patient with not so active patient? Even to very small fragment, it works. However, if young and active patient, this kind of small fragment patient, bone grafting is necessary. And also, because no bony fragment, this shoulder is bone grafting is the only answer. So the bone grafting there are two different types of bone grafting: the proper transfer and also the free bone grafting. Proper transfer, we can rely on we can rely on the string effect. But free bone grafting, we need to reconstruct the capsule, because free bone grafting always need to requires capsule repair. The capsule need to be very robust and strong. So my preference arthroscopic bone grafting with capsule reconstruction is very important. By repairing capsule, we need to restore the proprioception of the granular joint. But this is my device kit. This is not a different company. It comes from a different company. This is a device for graft introduction to the joint from the rotalinable, and this is a screw insertion system. Okay, so this is my first. I started with the posterior, using the posterior approach. The eye like this, and this is a view from the anteroposterior. And the first, I inserted the suture line pair for the temporal graft fixation. So normally I introduce the graft using this big cannula, and I zip line the graft to the joint like this, and tie the suture. Then the graft is temporarily fixated. And after that, for the screw fixation. So in order to insert the screws, I make an anterior-inferior portal. This is the kind of the slalom approach to retract the conjoint tendon medially. So this is my old posterior approach, iliac crest grafting. Now I use the slalom approach to retract the conjoint tendon medially, and now this is coming through the subscus muscle, and now I introduce the screw to the graft. This is my posterior approach. So posterior approach, the bone resorption in the graft position is very, very important. The bone resorption occurs after surgery, and also we can expect a remodeling as well. But it's very difficult because the screw angle compared to the granular surface line, the screw need to be a little bit perpendicular to the ground. So that's why this is a problem. So the screw angle to perpendicular, and the stress also because of the bone resorption, stress shielding by screws that cause bone resorption. So that's why this is problematic. So then I changed the posterior approach to anterior approach using suicide portal, way medium portal. And also graft harvested triple bones harvested from iliac crest. And I made this kind of hole, small hole, for granular screw, and this is for temporal graft fixation hole. Okay, so for anterior approach, I use a normally posterior anterior under suprapolar. In addition to this, I use an anterolateral polar and a posterolateral polar, and also a suicide polar. So this is my anterior approach when we ear grafting. So I release the soft tissue exactly the same way in the posterior approach. And now graft is introduced from the rotator ball using this big cannula. It's a blind graft. By tying the suture, graft is temporarily fixated. This is a view from the underball. Now I clean up the bursa space, and now scope is anterolateral portal and the viewing from the anterolateral portal. So this is graft inside the joint. And so the stick, the long stick is introduced through the subscap muscle and created the suicide portal. And now the screw is coming from suicide portal. So now we can make a little bit close to parallel screw insertion. This is after capsular reconstruction. So we published the papers a long time outcome study in 2021 and journal arthroscopy. This is the minimum 5-year follow-up study. We had from 2007 to 2014, we had 48 patients underwent the index surgery. This is including the posterior approach and also the anterior approach. The 20 were followed for the 1 or 5 years, and the mean for time was 8 years, and the mean age at the time of surgery was 30 years. Okay, so the bone resorption is the, some shoulder, the shoulder showed excellent bone resorption, good remodeling, and however, the very poor screw exposure was seen in the 3 shoulders. So this is poor cases. And also arthritic changes issue because of the use of screw. So preoperatively, the arthritis grade is like this, but postoperatively, like 5 years after surgery, grade increases like this. So that's why this is the outcome after the ear grafting by screw. Okay, so the Pascal published the papers and back in 2019, graft healing rate was 95%, and 93% return to scores, and only 3% failure. So that's why I followed my friend's way technique. So first I applied the Radage, 45 years old division case with huge capsular tear. So that's why I cannot perform capsular labor reconstruction. So that's why I did Radage, arthroscopic, and using one button. So I couldn't use the spreader nicely, so that's why it's a little bit in trouble to introduce the go through the subscap muscle. But I think this is acceptable. This is after surgery. The 3D CT after surgery is like this. So I think the little bit the graft angle is a little bit not the perfect ideal, but I think it's acceptable. Okay, so the arthroscopic bone work procedure, if we use screws, we need to use the suicide portal, but if I change to suture button suture system, then I need to create the suicide portal, and also no need to these portals. So this is very simple. Instead of this, I use one more medial posterior portal. Okay, so this is the Chris Grafting, 30 years old, competitive judo athlete, first time dislocation during the judo back in 2014. And since then, more than 10 dislocation experience he has. He has active patient, the primary size is kind of borderline, but I decided to do ear Chris Grafting in this case. And video, this is arthroscopic video. So I exposed the antigranon exactly the same way using when I was using screw. And this is Pascal's system. And the graft is introduced through the rotary interval, same cannula, big cannula. And suture time is performed posteriorly. And now the graft is very, stable. So I love this technique because I can use it in many portals. So after this, of course I perform the capsule label reconstruction. This is the 3D CT after surgery. I think the graft position is good. And 6 months after surgery, the little bit resorption happened, but I think it's very good. 1 year after surgery, the resorption a little bit progressed, but I think this is acceptable. So that's why I prefer to do this right now. And case number 2 is a 15-year-old girl. The right shoulder dislocation happened by softball throw. After that, 4 times dislocation. So that's why she underwent arthroscopic stabilization in a different hospital, by a different doctor, in February 2023. 6 months later, she fell without major trauma. And after that, after this event, she had 3 additional dislocations. So she was referred to Jsoa in March 2024. And imagine demonstrate like this. The little bit bone loss is a little bit severe, but I was hesitated to perform bone grafting because she's only 15 years old girl. So that's why I performed arthroscopic revision using soft stabilization technique using banker and interval closure. But she had not dislocated after revision, but she complained of continuous pain because of this bone loss progresses. So that's why human head stays always under inferior position. So that's why she's painful. So that's why I decided to perform the breast grafting in this case. So this is after surgery. So I make, instead of using posterior portal in case, I use a little bit superior, right below the acromion to obtain a good angle for the graft because the bone loss excavation is a little bit different. So I think right after surgery it's very good. And now she's 6 months after the surgery, so bone resorption also occurs, but still, I think the bone graft remains, and I think that she's now symptom-free. So she's very happy. Okay, so my take-home messages in arthroscopic bone grafting is the surgical indication is limited. However, the excellent stability can be promised. And the bone resorption, probably due to stress shielding and athletic change by using screws are concerned in the long term. And also, therefore, there may be the use of suture pattern can be a future choice. Thank you for your attention.
Thank you very much. Next, so may I invite both Pascal and Hiro to be here on stage so that we can discuss further. Okay, so we still have about 20 minutes. Okay, let's see if there's any questions from the audience. Any questions from the audience? Maybe I can start first, right? Okay, so we changed from screws to suture button, right? I think one of the advantages is that we are afraid of because of stress shielding, the bone resorption, right? But did it happen in your experience on having bone resorptions after using suture button? And how do you deal with that?
Of course, bone resorption occurs after all kind of bone graft, iliac crest bone graft, coracoid process, allograft, because of the valve slope. I mean, there is no or very little loads on the upper part of the glenoid, so there is a reshaping of the bone block anyway. In case of coracoid transfer, also the vascularization of the bone graft is coming from the coinbone tendon. So the more you go proximal, the less vascularization you have. So it's both a biomechanical reason and a biologic reason. It's for bone resorption. And regarding the use of suture button, I think there may be less. I didn't make a study to compare screw versus suture button in terms of bone resorption. But what I observed is that there is no need for 4 buttons because it will be exactly like with the screw. The upper buttons will be floating in the air without any bone underneath, so that's not needed. And even the rotation of the bone block is not a problem. Once you put compression, I mean, the rotation is controlled. So for me, it's 2 buttons, one in the front, one in the back, and no need for 4 buttons.
Thank you. So here, do you have experience of using suture button and then, bone resorption early usually before it heals?
Actually, I studied it only 1 year ago. So that's why I don't have enough experience of suture button bone resorption. But when I was using screws, that was a serious problem. The 6 months after surgery, I routinely take CT scan. And maybe sometimes 70–80% of bone is gone. That's good.
What is very interesting in your presentation is that although you came from the transpectoral medial portal, what you call the suicide portal, it was very difficult to be strictly parallel with the screws with the anterior approach. And that's why I developed the posterior drilling, because then you're sure, if you use a guide, to be parallel to the glenoid surface, number 1, and number 2, you're safe, because you just drill inside the joint and you're not in contact with the brachial plexus. So I think that progressively people understand why it's very useful to drill from posterior to anterior to glenoid.
Agreed. Okay, thank you. So, any questions from the spectators, audience? Yeah, over there at the back.
I have one question. How did you decide that 100 Newton? So I mean the bone quality is different in person.
The tensioning, yeah.
It's a good question. Just I didn't know how much to put, so I asked the Smith and a few people to give me 100 newtons like this, because we had to start at some point. Because at first, as I showed this morning, I was tying the suture with my hands, with an out pressure. So you cannot know how much you put tension when you tie knots with your hands. So we started with 100 newton because we didn't know if we will break the suture or if we will make a fracture of the coracoid. But it appears that 100 newton was a good start, but it was not enough. Because you need to put compression, not only to tie the knot with the tensioner, not only to remove the gripping, the elasticity of the suture, but you need to really get compression. And in fact, when you do a coracoid transfer, you must realize that the pulling of the conjoint tendon is orthogonal to the bone block. It's not vertical, it's horizontal. And the more external rotation you put, the more subscapularis muscle you have under the conjoint tendon, and the more it pulls the bone block away from the glenoid. So you really need to immobilize the construct, and for that, with experience, I've ended up with 3 times 100 newtons, so altogether it's probably 300 newtons, because I want to immobilize really the bone block and to have a good compression. But it's purely by experience, by trial and errors.
Okay. Jsoa, okay.
My question is to you, Pascal, exactly about this 2-button, 4-button thing. A lot of us use 4 buttons because we feel that when the healing is going to take place, there's going to be some amount of cancellous bone collapse. And if you've got just 2 buttons and you've got a conjoint tendon there where you've already started rehab, it may cause some rotational shift in that. And I see in your study that that doesn't happen. Is that because you've got 2 surfaces that are so plain and that's giving it that secondary stability, or what's giving it that rotational stability? Because the compression can't be giving it rotational stability.
First of all, it's not true that it never happens. In medicine and in surgery, there is no always or never. And it can happen, but if it happens, it has no influence at all on the results, on the clinical results, on the stability of the shoulder, on the pain or whatever. But again, with experience, by really immobilizing the bone block by compression, by suture tensioning, we don't observe anymore any rotation of the bone block today. Again, people were asking me all the time, why don't you put 4 buttons? So I did a study, I published it. I mean, there was no benefits in terms of positioning of the bone block, no benefits in terms of healing of the bone block. And the drawback was that it lengthened the procedure by 20 minutes because of the suture management, drilling, etc. So it's already a complex procedure, it's already a difficult procedure. I don't see any need to make it more complex and longer. So I think two buttons, one in the front, one in the back is enough.
Now, one more question to that. So normally when we take the coracoid, because you're so used to that 2 screw and then 2 button, we're taking 22 to 25 millimeters of the coracoid. I see that you're taking your coracoid a little smaller. Is that important? Should we be doing a single button with a 22 millimeter coracoid, or should we actually decrease that coracoid size to 18 or 20 if we're using a single button?
Yeah, it's a good point. That's another question that I get all the time. Your bone block is too small, it's smaller than what we used to. No, I take 20 millimeters. If you take more you can, but everything will resolve anyway. So I don't see any need to take a long bone graft to at the end up with the same amount of bone, because it's a recreation of the pear shape of the glenoid that we are looking for.
Thank you.
So 20 millimeter, whatever the size of the patient, is more than we need. And in addition, I can tell you that I have also a large experience with the Bristow procedure. And the Bristow procedure, because you put the bone block vertical, it's only 15 millimeter in width. And the results are exactly the same with the Bristow and the Latargia. Same result in terms of clinics and radiological.
So Pascal, do you think that this is probably because of the sling effect, even way more?
Of course, as we know, the sling effect is 70% of the procedure, so it was the same. And again, what we need is bone at 4 or 5 o'clock, between 3 and 5 o'clock, but no more. Above 3 o'clock is useless.
Okay, that gentleman first, and then followed by you, okay?
Okay, I want to ask about the disadvantage of the button and the advantage of the screw. So most of you will not return to the screw fixation anymore. Or in some case, you can use the screw fixation.
I quit using screws in the shoulder more than 15 years ago. Never used a screw. I just want to come back to the design of the anterior button. You know, it's a peg button, and there is a reason for that. Because when I started, I used a regular endo button from Smith & Nephew, which are rectangular, so they were not really adapted to this procedure. And what happened is that when I started to use the suture tensioner, in some cases I was putting a lot of tension on the suture, and then what happened is that the anterior button was sliding on the side of the bone block, and then the suture was cutting through the bone. So I have to solve this problem, and that's where I get the idea of doing a peg button. But now you can put any tension you want. It will compress, but it will not sew through the bone. So it's a little detail in the design of the button, but I think it's a very important point. And we see now many companies are copying our system, and they don't understand why there is a peg button in the front. But there is a clear reason. It's because otherwise you can have a sewing effect of the suture through the bone. And actually, Arthrex has developed a system without any button, just with sutures. And what I heard from colleagues who use this system is that, in fact, it's cutting through the bone. And they stopped using it because of that. So I think the spread of the loads given by the anterior button is very important. And the fact that there is a peg, it makes a central compression and no possibility to slide on each side of the bone block.
So here, answer?
Thanks to Pascal. So that's why Pascal's systems are perfect. So that's why I love to use that now. I changed 1 year ago, but I don't want to go back. Because the surgery is very different, totally different, very simple.
Thank you. So, questions?
My name is Desmori, so I have a question for the Dr. Pascal. So please let me know that
you indicate open latarjet. I think the severe bone loss may be the indicator for the open cortical latarjet. Is that true?
You mean the indication for the open latarjet?
Yes,
versus
open.
arthroscopic in your hands.
So you different.
Actually, I do everything under arthroscopy. I just did a video for the teaching purpose. But I think it's a very important point because the arthroscopic latarjet is a complex and difficult procedure. So my recommendation is that if you don't have 20 to 30 cases per year, you don't have enough experience, enough skills to do the arthroscopic latarjet. If you do less than 20 cases per year, I recommend to do open latarjet, but to use buttons instead of screws. There is no problem to do an open latarjet. It's a nice technique. But I think, as you know, all the complications with the latarjet procedure are related to the screw. So if you can avoid using screws and try the suture button system, at least you get used to it. And later, when you will have more patients, more recruitment, then you can switch progressively to the latarjet, arthroscopic latarjet. For instance, you can start doing the coracoid process preparation under arthroscopy, then you open. Next time you do the glenoid preparation under arthroscopy, then you open, etc., etc. There is a transition from open to arthroscopic latarjet. I think it's not fair to say just do the arthroscopic latarjet and you will see it works. You need some really a lot of experience, I mean a lot of patience to make sure that every week or every month you do a certain number of cases to get the skills. And there is no problem to open and to do an open latarjet. The problem is the screw. The problem is not the skin incision.
Thank you.
Okay, thank you. 30% bone loss is indicated for the arthroscopic latarjet.
30% bone loss, yes.
30% or over 30% is arthroscopic latarjet.
I think so.
Thank you so much.
Thank you. Thank you for the questions. Any other questions?
Thank you for the very good lecture. And I'm Ito Igawa from Juntendo University Hospital. So I want to ask about granule fracture and fresh granule fracture. Sometimes I use your system and button, so I fix the fragment. So recently, very good. Actually, the first time, so the granule bone toner is very good, reaction very good. But finally, tensional stage, 100 Newton. At the time, the fragment was broken. So after that, I choose a manual marks, the tensioner. If you perform the fresh granule fracture, so how much Newton of the tensioner?
Yeah, I think the buttons is a very good system for glenoid fracture, but also it depends on the size of the glenoid fragment. If it's a small fragment, of course,
a large fragment, more than
there is a risk of having a fracture of the bone block.
Yeah.
Also, it depends if you go under the labrum to fix your glenoid fracture or over the labrum.
Over the labrum.
I recommend to go over the labrum to keep the capsule, to make this just a slot here, and then to drill from posterior to anterior through the glenoid and through the bone block. And then, of course, be careful to not overtension because it's a fresh fracture, so it's true that it's not as big as a coracoid fragment, and it's fresh, it can be fragile. So you can use the tensioner, but you must watch clearly what you're doing and make sure you don't impact the bone block, the button through the bone.
Depend on patient, right?
Glenoid fragment, yeah.
Okay. Thank you.
Thank you very much.
A surgeon in Germany, Wafsad, has a huge experience with glenoid fractures, and he has published his results. I don't know if you read his article. He published the results with the use of suture buttons for glenoid fractures.
Thank you. So, any other questions? We still have a few minutes. Well, I saw a lot of friends here, right? A lot of shoulder surgeons here. Can we have a show of hands? How many of you, first of all, are you doing bone grafting or latarjet procedure? So, a lot, right? So how many of you are using screws at the moment? Okay. How many of you are using screws or button? Well, because sometimes you do screws, some of buttons. And how many of you just doing buttons? Okay. So majority is still screws, but changing over to button. Right? Hopefully. Yeah. So, well, I think we are gradually learning and improving, right? Today we've seen the two giants showing their techniques of using scissor button to fix this, to augment this bone grafting or lateral jet procedure. I'm pretty sure, well, later on probably some of the people will do some research on answering some of the questions that we raised out, right? For example, 2 buttons or 4 buttons, or the tensioning, is it 100 Newton or 150 Newton, and so on and so on. So, but today I think we can indeed take a lot of message from both of you. Thank you very much. Shall we join me to give a big round of applause to the both speakers? Thank you very much. Thank you.
I'm entering. Finally. Oh, what are you doing? You just alive. かなり患者さん来てるんですか？かなり。カメラで10件ぐらいその時にどんどん外傷、右の靭帯とかはやりますけど、肩も外傷もどんなしで、じゃあ野球選手も多い。いやでもまあ1年でだいぶ増えました。そうですね。進行していってくれて。徐々にね、お久しぶりです。お久しぶり。頑張ってやってください。
Receive Dr. Gerald Williams from USA. From yesterday, I received many. You drive? I don't. Taxi. Free taxi. I don't. No idea. Me too. No clue. You drive? No, nothing. Bicycle? No. Walking. Roll? Walking. Friendバイクじゃない。後ろに。セットバック。Oh my god. ห้องหนึ่งตอนนี้ยังอยู่ห้องหนึ่งเลยอาจารย์ครับครับได้ครับครับได้
食べないと外人2人は食べない。食べない。うん。
attending the Japan Sports Orthopedic Association 2025. The next program will begin at 1:10 p.m. Please refrain from taking photos or recording audio or video during the session. We appreciate your patience as we prepare to begin. Thank you. Thank you for your patience. We will now begin Special Lecture 1. This session will be moderated by Dr. Hiroyuki Sugaya. Dr. Suraya, please begin the session.
Good afternoon, everybody. So this is one of the most important session in this meeting. Actually, I invited two supergiant, Japanese supergiant. One is a knee giant, the other is a shoulder giant. I asked them to speak their life with shoulder and knees. So that's why it's very important. So the first speaker is the knee giant, Professor Concession. So he will speak about, maybe no introduction is necessary. So he will speak about my lifetime struggle with Asia. Please, Dr. Shino.
Thank you. So, please see these two pictures. One is the reconstructed graph with the BTB 13 years ago. And the right side is the healed ACL by new conservative treatment. Please note, two anterior cruciates are very close in terms of direction or tautness. You like this? No? Otherwise, I have to quit. Okay? So today, I have three topics. One, introduction literature review. So, look at this guy's knee on the left side, right side. You see some shift, right? Reduce. Drastic reduction, okay? So this video shows anterior dislocation and reduction. Agree? So ACL injury is not just an injury, but results of the anterior dislocation of the knee followed by reduction. In the olden days, the treatment of acute were primary repair was advocated by American famous great Don O'Donoghue. Don is a very great name, okay? The guy told us that the results are so excellent and most of all the people could go back to the football or something like that. But later on, 26 years later, the results are denied by John Fagan. Regarding treatment of chronics, this kind of ACLR, using a pellicle BTB graft, Ken Jones was the author. Femoral tunnel is created in the entrance of the nose. Entrance, okay? No tibial tunnel. So the graph is displayed on the right side, totally different from normal ACL. But remember, the guy told us 11 cases have been operated on successfully. No patient had a feeling of knee instability. All patients had a normal gait and all knees were completely stable. Could you believe that? I don't believe that. He must be a liar. Okay? Then the other concept of rotatory instability or RI came in by cruciate unbelievers. Cruciate unbelievers. Cruciate means anterior cruciate. This concept was led by Jack Houston, founder of AJSM. So after the anterior cruciate level is gone, two kinds of rotatory instability should be a problem. Anterolateral and anteromedial. All right. This RI leads to actual functional disability. The guy told us, not ACL reconstruction, but capsular peripheral procedures are more efficient to control RI. The guy told us. So this kind of extraarticular leap were very popular among those days. I tried one of them. Useless. Useless! Okay. On the medial side, medial extraarticular procedure are advocated by, again, American great, Don O'Donoghue. The medial capsule is dissected from the tibia and advanced distally like this. Surprisingly, total medial mastectomy was always performed along with this procedure. Total, okay? Patients were crying, I believe. But this is the American great guy's work. Disaster. So, due to Japanese American primary care, non-technical ACL, LE or ME, they should be gone to the garbage can. It's used as a kind of garbage. But at least we could get one effective lesson. ACL could be a solution. Actually, at this moment, 175,000 ACLRs are performed per year in the United States. So I have to make a journey to the seeking for the best ACLR. First, graft choice. There are three options, but I'm a strong supporter for BTB. BTB features 33 square millimeters of cross-sectional area is 80% of the ACL, a little bit thinner compared to ACL. Rectangular cross-section is very close to ACL. Maximum failure load of BTB is a little bit higher compared to ACL, a little bit higher. Fortunately, the graft has bone plugs on both ends. This means strain distribution within the graft is well organized, as the tension is applied via the bone plugs, not soft tissue, so not by suturing, bone plugs. Looking at strain distribution at the time of anterior drawer, the strain becomes higher approaching the insertion site, like this. This is the normal anterior cruciate ligament. So BTB graft is very close to ACL in terms of strain distribution and at the time of anterior draw. Very similar. I'm afraid this moves or not. Oh, moves. So, looking at the graft behavior around femoral tunnel, the BTB graft looks very stable. But if, in this case, the hamstring graft, the graft moves and the void is left behind the graft inside the tunnel. You see? Void. Which one do you like? I'm a fan of the BTB. BTB! Okay? So, BTB is very stable. So, let's move to the graft placement. Last year, I was totally surprised to see this picture in the SNS.
this doctor told us that this is his champion graph throughout his life. The second look was done due to failure of medial menstrual repair. But the guy told, this is a very gorgeous graph throughout his life. You know? You like this? To me, no. No. Compare this graph to the normal ASL, totally different in terms of direction or tautness. You know, vertical and slightly slack. I would say this is a kind of failure. Then one more surprise I got in the recent years, this article regarding acceptable ACL terms in the United States. In the tibial side, this red round portion is acceptable, I agree. But the femoral side, everywhere in the lateral wall of the notch is the acceptable. Everywhere. You can go anywhere you want. This means malpositioning is prevalent in the United States, at least in the United States. Thus, we performed this kind of histological study on femoral attachment area. These oblique axial sections were made to obtain this kind of histological slices. Please note, ligament attaches rear posterior part of the wall of the notch. Rear posterior, okay? Far posterior. So these slices, with these slices, we could get this kind of schema for the ACL femoral attachment on the 3D picture. The pinkish area is the femoral attachment site. This concave area is surrounded by several bony landmarks, including resonance ridge, apex of posterior cartilage, and posterior cartilage margin. So, I believe that the femoral tunnel should be located in this kind of attachment area like this. This area is located behind the resonance ridge. With the similar methodology, the tibial attachment site was defined like this. This is a boot-like attachment, very unique shape. This concave area is also surrounded by bony landmarks. Central intercondylar ridge, medial intercondylar ridge, and anterior ridge. Finally, the surgical procedure. US standard ACL reconstruction with a BTP graph is shown in this picture. Just published in the year of 2025. This technique may be called isometric round tunnel IRT procedure, in which isometric single bundle is reconstructed via round tunnels. But I'm afraid there's an issue for BTP grafting in the round tunnel SERR. So, due to length mismatch between the graft and SL itself, some area has this kind of void between the graft and the tunnel wall. So I developed this technique to minimize this kind of void in the technique. So rectangular tunnel, then the rectangular shaped graft, then this voidage could be minimized. I also try to optimize BDB graph to mimic the fiber arrangement inside the native ACL. Looking at the fiber orientation inside the ACL, superior position of the fiber attached to the anterior portion of the tibial attachment. The inferior portion of the femoral attachment goes to the posterior part of the tibial attachment. If we create a rectangular tunnel like this, then we could fairly mimic the fiber arrangement inside the native ACL. So it may be called multi-bundle grafting concept with a single bundle, with a single BDB graft. So this is the schema I developed to mimic the normal ACL with a BDB graph, anatomical rectangular tunnel or ART technique. So the BDB graph, 10 millimeter wide, is harvested, and this is the graph. So different way of grafting compared to the United States. So this may be called ART procedure, in which anatomical grafting or multiple grafting concept is realized via rectangular tunnels. We made a biomechanical study to compare these two techniques between IRT and ART. This slide shows the difference in terms of location of femoral tunnels between the two techniques. IRT is higher and ART is lower or anatomical. The robotic simulator was used to perform this experiment. Then the last image pretension or LMP is used. This means graft tension to restore normal stability is used as a parameter for graft biomechanical performance. If the LMP is lower, the graft biomechanical performance is higher. Here's the result. ART is much lower in terms of LMP compared to IRT. This means ART is much more efficient in terms of biomechanical performance compared to IRT. This is the actual tunnel in the patient. Femoral tunnel has created real far back in the notch. Tibial tunnel, much more anterior compared to the American way, but this is the tunnel I created. Looking at the behavior of the graft, there is no impingement to the PCL or notch. Remember, there is no notch plasty was added. After graft is introduced, the in situ pretensioning is done by this, like this. Then the fixation is finalized under the tension of 10 to 20 newtons, very low tension. Results, there's very few results are very consistent, not 100%, but very high in terms of success rate and very few outliers. So success rate is very, very high. Remember, there's no leap. But I'm sorry that there's a flaw in this technique, you know. In the left side, the ACL has 3 bundles, AMM, AML, and PL. But graft has just 2 bundles. One bundle is missing. This is the MRI shows the missed AML. But I was totally surprised. At the time of grafting, there's a AML is missed. But several months later, regenerate. I don't find any reasons of this kind of regeneration, but that's the fact. Not alternate fact, just fact, real fact, genuine fact, not alternate. So very close to ACL, very close. MRI also showed the regenerative AML as well. Distinct fiber. So, lessons I learned from this journey. BDB graft in ART ACLR not only restores the morphology but simulate the biomechanical performance of the native ACL. ART ACLR with BDB graft consistently results in good outcomes without bleed. Final topics. So, to share the new approach on conservative treatment. There is a consensus that the stumps are absorbed in weeks and leading to ACL deficient knee on the right side. This is the consensus, still consensus. Looking at the biological environment around the injured ACL, they say degradative environment. So it was believed that there was no room for conservative treatment of acute ACL injury. Looking at the biomechanical environment around the ACL is loaded at standing due to posterior tibial slope like this. If the heel, but remember the ACL is more loaded at the time the heel strike as well, due to increased PTS. However, if the toe touch gait is done, then the posterior tibial slope is decreased and resulting in reduction of ACL load as well. Tibial slope control treatment or strategy was developed to protect ACL grafts at the time of walking in the early phase after ACL. Soft knee brace and heel wedge to induce toe touch gait without restricted range of motion. So PTS decreased like this. I hypothesize TST treatment may protect the injured ACL, leading to healing. This guy came visited me with this picture a couple of years ago. ACL torn near the femoral attachment. TSC treatment was applied in the waiting period of ACL. At that time, I didn't think it will heal. But several weeks later, Lachman sign turned to converted to negative. I took MRI, so then, some healing, significant healing, just 5 weeks. So TST treatment was continued by 3 months. The guy returned to rugby football at 9 months post-injury. No problem. Follow-up MRI. Very good healing, I believe. You know, you like this? Totally it looks normal. Next case. Again, rugby football player, 70 years old. You appreciate the trauma ACL very clearly, right? Very clearly. Furthermore, that I have a ramp region of the medial meniscus. This is the follow-up MRI. ACL. Totally healed. Medial meniscus also healed. No problem. Without any difficulty. He's playing rugby football at home. Preliminary outcome of TSC treatment on these patients. If the patient has no anterior subluxation at the time of the injury, then healing rate will be more than 80% in my current practice. I was totally surprised. So, lessons learned from this approach. Healing potential of the injured ACL is much higher than we thought. Much higher. Proper protection, not overprotection or underprotection is the key. But proper, very difficult to identify. So the last message, let's keep learning. Just simple. But not from the grades or notables in the United States, but from what you see. Very important. Thank you for your attention.
Great talk. Thank you very much. So the time is limited, so I will move on to the next speaker. The next speaker is, of course, everybody knows, the shoulder giant, Professor A.G. Toy. He's going to speak about the shoulderology. This is your word, right? Yes. You created it. No. Shoulderology, searching for whys. What's up?
Good afternoon, I'm A.G. Toy. It's my great honor to be here, and thank you, Hiro, for giving me this opportunity. I'd like to share my 40 years of experience as a shoulder surgeon. My disclosures. What is shoulderology? This is a coined word of shoulder and ology, which means science. This term was first used by Slavin, an English tailor, who said in his book Shoulderology, Bustology, that the shoulder is important for men and the bust for women when tailoring clothes. When we use this term, it refers to the shoulder science, of course, but at the same time, it refers to the fascinating and mysterious world of the shoulder. And when we say shoulderology, it reflects our deep attachment to the shoulder. For example, we call Charles Neer Dr. Shoulderology. So to fully experience this fascinating world, we need to search for whys. First, let me tell you how I became a shoulder surgeon. When I became the member of Tokyo University, my boss was Professor Sakurai, who was an expert of peripheral nerve injuries, and he performed many muscle transfers for brachial plexus injuries. Because of this, he was elected as the president of Japan Shoulder Society, and 2 years before this Congress, he decided to set up the shoulder team in the department, and he invited me to the team. Well, at that time, I had no experience of the shoulder, but when the professor asked you to do something, there was no other option but to say, yes, sir. So I did. And first thing I did was to follow up the patients after muscle transfers. And we found that the shoulder function was influenced by the location of the muscle transfer. This finding sparked my interest and motivated me to delve into the world of shoulder. After finishing my thesis, I had a shoulder fellowship with Dr. Tabata, who told me everything about shoulder and patient care. In addition, he allowed me to dig into the treasure trove of clinical data. So during my 1-year fellowship, I wrote these papers, And during this process, I found many why questions. So after finishing my fellowship, I decided to go to the Mayo Clinic to find answers to these questions. At the Mayo, I was the research fellow at the Orthopedic Biomechanics Lab, and Dr. Bernie Mori, they told me a lot about shoulder biomechanics. And thanks to their support, I was able to find many answers to my questions. It's very important to ask why, because without asking, we cannot generate new ideas. We cannot clarify the truth. In fact, there are many whys all around you, but quite often you simply miss them. For example, you may say, oh, it's beautiful. Okay, let's go get some beer. That's fine, but you miss an important why question. Look at the reflection of the sun. It's in the vertical line. If the ocean surface is completely flat, then it should be a mirror image like this. If it's a little bit wavy, then the reflection should be equally dispersed in all the directions. So reflection should be something like this. But in reality, vertical line. So why is this? Well, some people say that the surface of the ocean is not completely flat, but it's convex. That makes the reflection vertical line. But do you think the surface of the water channels in Venice is convex? I don't think so. On a clear, calm day in Bruges, the reflection is a perfect mirror image. But when the wind blows, vertical line. So I just want you to think about it, because it's fun to try to solve the why questions. Of course, there are many whys in the shoulder. My first why question was this: traumatic dislocation occurs most commonly in the shoulder, and after the reduction, the shoulder is immobilized in these positions. The problem is approximately half of the patients have recurrent dislocations, no healing of IGHL. Why is this? Some thought that 3 weeks of immobilization was not long enough. They extended up to 6 weeks, but they could not reduce the recurrence rate. Others thought that the sling was not rigid enough, so they applied cast, but they could not reduce the recurrence rate. So how long or how rigid you immobilize the shoulder, you cannot change the healing rate. Then the only possible explanation would be the position of immobilization. So we took the MRI with the arm in internal rotation, anterior labrum is medially displaced, anterior capsule is away from the bone. So if we immobilize the shoulder in this position, healing cannot be expected. But with the arm in external rotation, these structures are very well reduced. So if we immobilize in this position, we may be able to reduce the recurrence rate. So in this prospective study, we compared internal versus external rotation, and this study showed that immobilization in external rotation significantly reduced the recurrence rate with the relative risk reduction of 38%. After this study, there are many RCTs reported, and the recent meta-analysis show that immobilization in external rotation is more efficient than internal rotation in reducing the recurrence rate. My second question was this: in unstable shoulders, we quite often see the bony lesions of the glenoid and the humeral head. When I went to the Mayo Clinic, all the textbooks said that surgery was indicated when the glenoid bone loss was greater than 1/3 of the glenoid. Well, how do you know this is 1/3? What about this? When you say 1/3, you're just eyeballing the size. It's not scientific. If you don't measure precisely, we cannot discuss surgical indication. But this 1/3 indication was widely accepted at that time. So why was this? First thing I did at the Mayo Clinic was to take the photograph of the en face view of the glenoid using dry bones. And based on these shapes, we created the average shape of the glenoid. And using this model, we created bony lesions stepwise. The question was how to quantify the bony lesion. We should avoid measuring the area because we need a certain software. The method must be simple. So we decided to measure this length, that's easy to measure, and this length is normalized by the width of the glenoid or the length of the glenoid. This way, we were able to quantify the bone loss. Now we are ready to start discussing the surgical indication, but before that, we should understand why we need to fix a bony defect. What's wrong with the glenoid bone loss? If there's a large glenoid bone loss, but if you repair the capsule, the shoulder is stable at the end range of motion because the capsule is tight, holding the head in place. But in the mid-range, capsule becomes lax, does not hold the head, then the head slips out of the socket because the socket is very shallow due to a bone loss. So the glenoid bone loss is related to the mid-range instability, which is independent of Hill-Sachs lesion. Many biomechanical and clinical studies have shown that the critical bone loss is 25% of the glenoid width, but the margin between safe and the critical zone is not clear-cut. There is a gray zone in between, known as subcritical bone loss, which varies according to the reporters, probably because of a difference in the risks of the study cohorts. What about Hill-Sachs lesion? It has nothing to do with shoulder instability in the mid-range of motion. But at the end range, if it is covered by the glenoid, it's stable. But if it is not, then another dislocation occurs. So the Hill-Sachs lesion is related to the end range instability. The risk assessment of Hill-Sachs lesion is much more complex than the glenoid because on your left is the Hill-Sachs lesion, which is stable, but the same Hill-Sachs lesion on your right is not stable anymore because of the glenoid bone loss. So the risk of Hill-Sachs lesion is dependent on the glenoid. We have to look at these lesions together. All the previous investigators searching for surgical indication look at the Hill-Sachs lesion alone. They measure the area, depth, or volume of the Hill-Sachs lesion, but none of them paid attention to the glenoid bone loss. So how can we assess these two lesions at the same time? For this purpose, we introduced the new concept, the glenoid tract. This is the cadaveric shoulder, and the glenoid is moved along the posterior end range of motion. This is the glenoid tract. This is the width of the glenoid, and this is the width of the glenoid tract. So if the Hill-Sachs lesion is here, it's an on-track lesion, which is stable. But if it is here, an off-track lesion, unstable. The question is there any difference between this and this? Both are on-track lesions, but different locations. So we divided the glenoid tract into 4 zones and compared the WOSI score. The WOSI score was significantly worse in the most medial zone. So this most medial zone, it's similar to the subcritical bone loss of the glenoid. And we call it the peripheral tract, and the rest 3/4, the central tract. Glenoid tract is a valid and well-founded framework for assessing shoulder instability. The main challenge lies in accurately identifying the medial margin of the footprint. So we introduce a new landmark. One is the intersection between the curved line of the superior head of the humerus and the linear line of the superior facet of the greater tuberosity. This is point A, and an intersection between the posterior inferior margin of the humeral head and the intermediate margin of the teres minor insertion. So this is point B. So these points provide a presumed medial margin of the footprint. Is this really correct? So we took the CT scan of the cadaveric shoulders with many beads embedded along the medial margin of the footprint. So this line connecting the beads shows the real medial margin of the footprint, and this is our presumed line, so they're pretty close. So using these anatomic landmarks, we may be able to improve the accuracy and precision of the glenoid tract concept. The details of this study will be presented by Kawakami during the Japan Shoulder Society meeting next month. Another solution is to use MRI, which clearly shows the medial margin of the footprint. But there is one problem using MRI. On CT, this is the medial margin of the footprint, long axis of the Hill-Sachs lesion, and this line is perpendicular to the long axis, and we measure the Hill-Sachs interval along this line. But when we use MRI, only the horizontal planes are available. So on the horizontal plane, we measure this Hill-Sachs interval, which is definitely longer than the CT value. So using MRI, we have an overestimation of the Hill-Sachs interval, leading to an overdiagnosis of off-track lesion. So we need to find a better way to use MRI. I'll show you some more recent whys. Last year, we had an annual meeting of Japan Shoulder Society in Kyoto, and I was assigned to work as a moderator of several international sessions. This session was about shoulder instability, and the symposists presented that the lateral J was effective, iliac breastbone graft was effective, and the meta-analysis showed there's no difference between lateral J and iliac breastbone graft. Wait a minute. We all know that the main stabilizing mechanism of lateral J is the sling effect, which provides 60% of shoulder stability. If the sling is so important, why there's no difference between these procedures, one with the sling and the other without? I asked the symposists, but none of them could answer my question. What is a sling? It's a flexible strap or band to support a hanging weight, and there are several types of slings like these. So the conjoint tendon hanging from the coracoid process seems to be appropriate to be called the sling. This figure shows that the conjoint tendon provides the sling effect. However, the original concept is a little bit different. Didier, who popularized the lateral J procedure, said that stabilizing mechanism of lateral J was threefold: bone, ligament, and muscle, including both the subscap and the conjoint tendon. He called it the triple blocking mechanism. He proposed this mechanism, but he never proved it. And Yamamoto and colleagues were the first to prove this triple blocking mechanism, but in this paper they used the term sling to refer to both the conjoint tendon and the subscapularis. According to them, the contribution of these muscles was between 5% to 60%, depending upon the amount of muscle force you apply to these muscles. But volume-wise, the conjoint tendon is only 1/5 of the entire musculature. Accordingly, the contribution of the conjoint tendon is calculated to be 1% to 12% at the most. With these small figures, it's understandable that there's no difference between these two procedures, with and without the conjoint tendon. This session was about irreparable cuff tear, how to treat pseudoparalysis. So after all the presentations are over, I said, well, before starting the discussion, we should define pseudoparalysis, because the pseudoparalysis consensus group issued a statement saying that there's no consensus on the definition of pseudoparalysis or pseudoparesis. So when we use these terms, we should clearly show our definition. So I asked the symposists, and some said less than 90, others said less than 45, or others say no active arm elevation. There was no consensus at all. But this term is so widely and commonly used without consensus. Does that make sense to you? So I showed this video to the symposists, and this is a man with a massive rotator cuff tear, and his flexion angle is 45 degrees before pain block and 90 degrees after pain block. So you may call this pseudoparalysis or pseudoparesis, depending upon your definition. Whatever you call it, he gained full functional recovery after the surgery. These patients show various angles, arm elevation before surgery, but one thing in common is that they could keep the arm in position. In other words, their arms were more or less under control. This is a totally different group of patients. She tries to elevate, but the arm drops down against her will. There is an elevation lag. She also tries to elevate, but it goes down. She cannot elevate. She looks as if she has paralysis, but there's no neurological deficit. So this is a group of patients whose arms were under control. So differentiating these different angles of elevation before surgery does not make any difference in your decision making. But this is a group of patients we need to find out because of their severe functional deficit, which needs to be reconstructed. These days, too many doctors use the term pseudoparalysis with too wide definition, causing a lot of confusion. To avoid this confusion, we should strictly limit the use of this term only to those with no active arm elevation like these. They look as if they have paralysis, but they don't. So this should be defined as pseudoparalysis. Do you have any objection? I asked the symposists. None of them did. So finally we got the consensus. The point is, always try to find the problem, and once you solve it, you can go forward one step at a time. This monograph, Show the Urology, was released in 2022. This is a summary of my career, and this book tells you where to find whys and how to find the answers. I wrote this book to stimulate your research interest. Right after this book was released, I got the message from one of the readers saying that your book, which I recently received and read in 5 days, was the most interesting book I've read on research related to shoulder. So if you haven't read this book yet, I strongly recommend you to read this book so that your research interest would be stimulated. This is one of the most shocking events in my career, the Great East Japan Earthquake and Tsunami. More than 20,000 people were killed or missing. This tragedy has been indelibly etched in my mind. So when I was the Congress President of Jsoa, I picked up this topic in my presidential lecture. Among the audience was the President of Asia Pacific Orthopedic Association, APOA, and also the President of the European Orthopedic Association, EPOR. They invited me to their meeting to give this talk. So I gave this talk at the APOA meeting in Antalya, and also at the EPOR meeting in Lisbon. Also, I gave this talk in the NEAR lecture at ASES annual meeting in New York, and also at the French Arthroscopy Society in Rennes. I gave this talk many, many times because we are still suffering. Why? Because of radiation. The melted fuel remains radioactive for 100,000 years. Nobody can take responsibility. So energy-wise, we must choose the right path. And we must do it now. Otherwise, the future of this planet would be apocalyptic. In summary, always be curious and open-minded, search for whys, and try to find the answers. This process will foster originality, which is one of the most valuable qualities in our professional career. Thank you very much for your attention.
Thank you very much. I have this appreciation letter for you guys. Professor Concesino, please come up to the podium. Answer ジノコンセのスペシャルレクチャー1、私の生涯にわたる ACL との格闘、My Lifetime Struggle with ACL。記念は日本スポーツ整形学会2025において上記セッションで講演され、会員指導に起撃すること、ここに代々のものがありましたけど、ここに本会を代表し、新人なる感謝の意を表します。Jsoa 2025プレゼント、菅弘之。感謝状、伊藤裕二とのスペシャルレクチャー、Shoulderology Searching for Whys、挙動文です。
Thank you very much, Dr. Sudaya, Dr. Shino, and Dr. Itoi. We are now preparing for the next session. We appreciate your patience.
Yes.
Already married. No German.
And you worked in India. Sensei, こんにちは。先日は見学に参加しました。いや、すごい盛り上がって、サージリー、ライブサージリー。I saw it. 見た、超美人と思って。超美人。うちのクリニックのこれね。ああ、そう。見てください。あれ？もう一人の先生どうでしょう？まあそうですよね。金曜日。あ、そうなんですね。
We will now begin Keynote Lecture 1. This session will be moderated by Dr. Sugaya. Dr. Sugaya, please begin the session.
Okay, so this keynote lecture is also one of the very important session in this meeting. So I'm very happy to introduce Dr. Keith Meister. Keith is the, everybody knows Keith. Keith is now taking care of the Texas Rangers, and he's the best Tommy John surgery doctor in the U.S. measuring. So he has done maybe about half of the measuring baseball pitchers, Tommy John surgery. He does. So anyway, no introduction necessary. So Keith, please go ahead.
Well, thank you. I'd like to thank Dr. Shigai, and I'd like to thank the Jsoa for the opportunity here. This is obviously a topic very important for me, and one that I'm very, very passionate about. And it's a problem that's really epidemic proportion now in the U.S., particularly with our elite level throwers. I've got nothing to disclose. We're over 50 years now of Tommy John surgeries. Incredibly, Frank Jsoa actually has a place in the Hall of Fame, but Tommy John does not. In spite of his participation in this first operation, which was monumental and really game-changing for the profession, he's not yet found his place in Cooperstown, which I think is a disappointment. Excuse me. The first procedure was in 1974, but the first paper wasn't written until 1986 that Dr. Jsoa published. And interestingly, if you look at the numbers here, that's 16 cases only between 1974 and 1986 that he was able to publish on. And that's going to be impactful as we progress here a little bit through some of these slides. That was reconstruction, but primary repair was tried as well. And obviously that's come back in vogue now for those of you in the elbow ligament world within baseball. But it was tried with less success, even in the earlier days. Just especially at the elite level, couldn't get the results that we were getting with reconstruction. And there's been a lot of evolution in the surgery since those times as well. I mean, obviously the first procedure and the first paper in '86. But Dr. Andrews, one of my mentors, published extensively on this and made some innovations in the procedure in terms of exposure and technique for reconstruction. And then Dr. Alchek really made some groundbreaking changes for us, and unfortunately he passed away just a month or so ago. But he came up with the muscle split and the docking procedure, which has really been foundational in terms of the techniques that are done today. And now the more anatomic techniques that are being developed are really based upon the foundations that these other individuals were able to put forth for us. Primary repair, as I said, I mean, early on, not much success, and Buddy Savoie published a paper in 2008, showed 56 to 60 able to return, but keep in mind this was a very mixed bag of athletes. They were high school, college kids. They were not elite level throwers. And then certainly have to give credit to Dr. Dugas, who was the first really to start using this within the medial elbow as part of elbow ligament procedures. But again, his experience was really with the lower level throwers, the high school, college individuals. This is a telling number for me. In 2023, there were more Tommy John surgery procedures among professional pitchers in the entire decade of the 90s. And you think about that, you think of the changes that have occurred as a consequence of this, changes in the game that have led to this, I think have forced us to change our approach in the way that we're thinking in taking care of some of these individuals. And here's the problem. We just published our paper just a few months ago looking at the numbers of ligament injuries that we're seeing at the pro level. And in 2010, there were 86 elbow ligament injuries that required surgery in professional baseball. 2023, there were 232. These are numbers that I have below that I pulled from Major League Baseball, but over 300 now in 2024. So you're looking at about a 400% increase over just about a decade and a half. So something's changed in the game significantly. And as a consequence of this, we're seeing far more revision surgeries. We just published this paper as well. And you look in 2010, there were only 4 revision procedures done in professional baseball. In 2023, 27, and I can tell you probably this year over 40. As I've done quite a number of those. What's changed? A lot. The game is not the same anymore. A lot of theories. Is it workload? Is it off-season training programs? Is it the baseball itself in the U.S. game, the lack of tact, so to speak, which is a little bit different than over here in Japan, where the baseball has a lot more tact to it. Does it begin at the youth level? Do we need to blame our young coaches? Well, Major League Baseball did this worldly study that they came out with after a year of investigation and told us all that they felt like this report was an important first step in a longer process in trying to figure out what's wrong and why. Well, my answer to Major League Baseball, and those of you that know me know I'm not shy and I'm not afraid to voice my opinion, is this. It's a complete denial in terms of what's going on now. And the answer is obvious. It's velocity and it's spin on the baseball. And this has been a monumental change that we've seen over the course of the last 10 to 15 years, but even less so, really over the last 5 to 7. If you look at velocity, velocity is the one single factor that we know contributes to an increased incidence of elbow ligament injury. And it's not just in the fastball. What we're seeing now is these pitch velocity trends occurring in the off-speed pitches as well, which has been magnified tremendously by some of the other ways these pitches are thrown. Average fastball velocity this season for right-handed pitchers has eclipsed 95 miles an hour. It keeps climbing. And the other thing that's happened is that on the low end, the gap, so to speak, between the high end and the low end is much smaller. So although these averages are continuing to increase, it's been pervasive through all the pitchers in all the game. But this is really interesting and very telling. Velocity's increased significantly, but fastball usage has gone down. And this is why. What I call the designer pitches, the off-speed pitches. Baseball is enamored with velocity, but if you look at the Major League batting average against the fastball, it's about 230 to 250. If you look at the Major League batting average against off-speed pitches, it's about 211. So it's this other thing, this other problem, this obsession with creation of ball movement is significantly affecting what we're seeing now in both the shoulder and the elbow. One of the things I do pretty uniquely, every pitcher that comes into my office, every professional pitcher, and that's almost the entirety of my practice, I actually sit there and I photograph their pitch grips. I walk through every pitch that they throw and I photograph their pitch grips. And what I found has been very obvious is that the old nomenclature no longer applies. The change-up, all 4 of these individuals are holding the ball, and this is their change-up grip. Well, they're all different pitches. And if you look at the velocity ranges, and if you look at the spin rate ranges for each of these pitches, it's significantly different. So the standard nomenclature that we used to use no longer really applies. And this is a perfect example, the sweeper slider that we hear all about. Well, this is an individual that I did the only failed hybrid reconstruction that I've had, actually, in a primary ligament reconstruction, 4.5 years out from his TJ. Started throwing a sweeper slider 60 to 70% of the time. 4 months later, he had an MRI like this, and we had to revise him. So it's real. Why? Why is this impactful, or why these changes are affecting the elbow so much? Well, I always say you have to understand the why, and I saw Dr. Miyoto just, I hope I pronounced that correctly, in a lecture before, said exactly this. To be able to come up with a how, we have got to understand the why. So how is the elbow impacted by these pitch changes? And this is interesting. The biomechanical study that we're all leaning on, that we're looking at for information as to what happens with the elbow when we're throwing, is 30 years old. 1995, Dr. Fleisig, who I know quite well, put this study out and showed that the primary peak of elbow valgus load occurs in late cocking. Well, there's actually a second peak that occurs right at the point of ball release. And my contention is going to be that this is significantly different now than it was 30 years ago. And this is what I call the continuum. This is the pathophysiology of injury that's occurring with these individuals now that they're throwing a baseball. To be able to spin the ball like it's being spun now, you have to take the ball and you have to contract very significantly the musculature on the medial elbow. And through the entire, what we call acceleration phase of the throwing motion, until you get to that release point, the muscles are now highly contracted. There's a big squeeze occurring on the baseball. And then right at the point of ball release, you get this eccentric load to the medial elbow. And as a consequence of this eccentric load, you've seen a monumental shift and a big, big change in what's occurring to these individuals that are throwing the ball. You don't see pain and layback anymore. They come in and they're complaining about pain at ball release. This is completely different than when I started doing this 30 years ago. It's usually a single event, and it's more often the off-speed pitches that this is occurring with. So this is an eccentric injury now. This is not this high valgus load injury that we used to see. A few little pearls in kind of our standard workup, as I said, pain and release only. Singular event, forearm tightness in these individuals usually portends a proximal ligament injury. Sometimes they'll have transient ulnar nerve symptoms. Oftentimes those are more distal injuries. And these are the two tests that I use most significantly to kind of discern some of this. You know, Dr. O'Driscoll, who's going to speak today, I know, has come up with a moving valgus stress test. I call it the O'Driscoll maneuver in deference to him. But he explained it being more in elbow flexion through a 70, 90, 100 degree arc of flexion. Well, most of these individuals are not hurting in that position any longer. They hurt toward terminal extension. They hurt at 0 to 30 now. And they hurt more with the elbow in a pronated position. So if you actually unload the flexors, pronate the forearm, and you do this maneuver toward terminal extension, they're going to have pain almost every time. Even better, even more sensitive is that test on the bottom. I look at every one of these individuals, I put them in full extension, I have them resist in full pronation and wrist flexion. They all hurt in that position because this is an eccentric injury now. It's different. Our imaging, we never use contrast. These are non-contrast studies, and it's critical that you get a coronal stir image. It really shows you much, much more detail and sifts out the scar tissue that sits there. We don't use ultrasound very much. I do use it for post-op ligament evaluation at times to show a player that his ligament, his graft is intact if we're struggling a little bit during the rehab process. And CT scans are really only for bony acuity. This is a game changer also. This is the fever view. Dr. Pam Lund, who does our MSK radiology out in Arizona during spring training, actually was very innovative, came up with this. So every individual gets a stress MRI now. So elbow held at 90 degrees of flexion, 8-pound weight on the arm, and then we scan them, and we see how much the medial joint space opens up. And usually when I get more than 3 millimeters or so, that's when I start to really worry about the competency of the ligament. Overall, though, as I like to say, we treat every individual as an individual, the N of one phenomenon. Who is the player? What level are they playing at? What position are they at? What is the personality of the tear? Is it proximal? Is it distal? Is it mid-substance? Is there soft tissue? Is there bony compromise? Where are we in the time of the season? Sometimes we have to make different choices in February than we do in September. We just don't have the luxury of time. And what's the realistic potential upside of this individual? The 6th P, I always say, though, is the parents, or in my case now, agents and coaches. I've got to deal with them. They're an X factor very, very often. Non-operatively, is there a role? Sure, there's always a role. But again, I think that you need to take these things that I just mentioned into account when you're doing such. What are the goals of the athlete? Time of the year. Is there a role for biologics? Look, the reality is there's no single good paper out there that shows that any of the biologics do anything to help in the healing process. I'm not going to say it doesn't help to mitigate pain, but in terms of healing of the ligament, there is no good evidence to show that it makes a difference. On MRI, we're going to see these periligamenous edema lesions. We see this injury to the proximal ligament far more often now than we ever used to. What I call these transitional zone tears, which we'll talk a little bit about in one of the other symposiums in a little more detail. But this is what's occurring proximally in the ligament. These are the common patterns that we're seeing with primary injury now. Proximal ligament injuries that leak into the flexor tendon footprint. There's a very, very nice anatomical histological study that Dr. Sugaya was part of that has helped me tremendously in understanding and explaining some of this. So what's our surgical indications, though? Recurrent grade 1 injuries. Somebody repeatedly has grade 1 injuries. At some point, you need to shore up the ligament. Fever view laxity helps us with that. The grade 2 injuries, the partial tears, I think, again, it depends upon the other variables that we're looking at and the ultimate severity of that partial tear. Is there any flexor tendon involvement? Are they lax on their fever views? And then the grade 3 injuries, the complete ruptures, obviously, those are the ones those are always a no-brainer. Our surgical options now, well, our acute primary tears, we can either internally brace them, and I do what's called I have my own technique, it's a docking technique, and we do a two-layer solution in some of these individuals, especially with the revisions. And then I have my hybrid reconstruction. So the way I like to look at this is everything now is brace-centric. We put a brace in with, and we put a brace in without a tendon graft. And also always address that flexor tendon. Why do we use a brace? Well, I think there's some good support now to show that this is probably helpful in several different dimensions. There's biomechanical support, no question. It helps to reduce the laxity in the medial elbow. There may be some biological effect as well. We don't know exactly what the collagen or the weave of that brace is doing in terms of helping it to heal in to the surrounding tissues. And the clinical results have been pretty obvious for me, especially on the revision side. Redo elbow ligaments are not nearly the challenge for me, at least that they used to be. My indications for just repair, well, the absolute contraindications are soft tissue loss. So significant degeneration of the medial soft tissues, you need to add a graft. Otherwise, I think it's a case-by-case basis. And ultimately, as I tell people, it is a game-time decision. I tell every athlete that before we get in there. My docking technique is nice because, A, you don't need to open kits. Now, obviously, the manufacturer doesn't like this because they don't make as much money on me. But the reality is, I only use a single implant, and I use the internal brace tape. And now there's a 1.7 tape, which is nice, which we can use in circumstances where the individual is obviously a little bit smaller elbow bony anatomy. You can put in the 1.7. I use generic size, reusable 2.7 millimeter drill bits. And for the tap, I cut off the handle on the kit cap, and I attach it to my drill, and I power it in there. So this is a basic docking technique, distal tear. And what we do proximally is I put two divergent drill holes in, I pull the ulnar nerve away, and I release the medial muscular septum, and I'm able to get my tape in there. Technically speaking, again, it's important to elevate the ulnar nerve proximally, release the medial intermuscular septum so it's not imposed upon by that suture knot. I drill proximally, you have to lateralize your tunnel. It's so important to stay within the native ligament footprint. You do not need to or want to get near the flexor tendon. That can be very, very destructive. And I tie deep with a knot tire there, actually, so I keep my fingers out of that little hole. And this is what it looks like, essentially, with a standard distal tear. This is a minor league pitcher. Usually a 5 centimeter sewn incision. You can see I'm elevating up the ulnar nerve. There's a split in the posterior raphe, so we're looking for the interval between the FDS and the FCU. And then we elevate up the FDS. And I do an internal neurolysis of the nerve as well. So I'm elevating up the ulnar nerve off of the posterior side of the ligament, split the ligament, and you can see in this case distal tear. We take real time to prep that area. I pre-drill with a 2 millimeter, and then that's our standard 2.5 millimeter drill hole, tap, and then our brace. Proximally, this is where it changes. I take that 2.5 millimeter, 2.7 millimeter drill bit, and I make two diverging tunnels. And you'll see we'll pass our sutures, and we use those sutures obviously for passing of the limbs of the brace, and then we close the ligament tear. So whenever there's an acute tear, we try and repair it. So it's a repair plus, so to speak. Brace arms are through, and then arm is held at 25 to 30 degrees of flexion, full supination, and we knot tie down posteriorly and deep. And then I flip the knot out of the way of the nerve, and you can see because I am lateral on that footprint, I've got plenty of good ligament tissue to pull over the top of that brace. So I'm protecting that flexor tendon zone, the proximal transitional zone, the zone between the ligament and the flexor tendon, one suture within the brace and the ligament, so we don't put a lot of stitches in there. Close this thing up with a running 2-0 vicral suture. And then we'll usually put, almost always in fact, 5 sutures in the sub-Q of 3-0 monocryl, and then my PA will run a 4-0 subcuticular stitch for us. So post-operatively, they're in the brace for 4 weeks. We start moving them after the first few days. take the brace off after a month, 3 months, we start with two-handed plyos, 3.5 months, one-handed. But again, these are more elite level throwers. I do not rush them, I do not push them. Ultimately, throw at 4, mound at 7, return to play, I look for 10 months. Your higher level throwers are going to take longer. I don't care what anybody says or what the literature says. You cannot push these guys that quickly. The loads and the stresses are that much greater. The proximal failures that we really see are ones where the internal brace is put way too close to the flexor tendon. You've got to stay out of this area. I've got 10 or 11 cases now where the flexor tendon has been avulsed because the anchor was placed right through the flexor tendon. And the goal was to just lay the brace on top of the ligament. That is not correct. That is not your best construct. Are they healing? Yeah, they're healing. This is a 2-year follow-up on a collegiate pitcher that we did a distal tear on. 2 years later, he came in for some posterior elbow discomfort, so it was an opportunity for me to get an MRI scan. The nice advantages to the docking technique, there's a technical ease of tensioning. People ask how hard you pull on those sutures, and I say as hard as I can. You do not over-constrain the elbow if you're putting a brace in an anatomical position. It's not a problem. There's less disruption of the proximal UCL footprint because your drill hole is smaller. There's a cost savings, especially if you're in an outpatient surgical setting, as we are many times in the U.S. I think there may be some improved outcomes over the screw, but I can't say whether that with certainty. We need more follow-up. But these are my numbers. And I've thrown out all my ligaments that are prior to 2015 because the game is so different now. But we've got over 1,400 elbow ligaments from 2015 to August of this past year. I've got 425 braces in there, and you can see I've got 71 pro elbows. And I've got guys throwing 100 at the big league level. So again, if you pick your patients correctly, they can do quite well. Will they last as long? I don't think we're sure yet. I don't think we know the answer to that yet. My failures have been in all collegiate players looking to increase velocity, doing crazy things with weighted balls and what we call compression throws. The hybrid reconstruction I started in 2018, and it was because I had a particularly challenging case that I really thought I was going to not be able to handle as well as I would with a standard reconstruction technique. And I had been thinking about this for a while. There was biomechanical support in the literature. There's no question that a brace decreases joint gapping in a cadaver model. Where do you put the brace? Well, this was a really good study for that as well. It shows the closer you are to the joint line, essentially, the more effective that you're going to be. That's where most of the load and stress is taken, which makes perfect sense with every other biomechanical study we've ever read. Distally, there's a lot of room there. The spine of the ulna there is very, very, very strong. And in these 1,200, 1,300, 1,400 cases that I've done, I have never had a fracture distally. I've had them proximally, but I haven't had them distally. So I don't think that's an issue. And we modify these tunnels a little bit. I like to go with the concavity of the ulna there, and then you can sneak the brace in there, and you're still well distal to the joint line, and you're careful. It's a 2-stranded graft. If I have a thin palmaris, sometimes I'll do what we call a dock loop procedure. And this was my first hybrid. Big piece of bone, what I call an enthoscopic osteophyte or a bullhorn. And in this case, it had fractured in this fairly elite level minor league pitcher. And I said, look, I've been thinking about this. Do you mind if we try this? And he said, I trust you, Doc. And that's what we did. We went ahead and we did this first hybrid reconstruction in 2008. Kyle Cody is the patient. He doesn't mind me mentioning it. He played another, actually just retired this year. So he went 7 years on this construct. He made it to the big leagues for a short period of time. And essentially, I think what we were doing was adding this seatbelt to our reconstruction. Initially, it was just challenging cases, but then as we got more confident and further along, we started putting it in more and more individuals. It's a pretty standard approach, as I already showed you with the internal brace alone. These drill holes go distal to the kind of the normal place where you may put your distal drill holes if you use a converging drill hole technique. And then, your brace goes between the drill holes and the joint line. And again, I'm going to just reinforce to you, and I should have a footnote here. This is Dr. Sugai's anatomical study, and I've taken so many pictures out of that paper. It really does elucidate well what's going on the medial side, especially in that transition zone between the flexor and the ligament itself. I'm going to skip right ahead here and take you to a little more real-time video. And this was This was, I believe, actually a major league pitcher with a standard kind of distal tear. I think I wasn't happy with the way the tissue looked on the MRI scan, and oftentimes the players will tell you, just go ahead and do the whole thing, Doc. I don't want just a brace, I want you to do the whole thing. And as I like to say, the customer is always right sometimes. So it's an elevation of the muscle, same thing. We elevate up the ulnar nerve, we split the ligament, and this again, another distal tear here. But you can see the ligament itself is actually fairly degenerative, it's loose, and he needed more tissue there. So you can see my converging drill holes, 3.5 millimeter tunnel. We pass our suture across for passage in the tendon limbs. I make my my internal brace tunnel just between the joint line as well as the distal drill holes that we made. We put our brace in. Approximately, we're going to drill a 4 to 4.5 millimeter socket, usually 15 millimeters, 12 to 15 millimeters is all you need in depth. You'll see I'm coming out with 2.5 millimeter drill holes past our sutures. One, then the second one. And the trick really becomes how do you get these things in there comfortably. We're going to repair the ligament distally here first, but then we're going to pass the limbs of the brace and the tendon graft. And I always pass an arm of the brace first, and then we're going to go ahead and we're going to set the length on our tendon. You'll see me pass my tendon here. And we're going to cut these to the appropriate length. I do a whip stitch. This is actually an orthocord suture because the central cord, this is PDS, so it's a very soft suture and the central cord dissolves. So one arm of the brace, then one arm of the tendon goes in next. And then I go ahead and I mark for the second arm of my tendon graft. We whip another stitch in. And then we'll cut that to length. And then I dilate the tunnel first, and then I pass the tendon. And that's a nice little step. Pull the second arm of the brace in, it pulls that tendon graft in, tie down the brace, tension it again, 25 to 30 degrees, full supination, followed by tensioning the tendon graft sutures. We can tuck our big knot deep and away from the nerve. And then because I've lateralized my tunnel here, you can actually see I've got plenty of tissue to pull over my graft and my brace, which is important. It really retains the normal anatomic structure of that area of the elbow, which I think is just so critical. Close up the muscle, close up the skin. Ultimately, as I said, with the graft passage, just to repeat, first limb of the brace, then the graft, dilate the tunnel, then the second limb of the tendon graft, and then we pull in the second arm of the brace suture in. One little thing we got to remember about with these transitional tears that we see a lot now, we've got to remember that there's some flexor tendon involvement, so I'll oftentimes put a suture anchor there proximally as well. And I think that's helped some of our results. These are almost hidden lesions. If you're not looking for it, not thinking about it beforehand, you can miss it, but we prep the bone and we put an anchor in there. Standard protocol for post-op for me is, for my elite level guys, 6, 9, 12. Meaning we start our interval throwing program at 6 months, off the mount at 9, start our lives at 12. We look for 13 to 14 month back full go. For my high school, college kids, I've actually sped all this up by about a month or so. Here's where we are now. With our primary hybrid reconstructions as of August, I've got 499. You can see that over half of these are professional elbows. So this is a very elite level group of individuals that are really challenging what we've done here. I've only got 3 failures that I know of. And again, I haven't done a deep dive on return to play. But again, the athletes that I take care of are such that if they're not doing well, I'm going to hear about it. Every one of them gets my cell phone, and I'm going to hear about it. We've had 2 arthrofibrotics. We've had to go back in and scope and move the ulnar nerve on. On the revision side, that's 95 of them, 73 pro, 18 college. So almost 80% of my revisions are pro. And I have not had a graft failure on any of these individuals. I have had a post-op fracture in the collegiate. This was my one post-op fracture following my primary hybrid. This was a closure in a major league, for a major league club. So you can imagine the sleepless nights I have when I see something like this. But fortunately, actually, he was repaired, not by me. I don't have that kind of ability with fractures. But somebody did a beautiful job, and he actually has gotten back to the big leagues. Unfortunately, just recently hurt his shoulder, but the elbow healed up fine. And I do think that was a consequence of the brace. So in conclusion, obviously this is a rising epidemic in Major League Baseball. 7 billion at last count and growing. The results have been good for primary reconstruction, but they're not lasting as long. People are asking, can we move faster on these? My personal feeling is no, but that's certainly a topic for discussion. The revision results are to me the most exciting thing. I think our numbers are improving. The game has changed tremendously today. I mean, our fastball velocities, our quest for spin have changed the challenges that we see on a very, very regular basis. And this has trickled down to the developmental level, the youth level. And these things just are not lasting as long. They're typically re-tearing at 3 to 5 years. I really think ultimately it's not going to change at the lower levels until it changes at the higher levels. We're seeing more and more individuals enter into the draft with TJ's already done. So that means they're going to have their second one early on as well. It's really come down to the lost art of pitching. Guys are not pitching anymore, they're just throwing. They're throwing the metrics. The future is newer biomechanical studies. I think we can build better prehab programs to eccentrically load the medial elbow and maybe have a better tolerance. And I think that incorporating some of these off-speed pitches earlier is going to be very helpful as well as part of our rehab process. I'd like to thank first all those that came before me, because as much as I think that we are evolving and we've changed some of the things that we're doing today, these are the people for me that laid the foundation. They're the important people for me in my life and my career that have allowed me to be able to continue to push the envelope as we move forward and hopefully do a little bit better job of dealing with some of the bigger challenges that we face today. So thank you again, Hiro, for the opportunity.
Great job, kids. So we're going to have the symposium after this session, so that maybe discussion will be done there. Okay. So this is all Japanese. Dr. Kiesmeister, thank you very much.
Thank you very much, Dr. Sugaya and Dr. Meister. We are now preparing for the next session. We appreciate your patience. We will now begin Symposium 3, UCL Injury in Throwers. This session will be moderated by Dr. Jsoa O'Driscoll and Dr. Yoshikazu Kida. Dr. O'Driscoll and Dr. Kida, please begin the session.
Konnichiwa. Maybe I speak Japanese, you speak English. Konnichiwa, watashi wa Sean desu. Watashi wa Yoshi desu.
課長はドレスコー先生と共同フリーズの木田が担当させていただきます。
等級比障害の内側側副人体の損傷について、このシンポジウムではエキスパートの先生方に解剖から手術療法までご発表いただきます。最後に相互討論の時間を20分設けていますので、各演者の先生のご質問は最後に時間があればお受けしたいと思います。このセッションは同時通訳が入っていますので、日本語でも英語でもご発言いただいて大丈夫です。それでは1番目のセッションを早速始めさせていただきたいと思います。内側支持機構の解剖学的な解析について船橋整形外科、現在留学先のカリフォルニアから帰ってきていただきました星川翔太先生、お願いいたします。
Thank you for having me. I will present the medial anatomy, the focus on the reconsideration of UCL in the context of the tendon structure and the joint capsule. Nothing to disclose. It was reported that the financial damage from UCL injuries and MLB team lost more than $70 million in a year. The usual injuries are no longer just the individual injuries, but the broader social issue. More importantly, the Keith Meister, the one of the world leading elbow surgeons, highlighted that the previous interview, that the baseball reaches at the breaking point, and with the usual injuries, threatening the future of the game. So without the prevention and cultural change, the baseball's future is at risk. So many preventive program existed in the baseball, but no program designed specifically for the usual injury. This difference doesn't matter because the usual injuries is increasing. And this is also the Meister's report. It's showing the numbers of the usual surgeries kept increasing. Even with the UCL treatment, the trend kept rising. I think we are missing something. I think that it's time to look again, changing with the UCL anatomy. The UCL is connected to the medial elbow at sublime tubercles, and especially the anterior oblique ligament is a band-like structure and the key stabilizer against the valgus stress during throwing motion. And flexor pointer muscles and the brachialis, the secondary stabilizer to support the AOL. The both stabilizers are well described separately, and the anatomical relationship between the both stabilizers remains unclear. Indeed, the anterior common tendon was reported as a surrounding structures, and it is supporting the AOL. It's also this structure, the boundary with the AOL is unclear. So we learned the ligament, tendons, and the aponeurosis were taught in integrity. Tendons have regular fibers, and aponeurosis is irregular. But realistically, the border with the ligament is unclear. So my question is, what the AOL is? I will explain the AOL using the three analyses. The first, historical analysis of APM. This is the left elbow, the viewing from the medial side. This side is proximal, and this side is distal. And then FPMs form the common muscular origin at the medial combat. To understand the arrangement of the FPM, we dissected at the level of sublime tubercles. This is the actual view of the sublime tubercles. The radii, the brachialis, and PD, FDS, and FCU attached to the subgram tubercle directory. And the thick common tendon septum, the structure is identified between the PD and FDS, this red dot area. So we focus on these structures and then make a section with staining. This is the histological analysis of the tendon septum. The tendon septum is well stained deeply. And then it's quite interesting. This structure is connecting the brachialis here. And also this structure is contained in the aponeurosis of the FDS, like this.
สวัสดีครับอาจารย์
Next, anatomical analysis of the tendon structures.
ห้องหนึ่ง
After removing the skin and the soft
ใช่
tissue,
ฝั่งเอว
the
โบ
AFD members
อาจารย์
are
อยู่ห้องไหน
clearly identified.
ไม่อยากหยิบ
After removing the PL and the
อาจาร
CL,
ย์อาจารย์ไปไหนห้องไหนต่อ
you can see the FDS. And then also identify distinct tendinous structures between the PD and FDS.
ได้ครับมันห้องสองใช่ไหมอาจารย์
After removing all the muscular component of the FDM, the common tendon septum is clearly visualized here. So viewing from the anterior side,
งั้นเดี๋ยวไปที่ห้องสองไหมอาจารย์
brachial tendon inserted into the common tendon septum and here. That's the
ได้ครับครับเดี๋ยวไปเจออาจารย์ครับอาจารย์
also the viewing from the medial side, the black color. Then after the reflecting the common tendon septum, the common tendon septum is continuity with the aponeurosis of the FDS. Like this one. So histological, next, the last one is histological analysis of the tendon structure of the joint capsule. We made a section including the medial epicondyl and subgram tubercles to identify the layered structures of the tendon septum and capsule. And proximally, the capsule lies under the tendon septum and attached to the medial epicondyl. And then with the synovial cavity like this. This is the capsule. And distally, the tendon septum and capsule attached that fuse and then attached to the subgram tubercle. So previously, the considered LL is separated from the tendon surrounding structures. But based on that anatomy, the actual LL could not be separated from the surrounding structures. So let me summarize the LL. The actual LL is the part of the common tendon septum between PD and FDS, and part of the deep fascia of FDS, and then connecting to the with the brachial tendon, and then containing the joint capsule underlying the tendon septum. So the LL is not isolated, but it's tendinous complex, and then it works as a cooperative stabilizer with the FDM and brachialis. So different from the ACL or PCL, which is isolated as a kind of ligament, but LL is not the ligament, but including the aponeurosis and tendon structures. So, based on that, I think the prevention should focus on this operative function of the tendon complex. And this is the last take-home message. The AOL should be understood as a part of the tendinous complex, composed of the FAMs, some brachialis, and also tendon septum, and the joint capsule. Thank you for your attention. Thank you very much.
So this second speaker is Professor Sean on this call, of course, the elbow specialist from Mayo Clinic. His talk is about disabling medial elbow pain in athletes. Please start.
Hello, thank you very much for this pleasure to be here, and really great symposium so far. Well, we've heard about the problems of the UCL, and all of us know that there are other causes for pain than the UCL, and I'll speak about some of those other causes now. My disclosure is not relevant to this topic. There are multiple causes. The most common would be ulnar neuritis, often due to subluxation, but you always have to think about a painful subluxating or snapping medial triceps as well. Keith Meister mentioned medial flexor tendonitis, which is actually more common than people recognize. But there are other causes as well, and I'll go through those and share them with you. First, let me tell you that patients with a painful ulnar nerve subluxation almost always or usually have a painful medial triceps subluxation. And here we see a video of the medial triceps and the ulnar nerve. The ulnar nerve is subluxating, but the medial triceps is pushing it, like pushing a boat in the surf up onto the beach, and it irritates the nerve. So always think about the medial triceps being a cause for that. Sometimes the medial triceps will snap, but very often it just rolls back and forth over the epicondyle. But if they have snapping at the medial elbow and medial pain, you can tell on the telephone they have a snapping medial triceps. It's not just the ulnar nerve. In a series of patients that we looked at, medial triceps subluxation was present in almost half of the patients undergoing UCL reconstruction. Rob Spinner wrote a paper with me and others on this condition, and it's often missed. So be careful to look for this, and we call it the second snap of the triceps after the ulnar nerve. Well, earlier, Dr. Meister was talking about the common flexor tendon, and we just heard now a beautiful anatomic study showing the importance of the tendon. And there's no question that the load on the tendon, especially eccentric loading towards the end of extension, is a critical component in throwing. We can diagnose medial tennis elbow or medial epicondylitis using the medial tennis elbow shear test. This is performed by asking the patient to flex the wrist, then you try to extend the wrist and supinate against resistance. That will usually cause pain. But if you then have the patient extend the elbow at the same time, they will have pain right at the origin of the flexor tendon. There are two more tests you can use as well. One is called the cheek press test, with the extended fingers pressing against the cheek. And the other is a serving tray test. Like carrying a serving tray and pushing down on it reproduces the pain. But there are other causes as well. We saw a nice example of an enthesophyte at the insertion of the UCL on the ulna. Keith showed us. But enthesophytes form where the triceps attaches as well. And a fractured enthesophyte is often a source of pain. So look for that. Sometimes you can only find that on a CT scan. You may not find a small one on an MRI. So be aware of that and be prepared to do a CT scan as well. Well, there are some uncommon causes that we need to be aware of. This is one that we reported, 4 cases of snapping MABC nerve, so the medial antebrachial cutaneous nerve. Very small branch, you can see it shown here. Here's the medial antebrachial cutaneous nerve. In extension, it's behind the epicondyle, and in flexion, it snaps back over the epicondyle. There's the ulnar nerve behind. And this is a video of the first patient we diagnosed. You can see the ulnar nerve there, and this is the MABC nerve. Look, the MABC nerve is very small, but it has a neuroma from the irritation. And this patient had severe neuritic pain from this neuroma. So you have to mobilize that nerve and prevent it from snapping back and forth over the epicondyle. Here's something that most people are not aware of yet. We're going to report this shortly. This is perineural fibrosis from injury to an anconeus epitrochlearis muscle. So here we see, this is the anconeus epitrochlearis muscle. I lifted off the epicondyle. And here we see the ulnar nerve underneath, behind the epicondyle. But look at the scarring under the anconeus epitrochlearis muscle. This scarring is adherent to the ulnar nerve. And when we dissect that, you can see that it's a very tight space. I can't get all the way under, so we have to completely release that and do an ulnar nerve neurolysis, and then remove that anconeus epitrochlearis muscle. This was a 17-year-old high school pitcher who was disabled with a sudden onset of pain with one pitch. He saw many people. Some of the people on the screen saw this patient, had no idea what the problem was, but his problem was completely cured by resecting his anconeus epitrochlearis muscle and doing a neurolysis. This is not a picture, but it's a similar situation. I want you to see it. This was a hyperextension injury in a collegiate athlete. But the anconeus epitrochlearis muscle, which you see here, was avulsed from the epicondyle. And when it avulsed, it then became adherent to the ulnar nerve. Now you can see that the muscle is now stuck to the ulnar nerve. It has avulsed from the epicondyle. And when the elbow would flex and extend, the ulnar nerve was being stretched and compressed and tethered. You can see there's no movement between the scar tissue and the nerve. So during flexion extension, the nerve is being irritated, and this usually causes a contracture and pain. So it's a diagnosis that is not in the literature yet, but I think you should all be aware of it because of its potential to show up in athletes. You have to release that, do a complete neurolysis, free up the nerve, and once you have done that, then you will find that the nerve is now free to move, and the patient's pain will be relieved. We resect the anconeus epitrochlearis muscle as well. So there are other causes than just UCL injury in overhead athletes. Ulnar neuritis, subluxation, medial tricep subluxation or snapping, medial flexor tendonitis, fractured triceps and thesophyte, and then some nerve causes as well, which you need to be aware of. But remember also, the reason that the patient had a UCL injury might be secondary to pain in the elbow. They usually have pain. They often have pain. But then they have a sudden injury and everything goes downhill. So was that pain caused by one of these conditions that was being missed? Very important for us to be aware of it if we're going to prevent those injuries and rehabilitate them properly. Arigatou gozaimashita.
And then speaker is Professor Jsoa. Again, he's taking care of Texas Rangers and many major league pitchers. So his talk is about pathomechanisms of UCL injury and the role of the flexor mass, the proximal transition tear.
I'm going to take you through a really whirlwind tour here, the medial flexor mass here, and I just drooled over that anatomical dissection because this is exactly what I think is going on these elbows now. I have nothing to disclose. But we've seen just this significant uptick in flexor tendon injuries in the medial elbow, and I think that the loads and the stresses that we're seeing now have reached a tipping point. And there's actually very scant literature, evidence in the literature as to the biomechanical influence of what's going on medially with respect to the flexor mass. Epidemiologically, there's very little, and there's very little surgical data. There's really one paper out there, Dr. Olczyk's paper from some years back, and really was on 8 cases only. We've got far more than that now. It just shows you how things have shifted in the game. And I say, what's changed? Well, a lot. And again, I'm going to tell you, if you have to be able to understand or fix that, or come up with a how, you have to understand the why in these cases. And we talk about workload and training programs and the baseball itself and the youth level. And MLB has made a mess of this, I believe, by avoiding the essential problem here, which is that we've changed, again, this velocity and spin metrics that we're seeing in baseball. We've talked about velocity, so I'm going to skip through this so we can get to the meat and potatoes of what we're talking about here, because fastball usage trends, so it's not just velocity has to actually tick down. Although they can throw harder, the use of the fastball has been significantly less, and that's because of the implementation of all these designer pitches, these ball movement pitches. And I contend that it's the horizontal movement that's created in these pitches that is creating problems. And this is what we're seeing. We're seeing all the funny pitch grips, but ultimately guys are trying to create this magnitude of change in the way the baseball moves. And a lot of this comes down to grip, and a lot of this comes down to not just grip, but the way and how these individuals are holding the baseball. And I'll lead back to the biomechanical study that we discussed just a little bit earlier. And it's what's happening now that wasn't happening 30 years ago when this original study was done, because people are not feeling pain in layback. They're feeling pain at ball release. And again, it's going back to that anatomical study that's actually showing us that the attachments of the flexor are occurring proximally and distally, almost indiscernible, or very certainly very difficult to discern the layered difference between these structures. They're inherently intertwined. And this is the study from 2019 that Yoshiko and Dr. Sugaya had done, looking at the anatomy of this musculature and the tendinous involvement interweaving with the ligament. This is really critical. And as I said, this proximal transitional zone that perplexes me here. And it's this zone right as the flexor tendon comes in and enacts with the proximal fibers of the ligament. And as we've seen now from this latest anatomical study, that these fibers are also inherently involved distally. And it makes sense to me because I see a lot of these patterns of injury that perfectly exemplify the anatomy that we've already been shown today. It's difficult to separate the two. So if the flexor is being eccentrically loaded in some crazy kind of way, which is happening now and it didn't happen before, we're going to see the typical patterns of injury that are distinctly different than we used to observe. So I call this the proximal transitional tear, or this transitional zone tear. And we're seeing this on MRI scans. If you're careful and you're looking closely enough, you can see that anterior raphe pulling away from the medial epicondyle and involving the proximal fibers of the ligament. And it gets the top two buttons on the shirt in these cases, in these instances. And again, these individuals are presenting differently now. It's no pain in layback, they're complaining of pain at ball release. Almost every one of these individuals. And it's the off-speed pitches that have been much more impactful in these individuals. You can see it specifically on these three images, your coronal stir, your sagittal, PD fat suppressed, and your axials. You can see where the tendon, again, intertwining with the proximal ligament fibers, is failing. And this is where these individuals are breaking down. They can be acute or combined with or without a ligament, or they can be chronic, isolated tears to the tendon, or they, again, can be involved with ligaments. They can be isolated. This is the top three figures are a 100-mile-an-hour sinker, major league pitcher who ripped off that deep layer of his flexor mass, and in this case without involving the ligament. So luckily he did not, remember, just fix his flexor. In the case just below that is a more acute combined case, where it's almost this delamination of the ligament, of the tendon that extends into the ligament, completely follows the anatomical drawings that we saw. It can be chronic where it's isolated flexor, and it can be chronic where the ligament also fails as well, becomes attenuated. In the exam on the presentation, I wasn't aware of Dr. O'Driscoll's modification of his O'Driscoll maneuver, so to speak, but as I said, these individuals hurt in extension, resisted pronation, wrist flexion. This is where they have pain. It reproduces the pain they feel when they're throwing, and it correlates with biomechanically, pathomechanically, I think, what's going on here. And their O'Driscoll maneuver is much more symptomatic in terminal extension, more so in pronation than supination. These isolated tears, sometimes you can treat non-operatively, but again, the further they go on, the more likely you're going to have to fix them. And then these combined tears, again, same thing. You've got to do the ligament, but you can't just debride the tendon. You've got to restore normal structural anatomy to these individuals. This is that 100-mile-an-hour sinker guy I was just telling you about, where he actually avulsed the deep layer of his flexor mass, We can clean up the medial epicondyle, put a couple anchors, double-loaded anchors into the bone, and did almost a 2-layer repair on that immediately. Here's a more isolated chronic tendon tear that's not unusual to see in many of these older throwers, older professional throwers especially. And again, same thing. You've got to debride and reconstitute the normal anatomy. You can't just debride them. You've got to repair them. And with these individuals with a little more ligamentous involvement, sometimes you can just put a brace in these individuals. So again, flexor tendon repair, you can see the distinction in the top right-hand corner surgical picture. You can see where the flexor tendon footprint is, but in this case we also added an internal brace, so flexor tendon plus internal brace. And then lastly, we have a potential flexor tendon plus a hybrid reconstruction in these individuals where you have to address both, but you have to add tissue. So our experience basically for these has been not 8 cases, but I got now 41 primary UCL reconstruction plus flexor tendon repairs, 39 of them pro. We haven't had any recurrent tears in those individuals. Of the 18 pro guys that I've done isolated flexor tendons on, I did have 1 recurrent flexor tendon tear that I probably should have put a reconstruction in to begin with. So implications for the future, I think we're going to continue to see an increased incidence of these ligament injuries. I think that we need to recognize them very often as combined ligament flexor mass injuries and address the flexor footprint appropriately. I think our greater failure rates in primary surgeries, we need to maybe look a little bit more towards the flexor as part of the problem and hopefully the solution to the problem. So, thank you.
Next, we'll have Dr. Yoshikazu Kida from Kyoto University speaking about Tommy John surgery, a Japanese perspective.
I apologize, I speak in Japanese. I have nothing to disclose. 日本におけるトミー・ジョン手術についてお話しさせていただきます。内側の痛みについてのアンケートですけども、肘の痛みの内側の痛みが 68.6% という結果で、肘の内側の痛みは野球肘の症状として最も頻度が高いということになります。これは中学生と高校生でもその傾向は同様で、日本における野球肘の頻度は非常に高いというのが現状です。アメリカのトミー・ジョン手術についてですけども、ジョーブ博士のフィギュア8の方法をはじめとして、ドッキング法、インターフェランス法、そしてレインテクニックといって、インターフェランス法とドッキング法を組み合わせた術式とか、あとダブルドッキングテクニックなどさまざまな方法が用いられています。いずれも近年は 80% から 90% の良好な復帰率が報告されていて、投球における肘内側損傷に対してトミー・ジョン手術は確立された術式と言えます。アメリカの肩肘学会のメンバーにどの術式を用いているかというのを尋ねたところ、報告によるとアメリカではドッキングテクニックが 66% と最下で、上部法が 15% と続いておりました。日本における内側側部靭帯再建術もさまざまな術式が開発されていて、慶友の伊藤先生、古島先生の固定による PL 腱が固定する術式が有名です。日本では広く広まっている方法で人工物を使わないので、再手術にも障害の少ない方法と言えると思います。これは田中先生はオリジナルのインターフェランススクリューを開発され、肘靭帯再建に応用されています。金属の TJ スクリューによる方法で一足のライン上に UCL を再建する術式です。正富先生の方法はエンドボタンを用いた PL の30足再建で AOL の後方を20にして前方一重の30折りで強固にされている点やインターナルブレースが言われ始める前から高い強度の糸をイントリンシックスプリントとして初期強度の確保に用いるアイデアで、使用されているオリジナルの術式で行っておられます。山崎先生はティークの案が用いた PL20 折りのライン上の再建で非常に多くの突破スイートを復帰に導いておられます。後で講演される島村先生は30折りの太い PL を円位をアンカーで固定されて、金を固定で固定するこれもオリジナルの術式で再建を行っておられます。 2018年に実施した野球障害予防顧問会にご参加の78名のドクターに対するアンケート調査ですけども、日本のドクターの術式は伊藤法が 46% と最も多く、次にインターフェランス法が 29% という結果でした。日本における手術適用ですけども、絶対適用はないものの、競技レベルでの投球が困難で、外反ストレスによる疼痛があって、保存療法が3ヶ月以上は無効で、強い競技復帰への希望があって、術後リハビリ、チームの協力も含んだリハビリへの理解と骨端線が閉鎖していること、そして UCL の画像異常所見ですね、超音波での外反ストレスで腱関節の差が2ミリ以上とか、あと MRI で明らかな損傷があるなどが一般的かと思います。ここでフロアの皆さんにお聞きしたいんですけども、I want to ask the floors that whether you indicate surgery or not. Case 1, this is 24 years old professional pitcher, 24歳の選手で、プレシーズンなんで冬2月ぐらいで、medial elbow tenderness, positive bowel stress test, both positive, and in the MRI you see the full thickness you see up here, and he failed conservative therapy. Who do you think he needs surgery? Okay. According to the study, the 73% of Japanese surgeons and 88% of United States surgeons said he needs surgery. So second case, the 20 years old college pitcher, medial elbow tenderness and positive bowel stress test, both positive, and full thickness tear and UCL tear, and he failed conservative therapy, and he has no potential for pro career, so he wants to continue his college career, but not anymore. Who do you think he needs surgery? That's the before. This is very different from Japan and the United States. 12% surgeons indicated surgery in Japan and 72% in the United States. And this is last one. This is I think it's tricky. It's 18-year-old high school pitcher. He's third grade, last grade of high school, 高校3年の春5月, let's say it's spring in season. And he has medial elbow tenderness and positive bowel stress test. And on MRI, 50% distal UCL tear, and he failed conservative therapy. And he will play college baseball next year. So, who do you think he needs surgery? Okay. So only 3% in Japan said he needs surgery, and 56% in the United States. What made this difference? It's Koshien. Koshien is Japan's field of dream. The Koshien tournament は日本の高校球にとって最高の舞台とされていて、で全国4000校がトーナメントを戦って、アメリカのショーケースゲームとトラベルゲームを合わせたような、そういうような立ち位置になると思います。で、予選、県大会が4から8ゲームで、ファイナルトーナメントが甲子園で行われますけれども、これが5から6ゲーム、6 weeks のトーナメント大会になります。で、この甲子園大会の直前に手術を受けたいっていう考える高校生、非常に少なくて、でこの大会の存在が日本の高校生の内側側部靭帯の手術適用に大きな影響を及ぼしていると思います。So in summary, in Japan, the incidence of throwing-related elbow injury is high, and commonly selected method of UCL reconstruction is Ito method and interference screw technique. And for high school players, conservative treatment is often preferred over surgery. Thank you very much.
Next, we'll have Dr. Shimamura with Ishihara, Nezu, and Ozaki, speaking on ulnar ligament reconstruction with the internal brace for baseball players.
Okay, thank you. First, I would like to tell thanks to the chair, Dr. Shon and Dr. Kira, and great president, Dr. Sugaya. So let's start. As Dr. Kira mentioned that, I also understand that TJ surgery has such good result, and as it calls pitcher's best friend. I've been doing TJ surgery, and I still am doing today. We perform linear type reconstruction surgery that combines anchors for SLT and one tunnel for medial epicondyle. The result of the past 124 cases showed a satisfactory RTP of 91% with average 9.8 months, which is comparable to other papers. However, for pitchers, it takes 11 months, which I still think is a long time. And the players themselves have told me that. As Dr. Kida said, and this is one of the biggest tournaments in our Japan, high school baseball players, so-called Koshien. In Japan, all young baseball players want to play with the goal of competing in the Koshien in their last grade 3 high school. And almost players retire after high school at age 17 or 18. Their baseball life is very short. The great player Shohei Ohtani is also played at Koshien and still a great legend player, you know. Dr. Dugas reported that current TJ surgery makes a good RTP and low complication rates, but rehab period remains still long. Almost 1 year is too long for high school players in Japan. That's where internal brace augmentations comes in. This paper is from Dr. Dugas, also reported that about so-called internal brace surgery, amazing, 92% RTP with only 6.7 months recovery. After this, we adopted this surgery. This is the schema of each our surgery. In the IB surgery, the original ligament is repaired first at each doctor side, and then augmented with a suture tape. This slide shows the case of proximal rupture, and anchor is inserted to medial epicondyle and suture tape repaired. I'm now using a 1.7 mm suture tape from Auspex. Is doubled over the surface of repaired ligament and fixed with an anchor. This is a case 1, a 17 years old high school catcher. He has very little time left, and IB surgery was indicated. 2 months out no slope and 2 months slowing program. He returned to practice in total 4 months. At 6 months, he was pain-free and had returned to being a later catcher of his team. This case was a college pitcher was ruptured at this sublime tobacco. There was no sign of improvement after the Cons treatment. He requested me surgery with ASAP return. This case involved a tear on the ulnar side, and an anchor was inserted into the SLT. The ligament was repaired, and then augmented with a hybrid tape on their surface. The patient underwent the RTP program and returned to play in almost half a year, 6 months. In our institute, 87 cases have been operated on using internal brace. The majority of cases were high school students, with pitchers and feeders making up roughly half and half of the cases. In 68 cases with follow-up available for more than 5 months, 92% returned to play with satisfactory result equivalent to those TJ surgery. The RTP was average 5.4 months, and for pitchers it was about 6.6 with good result. This is a comparison with the TJ surgery I previously performed. And the internal brace surgery showed significant result in both RPP and clinical score. And this is a paper from Dr. Lucas again about UCL repair versus TJ surgery. There was no significant difference in revision rates between both procedures. However, athletes who underwent UCL repair had a significantly shorter time to RPS. This is a systematic review by Dr. Spears. Reported that IB surgery had significantly better outcome than TJ. As described above, the internal brace surgery is very useful, but there are still issues to be addressed. First, when the remaining ligament cannot be repaired, this case with a 23 years old professional pitcher was scheduled for internal brace surgery. During the surgery, the ligament was almost scar tissue and could not be repaired, so decision was made to change to TJ surgery. It is always necessary to be prepared for the backup surgery. Next, this is regarding the surgical technique. It can be noted that tensioning of the internal brace is sometimes difficult. In many cases of baseball players, there is deformation of the medial epicondyle of the humerus. So careful determination of the isometric point is required, I think. Finally, there is a concern that the long-term results are unknown. At most, there have been was over 10 years period, and it is true that artificial ligament used in the past for the knee joint have had poor result. However, IB surgery for elbow placed outside of the joint and is a non-weight bearing joint, so there's no need to worry, I think now. In any case, careful long-term follow-up is necessary. This is my last slide. A player was performed well at Koshien this short, just 8 months after surgery. I hope to continue working hard in the future so that this is nice role. And I can help as many players as possible like him. Thank you for your attention.
Last speaker is Professor Kismeister again. Next topic is revision approach to failed UCL graft.
Here's another whirlwind tour. This is an increasing challenge, and I think that prior paper was outstanding. Presentation was outstanding, but I think we also have to understand there's a very, very, very distinct difference between those individuals throwing at a high school and a lower collegiate level, and then those that are aspiring to have real careers in the game, and some of the training techniques, especially in the U.S. that they're doing that unfortunately are causing some of these problems that I'm going to just kind of discuss real quickly with you. Again, nothing to disclose. We talked about the essential problem here, that the huge number of increasing UCL injuries that we're seeing in pro baseball, and this is the category of individuals that I deal with almost exclusively now. And then revisions, you see what's happening. 2010, 4 revisions, 2023, 27. I think we're probably 40 plus this season. 40 revisions in professional baseball. That's a lot. And it's these pitch velocity trends that are increasing, not just with a fastball, but with all the off-speed pitches as well, that are really been very, very detrimental to our constructs that we've been utilizing. And this is the game today. It's the velocity, the quest for spin, and even at the youth levels. Again, I can't speak specifically, obviously, for what's going on in Japan, but the National Perfect Game, I guess, is the closest thing that we have to your tournament here. And in 2013, 7 players threw over 94. In 2023, 57 players threw over 95. That's a different category of individuals. That's a different challenge than we're dealing with. So these individuals are getting their Tommy Johns at much younger ages and hoping to aspire and carry their careers longer. And so we're seeing this reflected in the individuals coming with prior surgeries in the draft. The past outcomes for the second Tommy Johns has really not been particularly good. We've got a 50 or 55% return to play same level, but we do have upwards of 75% returning to play at some level. And that's more consistent in the newer papers. Dr. Elatrash, a close friend of mine, published really the only paper on graft repairs, which is six graft repairs, 4 out of 6 return to play. And that's an interesting concept that he's put forth, and I've taken the ball and run with it for sure. But for me, there are 3 recurrent tear types. There are these proximal transitional tears that you see that are occurring at the corner of the grafts in confluence with oftentimes the flexor tendon, the recurrent distal tears that we see, and then you have these complete graft failures. And again, that proximal transitional tear harkens back to the anatomy paper that we had as the first paper, which was what I thought was incredibly appropriate and really shows us what's very much happening with many of these individuals throwing these high spin pitches. Our surgical options today are multiple. It's not just a reconstruction. It's brace-centric in both cases, but it's either a revision repair, a 2-layer repair, which I'm going to show you briefly, or a reconstruction or hybrid reconstruction, so tendon plus a brace. And depending upon the quality of the tissue and the construct of the tear pattern is how we make the determination on these individuals. So preoperatively, we get our standard x-rays. We get non-contrast MRI scans always. I can't tell you that I found the need to do a contrast MRI scan at all in the last 15 years. Ultrasound, rarely for us. CT scan, if I really want to look at the bony anatomy, especially somebody who's been previously operated on with a distorted medial epicondyle. And then the theater view, our MRI stress views, which are incredibly helpful, have been another added helpful piece of information in trying to determine who do we repair only and versus who do we potentially reconstruct. My treatment based upon these classifications, well, if it's a proximal injury, what I call a partial transitional tear, then I look at the fever view and I look to see how much laxity is in the remainder of the ligament, because I think that increased laxity is probably going to portend poor quality tissue, and then you have to add a tendon graft. These complete transitional tears are really probably more likely, although not always. Again, depends upon tissue quality. Game time decision, I always say, as to whether or not you have to add a tendon graft. These isolated recurrent distal tears, very often you can repair and brace. Again, need to see what the tissue quality looks like. And then obviously the complete graft failures, that's a no-brainer. You got to add tendon plus the brace. Muscle split versus muscle elevate, I think pretty much everybody doing a muscle split, but there are times where that flexor pronator mass is avulsed completely and just opens a window up into the elbow itself and already has done your dissection for you, so you just got to kind of lift that up and peel it all back. The ulnar nerve, if it's not transposed, again, generally we leave it alone. If it's grossly symptomatic or unstable, then we may consider a transposition, and we'll usually, typically use a fat sleeve to hold it in place these days. Gives it a nice, warm, comfy bed. If it's been transposed before, you got to dissect it out, and usually that's more than half the operation. If they're long time prior transpositions, the nerve can oftentimes be very scarred up. If I don't feel particularly good that day, I may call my hand surgeon in with his scopes and go ahead and dissect it out for me, so I get to do the easy part after that. If it's a primary repair of a proximal ruptured graft like this, it's a brace plus suture anchor construct. It's a 2-layer repair. The deep layer is my internal brace plus suture tape, and my more medial layer is suture anchors. We want to make sure we reconstitute that flexor zone. I think that's very critical in these individuals. Here's a typical tear pattern that we'll kind of oftentimes see. It's this high-grade proximal graft tear. It looks pretty angry, pretty challenging, but then when you get in there, look at the picture on the bottom side, you can see how thick and robust that tissue is. So it really does lend itself to repair alone, especially when the fever view, the stress views are stable. So what we do is we put the internal brace in. I take a 1.3 millimeter suture tape. I put a baseball stitch in it. I pull my brace underneath the suture tape. Again, I'm going to make the point that I believe the internal brace needs needs to go more lateral or deeper within the ligament footprint, then it has been taught to be done. I think you can run into some really difficult situations with your higher level, more elite throwers with a lot more load and spin on the baseball. And then we'll add some suture anchors there. It could be a single anchor, it could be multiple anchors. It depends on how much of that flexor footprint is pulled away. And so we pull our internal brace through, set the tension on the elbow. Then we pull our suture tape through, and you can see how nicely that tight right-hand corner picture, how it brings all that tissue back to the epicondyle. And then we pass our suture anchor sutures underneath, usually underneath and sometimes through the flexor tendon, and get a nice repair of that as well. So 2-layer repair. And I've got over 60 of these now. And what I do is I actually MRI 6 months post-op with a stress MRI. So I really get a good idea of how well these things are healing and maybe how hard I can push them on the rehab side. Because typically I tell them about 12 months or so. So they go into a brace for 6. We caution against flexor tendon usage for the first 6, and then after that we kind of step on the gas. We start their plows at 4, and actually don't start throwing till 6 months. Again, these are revision elite level throwers, so I'm very, very cautious in pushing them back too quickly. I can't afford a failure. And the graft choices for the reconstruction is typically palmaris versus a gracilis, and in these cases, again, the tissue's pretty bad, and we've got to go ahead and sometimes dissect out a nerve. But again, it's a hybrid reconstruction, tendon plus a brace in these individuals. I think that the brace adds a biologic as well as potentially biomechanical advantage. Again, drill laterally and deep proximally. I think that's a safer place to be, better healing response. Post-operatively, I always warn these individuals with a hybrid that they're going to be slower to recover their flexion. Don't overpush. More bone stock. We can adapt. Sometimes use buttons or whatnot, so we don't have to drill as many tunnels. Distally, you have a lot of latitude, a lot of leeway with that long ulnar bridge. The flexor tendon, again, that's something you just have to make sure you treat aggressively. Make sure to reconstitute the flexor tendon footprint. Our post-op protocol is a month longer with our hybrid revisions than our standard flexor tendons. We just published our results from AHMS database MLB, which is showing, again, the same older results that we had in the past that weren't quite as good. This is my own personal study. I got 156 total revisions, 95 hybrids, 61 revision repairs. You can see the dominant elite level group that I'm dealing with. So I am slower, I am more conservative with these individuals. I have had one fracture on a revision hybrid reconstruction. I've had 2 ligament re-tears on the revision repairs, one at 16, one at 22 months. They both returned to prior level of play, but they did re-tear. So I think we just have to continue to push our understanding of pathomechanics, anatomy, build better prehab programs, and better understanding of what these guys are doing with their spin on the baseball, because it's creating, obviously, huge problems for us. So, thank you.
Thank you very much. So, speakers, please come up to the stage. メディアの先生方にご質問をしてから質問をお受けしたいと思いますので、しばらくお待ちください。
Dr. Kazner, maybe while they're getting ready, can I ask you a question? You said, and you have a lot of experience screening thousands of baseball players, that the high school baseball players, about 2/3 of them have medial elbow pain. What is hurting? What structure do you think is painful?
Thank you for the question. I think the players I see already has some kind of lesion in medial epicondyle, like fragment. So it's not only UCL, might be the ossicles and something like that.
And those little fragments that you see, I believe are stress fracture avulsions. So I don't know, do you think that's the case, or do you think differently about that?
A little bit different I think they are the chronic obstacles made when they were like 11 years old or 12 years old. And it's not only, sometimes there are avulsions, but not always. I want to ask the panel about the question. When the athletes complain the medial elbow pain, despite of no apparent anatomical abnormalities after UCL reconstruction or repair, what do you consider and how do you approach it? もし肘の靭帯再建後とか修復後に修復した靭帯には問題がないのに肘の内側に痛みを訴える選手がいたらどのように考えてどのように対応されますかっていうご質問を一人一人星香先生からいいですか。日本語でも英語でもいいですか。
My priority, the dynamic stabilizer. If the FM has a dysfunctional imbalance, that causes some pain, even with the normal anatomy. And also the nerve-related pain is also bad.
Dr. Master.
Yeah, I'm going to credit Dr. O'Driscoll with this. Years ago, he actually taught me this, and the first thing I think about is nerve. I think that a huge preponderance of these individuals post-TJ with a good-looking graft and ongoing nerve symptoms can have very focal medial elbow pain with ulnar nerve entrapment. And if it's not the ulnar nerve, and or this is TOS, neurogenic TOS. I think it gets very, very often overlooked or never thought of to begin with. So.
Can I ask a question? Do those players have numbness on their fingers or just pain?
No, it's just pain. You can have very focal medial elbow pain with just ulnar nerve entrapment. And I've had a number of cases now that I've treated successfully with decompression transposition following a ligament procedure as a consequence. And in many cases, I've actually seen I should say quite a few. I've seen certainly enough cases where the ulnar nerve has been decompressed and transposed, and it wasn't the primary problem, it was TOS. And it was the TOS that was missed, and once they have appropriate treatment of the TOS, then their pain goes away.
Okay, thank you.
Yeah, if I could add, I think the greatest thing that I learned in the last 15 years, without any question, was the importance of understanding neurogenic pain, and that you can have that most commonly with no nerve symptoms of motor sensory change, because the motor sensory fibers are insulated with myelin, and it's the small unmyelinated nerve fibers that cause the pain. So those can be malfunctioning with normally functioning motor sensory fibers, but still a severe cause for neurogenic pain. It changed my practice in the last 15 years. I agree. Keith?
指先の感覚障害近くして運動障害がなくても肘の内側物は神経由来のことがあるということでした。
My question is, if that patient has some tenderness at the nerve or just the bone?
No, not a condyle. It's usually, they'll express pain and usually through acceleration toward release, but they'll express pain late cocking through acceleration along the medial elbow. And the other thing that I've seen, which is a little bit of an aside to this, but I've learned as well from my own mistakes, is that isolated posterolateral elbow pain is neurogenic TOS as well. I've got, again, a number of very clean elbows, normal looking elbow ligament, could be with or without a reconstruction. Inside the elbow, normal articular cartilage, elbow's been scoped, nothing's found, and they get a pec minor block and their pain goes away. Incredible.
You say posterolateral? Posterolateral. Thank you. Dr. Shimamura.
I have one question. Do you treat and your first contact to the players, he has an elbow pain and TOS. If you treat that you show the repair or operation, you treat the TOS by surgery. Same time? No.
No. First things first, you have to make the diagnosis. I always say diagnosis first. And if they have medial elbow discomfort with a normal ligament, you're concerned about the ulnar nerve, and you're also concerned about TOS, well, I always start proximal. So probably the top TOS surgeon for professional baseball in the States is in Dallas with me. So he and I trade patients back very frequently. And so usually I will send them up to his clinic. They do a scalene block and a pec minor block and see what kind of abatement of the symptoms occur. The EMG nerve conduction studies we usually do, but I can tell you they can oftentimes be negative in the face of either dural tunnel, I'm sure Dr. O'Driscoll can shed light on that, as well as TOS, potentially as a diagnosis. So it's the injections proximally that help me to make my first move, so to speak.
Dr. Shimamura, do you have something to add for video?
I'm sorry, what was the question? I forgot it.
The question was, もしUCL を再建したり修復したりして、で組織が正常なのに、if the player has medial pain, what would you think and what would you treat?
It means about the after operation.
After operation, yes.
Okay, I do it in the repair and internal places. Many patients, the timing of the 6 months or 7 months, they sometimes complain about the medial pain, very little pain. So almost, I think that almost this complaint is from the fascia. So maybe no absorbable
sutures.
Yes, is complaining about that. So I do it. I say my therapy, AT and OT and PT. Please release these parts, and many of them go back to the play.
So you mean the fascia of FCU?
Well, adhesion, maybe.
Adhesion?
Yeah.
Yes.
The other thing I'll add that we see, because I do a lot of MRI scans post-surgery, because again, a lot of these individuals come in and they want sometimes better answers, something pictorial. And what we do see with a lot of the braces, whether it's a hybrid or isolated, is a lot of stress reaction in the medial condyle. So it is a stout, it is a firm construct, and I think it's the next weak link in the chain, so to speak, that begins to maybe be a source of pain. But I do think the nerve is the primary issue.
Keith, can I ask for others about that? How often are you seeing osteolysis around any of these internal brace constructs in the epicondyle or in the ulna? Is it common or uncommon?
Does it include the widening of tunnel?
Yeah, the osteolysis, widening of the tunnel. Yeah.
I think in my case it's uncommon, I think, yeah.
It's common, but without symptom.
I think that it's probably, I get a lot of post-operative x-rays as well, and I do see, a tunnel widening on the hybrids, not so much on the straight brace, just do a tunnel and a dock, but on the hybrids, I'd say that there's probably a millimeter tunnel widening, at least if I'm accurately measuring off the x-ray, but it doesn't seem to be clinically relevant. The proximal, the humeral side, yeah. Yes.
Peter, you're saying that the place, the whole of the internal place is widening. Okay.
Question.
So, yes, Paolo Paladini from Italy. I have seen a couple of these osteolysis of the condyle, and in both cases, I have seen that the inclination of the screw was too acute with respect to the epicondyle. Do you think that can be the cause? This is a sort of guillotine effect on the tendon?
I think we don't have good scientific data yet to know that. It's not like work on the ACL that's had hundreds or thousands of research studies. But I suspect strongly that the biomechanical principles will be similar. And so wrong placement will probably lead to some of these problems, I think.
フローの先生方ご質問ある先生おられましたら、時間があまりないんですけども、一つぐらいは受けられると思いますけど、いかがでしょうか。Okay, no questions?
Maybe I could ask one last question then. Is there a role for preventative exercises like eccentric strengthening of the flexor group to prevent these problems? Is there a role for that? Keith, you mentioned the importance of the eccentric loading and extension.
Yes, I mean, I think that's important. The problem we have is how do you train eccentrics? We don't have a good way. I've got a friend of mine who is a former spine surgeon, has developed a line of eccentric strengthening equipment that I'm trying to get him to adapt something for the elbow. That's the problem. There is no good way to eccentrically train the musculature on the medial elbow. It's a challenge, but you're right.
Okay, thank you very much. I would like to sincerely thank the speakers for their excellent contributions and valuable insights. So, and I also thank audience for your attention. So with this, we close the session, and thank you very much.
Thank you very much, Dr. Augusto Odorisco, Dr. Hira, and all the speakers in this session. Now we would like to take a short break. We will proceed with our program at 4 p.m. We will now begin the roundtable discussion with our special guest, Ms. Kimiko Tate. This session will be moderated by Dr. Ryosuke Kuroda and Dr. Hiroyuki Suraya. Dr. Kuroda, Dr. Suraya, and Ms. Tate, please begin the session.
皆さん、こんにちは。日本語でいきます、このセッションは。 同時通訳がついているので、日本語がわからない方はマイクをつけてください。伊達公子さん、皆さんも紹介するまでもないと思いますけど、世界4位でした。はい、世界4位ですね。世界4位だった女子プロテニスプレーヤーですね。で、肩を痛めたり、膝を痛めたりして、いろいろそういう経験もおありで、今回、この会にぜひというふうにお願いしたら来ていただいて、私と黒田先生で座長させていただいた伊達さんに、伊達さんの思いを語っていただこうかなと思います。その後、フロアの方々を交えて、質疑応答というかディスカッションしたいなというふうに思いますので、どうぞ最後までよろしくお願いします。先生、何か一言。
いや、先生、ここにお呼びいただいただけで光栄でございます。ただ、僕はつい30分前まで先生の病院でライブサージェリーの手術をしてまして、ちょっと体が汗でベタベタで、手術中も19度まで下げていただいたんですけど、ちょっと体が燃えていまして、ちょっとこの燃えた勢いで頑張ります。はい。
はい、じゃあ、それでは伊達さん、よろしくお願いします。拍手をお願いします。
ありがとうございます。皆さんこんにちは。テニスプレーヤー伊達公子です。今日このような場所でお話しするということで、菅井先生の方からお話をいただきまして、アスリートとして現役の間、たくさんの怪我をしてきたんですけれども、その中で私自身が経験してきたことをアスリート目線で少しだけですけれどもお話ができればなと思います。よろしくお願いします。アスリートの怪我、ここは本当にもう避けられないものではないかなと思うんですけれども、アスリートにとって、怪我というのは避けられないんですけれども、私も数々の怪我を繰り返してきた中で、とは言ってもやはりキャリアが左右する、大きな出来事になるのかなというふうには私自身も感じてきました。一日でもやはりアスリートであれば復帰したいという強い思いの中で怪我と向き合っていかなきゃいけないというところがどうしてもあると思うんですけれども、その中ででもやはり無理をしてしまえば競技生活、自分のキャリアというものを縮めてしまうということにもなりかねない、その不安と恐怖と向き合いながらやっているということがあるのかなというふうには思います。でそこでどういうふうに怪我をした時に、向き合っていくのかということがとても大事なのかなというふうに思います。はい。で、私自身テニスプレーヤーとして2度の現役を経験してきたんですけれども、ファーストキャリアというのは90年代になります、約8年間になるんですけれども、その時代には私の経験でいうと、膝の内側側副靭帯というものを、ウィンブルドン4大大会でグランドスラムと呼ばれる、大会で芝の天然芝なんですけれども、そこで足を滑らせて、もうあさって3日前かな、3日前ぐらいに、会場で練習をしている時に芝生で滑って、膝を内側に、転んで損傷させてしまったというようなことが一度あり、その時は大会を出場することができなくて、もうそのまま日本に帰って診断を受けるということになったんですけれども、この時は手術をしないで済んだという、ギリギリ手術なしでなんとかできるということで、しばらくリハビリを繰り返して復帰をしたということになりました。でその後はもう後半はやはり右の肩の腱板炎ということに悩まされながら戦い続けていて、ひどい時は本当にこのグラスのコップが手で持てないぐらい肩が痛いというようなことを状態で、プレーを続けた後、1回目の引退という形になりました。ファーストキャリアを引退したのが私の場合1996年になるんですけれども、また2回目の、キャリアをスタートする間なんですけれども、その時は1 一度だけ公式戦にテニスの試合に出たことがありまして、でその試合ダブルスだったんですけれども、試合の途中でアキレス腱を断裂しました。でその時に、保存を選択して、その当時、現役の選手ではもうなかったので、保存ができるのであれば、手術はできることなら避けたいという思いから保存療法を、生活に支障がないのであれば保存療法を選択したいということで、保存療法を私自身は選択をしました。でその後、アキレス腱を切ったんですけれども、2004年に、フルマラソンにも挑戦をして、特にアキレス腱への影響ということも、感じずにしっかりと走り切ることもできたという経験もできました。でセカンドキャリアになるんですけれども、2008年に、2回目の現役を復帰しまして、ここは整形外科とはちょっと違うかもしれないんですけれども、やはり回復力っていう37歳からのセカンドキャリアをスタートしたので、肉離れ痙攣というものに苦しむセカンドキャリアだったんですが、肉離れの時には PRP をトライしてみたり、痙攣があまりにも続くので、ちょうどニューヨークの全米オープンの大会だったんですが、そこからサウスダコタという私には聞いたことがない、ところに飛行機で飛んで汗の専門の先生に見てもらったりということもトライをするようなセカンドキャリアにとってはいろんなことに悩まされることが多かったかなと思います。そして、一番大きな私にとって初めて、考えもしなかったことが起きたのがこの膝なんですけれども、振り返ってみると、予兆はやっぱりあったんだなということは思います。で2015年の9月、大会期間中なんですけれども、試合が終わってみるとなんか膝の周りがぷくっとちょっと腫れた、今までに経験のないような腫れを感じるようになって、でそこからやはりもうガタガタガタっと悪くなっていくんですけれども、2016年2月に最初の手術をするようになるんですけれども、実際遡ってみるともう2015年の9月には水が溜まるようになったんですけれども、その前にやはり膝が痛くて、試合を、思うようにできなくって、アメリカの途中で現地のフィジオたちに協力を得るようなことで、繰り返しやるようなことが実はあったんだなと振り返ってみるとありました。すでに9月のこの試合の時に膝に水がたまるようになって、実際にはその後ただ試合には終わって翌週がそれこそ韓国の試合が入っていたりというところで、どうしても試合が続いてしまうというところで、私は9月10月11月年内いっぱいまでは試合を繰り返してしまったことも、大きく影響していったのかなと思うんですけれども、とにかく試合に、フランスにも行ってフランスでも試合が思うようにできない時間をこの数ヶ月、続けてしまって、そしてどうしてもこの1月の全豪オープン、テニスの4大大会の一つ1月にある全豪オープンにやはり出場したいという思いから1月ここまでなんとか粘って、トレーニングをしてっていうところでここを目指したんですけれども、やはりここでかなり痛みが感じてしまったということが実際ありました。そしてもうここでこれはもう無理だというところになり、2月に手術を1度目半月板の手術をして、見たところやはり半月板だけではなく、軟骨の方もやらなきゃいけないというところで、実際に手術を黒田先生に、手術をしていただくというところで神戸大学で2016年4月にお願いをしました。その後はもう回復させていってリハビリをしていくしか復帰への道はないというところで、初めて人生にとってこの膝の手術が私初めてだったので、本当にこう言われている通りに自分ができなかったことが少しずつできていくんだなということをすごく実感しました。 5月、4月に手術をして、5月の時には車椅子に乗って、我慢ができなくて車椅子に乗ってテニスをしてみたものの、やはり車椅子でも膝が腫れ、少しずつ動けるようになってもまた膝が腫れっていうことを繰り返しながらも、カレンダー通りにできるようになっていくことが一つ一つ増えていくということを経験しました。そしてトレーニングにしても立位でできることが徐々に増えていくというところを経験しながら、1年後の復帰ということを目指しながらやっていくということで、やれることが増えていくことの嬉しさというのをすごく実感しながらやっていたかなと思います。そして年内ギリギリに、実際球出しからボールを球出しというのはボールを手で出してもらって打つというところを繰り返しながらやっていきました。そして4月ですね、そこに、やっとコートに立ってエキシビションを、実際の本当の復帰に向けてのエキシビションというものも、現役の選手と一緒にやることができました。で5月になってやっと1年ちょっとですか、1年と1ヶ月ほど、1ヶ月弱になるんですけれども、復帰戦を岐阜で行い、やっぱ不安から少しテープは巻いた状態でプレーはしたんですけれども、なんとか戦い抜くことができたかなというような状況でした。そしてその後、岐阜を復帰戦からそのまま、韓国に行って、下部大会に出るんですけれども、ランキングというのが落ちていってしまうので、その中では下部大会というものを何十年間ぶりに経験をして、スコアカードっていうのを高校生以来に自分でスコアカードを変えるっていうような経験も膝の怪我を機にやることもしてました。そして、膝は少しずつ良くなっていったんですけれども、100% 何も感じない状態っていうことは難しかった中で、やはり膝が使えないアキレス腱を切ってるっていうこともあったのか、使えるところを一生懸命使おうとするからなのか、肩の痛みを、その後感じるようになりました。で6月から7月遠征に出たんですけれども、この遠征が私にとっての海外の遠征が最後になってしまうというところで、肩がもう全くもう上がらなくなってしまって強い痛みを感じるようになってしまったというのがこのアメリカ遠征です。その時も戦い抜くこともできなかったんですけれども、希望を捨てず自分なりにできることを、トレーニングは続けながらアメリカの時間を過ごしていました。そして帰ってきてからもやはり、膝も水を抜くということが続いていくような時間ではあったんですけれども、なんとか私の中では、日本でもう一度引退の、しっかりとできる状態で戦い抜きたいというところで、皆さんのお力をお借りして、2017年9月に最後の引退試合というところで有明で、この時には黒田先生にも会場の方に来ていただいて、見守っていただいた中で、戦い抜くことが、プレーは肩も菅谷先生にもう毎週のようにステロイドの注射を打って、先生こんなにステロイド注射打っていいんですかって聞いたら、もうあとは引退した後に俺がちゃんとするからもうやれるだけやってこいと強い言葉をいただいて、引退試合に挑んだことをよく覚えています。で、引退をしてその後11月ですね、肩の手術をして、見ました。肩は痛いよって他のアスリートからよく聞いて、膝以上に痛いよって言われていたんですけれども、本当に肩の手術の後は痛くて寝れなくて、真っ平らにベッドで寝ることができなくて、いつもこうやってかがんだ状態で2時間おきぐらいに、少し横になってみるのなると痛いし、こうやってかがんだ状態でしばらく耐えてっていうようなことを肩の手術の後は繰り返して、肩の手術だけはもう二度と嫌だなって思うくらい痛かったです。そして、 2017年の11月なんですけれども、その後、肩の動きもだいぶこの右側の方がだいぶ良くなった時なんですけど、かなり頑張ってここまで、行くようになるような、本当に手術をした後というのはしっかりとやるべきことをやっていると、こうやって自分の体っていうのは変化していくんだなっていうことを本当に目の当たりにした私の、手術を通して感じてきたことかなと思います。で、ここまで写真をいろいろと入れてみたんですけれども、私が数が怪我が多いというのか少ないというのか、キャリアとしてそれなりな時間をテニスプレーヤーとして過ごしてきた中で、少ない、比較的私は少ない方なんじゃないかなとは思っているんですけれども、手術をするにあたっていろんな私の中にも悩みが起きました。でその時にやはり感じたことっていうのはやっぱり任せきりではなくってやっぱり主体的に自分自身のことに対して向き合う、そのためには自分の体をやっぱり知るということがとても大事なんだなということを学びました。テニスだけに限らずアスリート外で体を鍛えるとか、コンディショニングとしてキープするとか、そういうことはとても前向きに知ろうとしたり取り組んだりっていうことはできると思うんですけれども、やっぱりこの体の中のことになってくるとなかなか自分自身で向き合うということが非常に少ないのかなと、これもちろんアスリートによると思うんですけれども、私なんかはやっぱりすごくそこに向けてっていうのが怪我が少なかっただけに、向き合うことが少なかったのかなと思うんですけれども、やっぱりそこを向き合っていくっていうことの大事さを知ることができたかなと思います。ただその中でも私は常に、どんな時も自分の、練習を取り組む時にしても自分の予定を決めている時に、今日の体調っていうものを自分の感覚っていうものをすごく大事にしてるんですけれども、体の声を感じ取る力、自分がどう感じどうしたいかっていうところを非常に重要視するところはあるので、そこはしっかり残しつつやっていくことが自分の最適な選択になっていくのではないかなっていうことは感じました。ただ今育成プロジェクトというところで私はジュニアたちと接することが時間が多くなっているんですけれども、ジュニアたちになればなお自分の体を知るっていうその感覚っていうものをまだジュニアたちは自分の体がどうなると調子がいいとか、どうなるとこう怪我に直結することにつながるかっていうようなことがまだ感じ取ることが難しいっていうところもあるので、ジュニアたちに今私の立場では何か異変が起きたらすぐに画像を撮るとか、すぐにドクター、自分の信頼できるまずトレーナーと話した上で、画像を撮るっていうことをできるだけ早くするっていう、画像を撮ってもし何もなければそれを安心してまた競技に戻れるので、まず画像を撮りに行くっていうことをできるようなことを今育成に携わるようになってからは、ジュニアたちに伝えているっていうところでも、アスリート自身の意識を向上していくっていうことはとても大事なのではないかなというふうには、思っています。そして先ほど最初の方にも触れてはいたんですけれどもやはり私は怪我をして、すごく感じたことっていうのがやはりドクターとアスリートの信頼関係っていうものでした。医学的な部分っていうのは本当に無知なところが多々あるアスリートの中で、その判断っていうのはとてもどういうことができるのか、どういう状況なのかっていうことを、示していただくっていうことはとても重要なんですけれども、やっぱりアスリートにしか感じられないこの焦り、不安、恐怖みたいなものを抱えながら必ず病院に行っているっていう現実の中で、なんかこうアスリートの予断じゃないんですけれども、この状況はどうなんでしょうっていうその予断のところになんか、耳を傾けてもらえるとアスリートはとても心が安らぐのではないかなというふうなことはとても思いました。 そして、そこを考えるとやはり、アスリートの焦り不安っていうことと、医学的な、判断っていうところのどう橋渡しをしていくかっていうことから、信頼関係っていうのは強い信頼関係っていうものができていくのではないかなということをとても感じます。でそれが結果的にアスリートの一日も早い復帰っていうことにつながっていくのではないかなというふうに思っています。最後になるんですけれども、アスリートが求めることっていうことのまとめとして、やはり何が起きているのか、できるだけ最後まで、復帰するところまで見通しを立てた、ところを選手たちっていうアスリートっていうのは知りたい、理解したい、イメージをさせたいっていうところがあるのではないかなというふうには思います。そして、そこの復帰に向けたロードマップですね。やはり私もそうだったんですけれども、できることがあるのであればもう何でもやりたかったんですよね。やっぱりみんなリハビリのモチベーションはどこから来るんですかとか、よくそのモチベーションを怪我した後に続きますねとかって言われたんですけど、私はそのリハビリで心が折れるっていう不安は自分の中にはもう全くなかったです。やれることがあるんだったらそれは全て、やりきりたい。もちろん年齢的なところで自分自身が戦い続けられる時間が限られていたっていうこともありましたけれども、復帰ができるのであれば、何でもやってみたい、知ってみたい、トライしてみたいっていう思いがあったので、そのどこまでリスクを取るかっていうことが、これ以上やったらこういうことが起きますよ、ここをやらなければ、ここだけは守られますよっていうような一緒に考える姿勢っていうものを見せていただけると、選手たちっていうのは取り組むモチベーションにつながっていくのかなというふうには感じます。そして3つ目なんですけれども、私自身アキレス腱の時に手術をするのか保存にするのかっていうことに悩んで、その時も1日も早い方がいいですよっていう意見もあれば、今しても明日しても1週間後にしても変わらないよっていうような選択肢があったっていう中で、最終的に私はアキレス腱の場合は保存を、そして肩もその当時は保存っていうところで選択をしていたんですけれども、膝の時には今度は培養するかどうかとかっていうこともいろいろ見ながら、従来のやり方なのか最新のやり方を取るのか、そういうところを、一つの中で示してもらえると、共に、復帰への道というものの、道が開けるのかなというふうには思いました。そして4つ目なんですけれども、これが一番私の中で大きかったかなと思うんですけど、やっぱり心への配慮っていうところが一番大きいかなと思っていまして、一緒に、コーチに求めることもそうなんですけれども、やっぱり今テニスというスポーツは個人スポーツであるものの、チームというものがだんだん大きくなってきて、一人の選手に対して、マッサージがいて、フィジカルトレーニングがいて、コーチがいて、エージェントがいて、栄養士さんが中には人がいてっていうような感じでチームができてきていることが当たり前になっている時代なんですけれども、やはり、今回その膝と肩をやった時にもそうなんですけれども、やはりアスリートである、私と、そしてドクターと、後にリハビリをやっていく、フィジオと、そしてその後のトレーニングをする時のトレーナーとっていうところの連携っていうものがやっぱりスムースにいけばいくほど、選手たちっていうのも安心する部分が大きくなっていくっていうところで、一緒になってチームとして戦ってくれる、一緒になって向き合ってくれるっていうこのパートナーとしての姿勢っていうことが力になっていったっていうことが大きいかなというふうには思っています。医学的専門性というところと選手 対してアスリートに対しての共感っていうところと、そして信頼関係、そこが重なっていくと、非常にアスリートの立場とすると、充実したというか怪我に対して、前向きに捉えていくことができるようになるのではないかなというふうには感じました。私自身がもう本当に菅谷先生と、黒田先生と、本当に信頼関係を築くことができたっていうことが、本当になんかこう私のいろんな思いを受け止めてくれたことが、再びコートに立つ力を与えてくれたことはもう間違いないかなというふうには感じます。そして最後に、怪我というのはネガティブにはなる部分が多いんですけれども、私自身はそれは終わりではなく、いろんな気づきと、気づきの中からの学びと成長のきっかけをくれたものが私にとっての怪我だったかなというふうには感じています。以上となります。ありがとうございました。
ありがとうございました。まさに今回のテーマであるアスリートマネジメントにぴったりのレクチャーでした。では私たちの中央の席にどうぞ。この後フロアからもいろいろ質問を受けながらまずフロアから皆さん何か質問ございますかね。ちょっとこれを聞いてみたいとかそういうような話。写真もいいですけど質問もお願いします。
僕いいですか。
どうぞ。
これ僕治療してる時にあまり聞けなかったので、ファーストキャリアで一回引退されて、でその、引退になったっていう話は伊達さん時々テレビとかマスコミでもお話しされるのでなんとなくわかるんですけど、その後37で、よしもう一回やるぞっていうこの意気込みがですね、僕にはちょっと考えがたい、このトップへの復帰っていうこの心境っていうところを聞きたいんですけど。
なんかでもこう振り返ると2年に1回ぐらいこう何かチャレンジすることをやってたんですよ。さっきマラソンの話も入れてたんですけど、気が付くと2年に96年に引退をして98年にエキシビションをやってるんですね。98年の後また2000年ぐらいにエキシビやったり、なんかこう2年に1回周期でなんか自分に目標を掲げてそれに向けてやるっていう、なんかこう意識的ではないんですけれども、振り返るとそれぐらいのスペースでやってた。でマラソンもそのうちの一つで、テニスでなきゃいけないっていうよりはやっぱりスポーツの何かをやりたいっていう欲望みたいなものが多分、あったんだと思うんですよね。で、37の復帰へっていうのも実はドリームマッチっていうのがあってエキシビションがあったんですよね。でそれに向けて、練習をしていったんですよね。でトレーニングもやってました。でだんだんと自分の中でなんかこうふつふつとこう勝負魂が戻ってきてる。でもそれをなんかこう自分で一生懸命蓋をしてたんだと思うんですよね。でそれを、今や夫になるんですけど、ドイツ人だったんですけど、彼が「キミコはやりたいんじゃないの?」っていう一言がきっかけで「いやいやいやそんなわけはない」って自分でこうそれを否定していたんですけど、でもなんかこうそれを言われてから自分はもしかしたら本当にやりたいっていう自分がいるのかもしれないっていう自問自答の先に決断をしたっていう感じですかね。はい。
先ほど黒田先生のところで膝の手術を受けた後に、1ヶ月かそこらでなんか車椅子に乗ってテニスしてますよね。
とかしてないです。
許可してない
ダメって言われました。どっちかって言ったら絶対ダメって言われたんですけど。
だからやっぱりそういうところをどういうふうになってもこういう方ですから言っても聞かないっていうことが
ラケットを振るっていう野球とかテニスとかありますよね。素振りをするっていうのは下肢の手術をして、素振りするのは感覚をねこうキープするという意味では握るのはいいと思うんですけど、まさか車椅子でやるっていうのは僕は全く想定してなくてですね、突然その動画が送られてきて、
しかも先生車椅子だけで我慢できなくて肩松葉で打ったんですよ。
先生肩松葉でテニスをやっててですね、これは一切僕許可してないので、これはアスリートはやっぱりすごいですね。なんかこういろいろ考えるんですね。こうやれることを。そういう意味では素晴らしい発想は素晴らしいと思うんですけど、もうドキドキですよね。はい。
言うことを聞かない選手ってどういう言い方されるんですかね。
このぐらいのトップレベルの選手は基本言うこと聞かないんですね。
でも私入院中は優等生です。ちゃんと先生の言うこと聞いて、ちゃんと寝て。
もう一つね、僕は本当これ言っていいのかな。伊達さんね、スキーが好きなんですよ。スキーが。
そうでしたね。
そう、それでプロのテニスの選手はスキーしたらダメなはずなんですよ。スキーってすごい膝の怪我するんですよ。だけど彼女はですね、結構こっそりスキーに行かれていて、ね、僕そっちの方がドキドキしてました。
ファーストキャリアも言ってました。
言ってたんですね。
トップアスリートの治療っていろいろテニスに限らずいろいろやってますけれども、特殊なんですかね、だってさ、その中で。
いや、どうですかね。
僕は思ったのは、とにかく自分でいろいろ考えます。普通はトレーナー任せであったり、ドクターに聞いてそれだけやる受け身の人多いですよね。でも彼女は結構自分で考えてこれをやったらどうか、これはやれるんじゃないかってすごくたくさんあってですね、僕も不安ではありますけど、やっぱり選手がこれぐらい積極的になるとこっちもですね本気にならざるを得ないじゃないですか。もうずっとなんか見とかないといけないっていう感じになるので、それはそれでかかるっていうか、いいのかなと思うのと、たとえトップアスリートであっても一般アマチュアのねアスリートでも先生、なんか傷の回復ってそんなに変わらないんでしょう。それをちょっと聞きたいです。先生いっぱいトップアスリート
僕は肩に関してはトップアスリートの方が早いですね。要するに作った手術したところの回復の問題ではないと思うんですけど、例えば周囲の筋緊張とか筋がいい筋肉っていうか筋バランスが戻りやすいというか、それはありますね。やっぱり一般のアマチュアの人の方がアマチュアっていうか一般の方の方がやっぱり遅いような気がします。だからアスリートがね、でも早いんだけど逆にここからここまでだよってことをきっちり言うと絶対やらないですよね。再断ですとか絶対やらない。僕は以前手術した体操のオリンピック選手なんですけど、彼は3ヶ月だなったら手をもう結構上げていいよって話をしたんですけど、上げなかったですね。なんか僕の肩甲骨ちゃんと動いてないような気がするんで、もうここ以上やりませんと言ってて、やればできるんですけど無理にやりませんとか、なんかすごいボディバランスというかボディイメージっていうか、それが良かった気がします。だから伊達さんも多分早いんだと思うんですけど、でもまたちょっと早いのとまたその車椅子テニスはまた別物です。
そうですよね。いやでもやっぱり初めてだったので、なんかこう1年かかる、復帰までに1年かかる、でも自分の意思は絶対に心も折れない自信がある、じゃあ8ヶ月にできるんじゃないかと思ってたんですよね。やっぱりそこをやることを増やせば、なんで一生懸命やれることを探そうっていうのはありましたね。でも膝に関してはないってことだったんですね。
可能性はあるんですけど、どうしてもやりすぎると水が溜まったり、痛みが出たりっていうことがあると、僕は伊達さんの講演の中でアスリートの心に耳を傾けてほしいっていう、これはもちろん大事なんですけど、耳を傾けすぎるとですね、ちょっとそっち寄りになっちゃって、
なるほど。
やっぱり線引きっていうか、あんまり希望を叶えていくと逆にリハビリが こう悪くなって止まったりっていうのがあるんで、ここなかなか難しいんですよ。耳は傾けたいんですけど。
ぐっと来られてるんですね。皆さん。
多分皆さんそうだと思いますよ。みんなあれやりたいこれやりたいって言うけど、ダメダメダメダメって言って、それでアスリートの方がなったものドクターは全然私も
そこまでは思わないですけど。
っていうことになることも僕はあるとは思うんですよね。そうですよね、先生方ね。
そうですか。
やっぱりダメなものはダメっていうので。
ティッシュヒーリングの時期ってのは多分決まってますよね。
なるほ
ど。だからそれなんですよね。まあ、たまたま今の前のセッションでそのティッシュヒーリングがあるんだけど、もっと早く着させるためにインターナルブレスを使って腹筋を早くなる。そういうことをしているであればまあ別ですけど、普通の手術であるティッシュヒーリングの時期ってのはどうしても変えられないんじゃないかなと思うんですよね。
そういう知識もね、ない中で、とにかく一日も早くっていう思いだけでこう言ってしまうので、そうですね。方はじゃあ、年齢はでももちろん、復帰への道っていうのは、これが私が例えば20代だったら変わってたんですか
？20代で鍵盤切れませんか？
本当ですか？切れない？
切れません。あれは思いっきり年齢的なものなんですよ。
寂しい現実ですね。
腱板炎というふうに診断を受けた頃は多分腱板切れてないと思いますよ。まあ、あるとしてもまあ部分断裂。
部分断裂。そうなんですね。
腱板炎っていう診断出てること自体おかしいですね。腱板炎っていう診断は普通はちゃんと肩の専門医だったらしないですね。
なんていうんですか。
腱板不全断裂とか、肩峰下滑液公炎とか言いますから。
なるほど。
でも今日は出てきてなかったけど、伊達さん、僕は手術した頃は、その前よく股関節、この大天使のところの活液包炎ですごい苦しんでおられたっていう。
今も苦しんでますよ。
ああ、そうなんですね。
はい。大天使活液包炎って今までそれ2回目の一番最初に活液包炎になったのは2回目の現役の途中なんですけど、リターンで打った瞬間に激痛がビビビって走って、それは右だったんですけど、それでもう歩くのも痛い、何するのも痛いっていうのが一番最初でしたね。で、ある時右がまだ痛い時に左にも来て、もう本当歩けなくなったぐらいありましたね。で、最近もまた痛みが感じることもあったりして、それで今日高平先生に
高平先生、ちょっとご質問一言ご質問、その活液包
先生のとこ行った時は活液包炎の症状ではなく、また別の痛みですよね。
どうもありがとう。私のところに来られた時は、やはり股関節周囲ということで、伊達さんが大天使活液包炎ということだったので、そこを中心にまず初め見させていただいたんですが、部位はそうなんですけども、どうも動かしてみたりすると、なんかちょっと、もうちょっと違うんじゃないかっていうのがあって、MRI を取らせていただいたんですけども、そうすると、じゃあ大天使活液包炎とかそれほど炎症所見がなくて、でもやっぱり関節内に多分滑膜炎を起こしていて、結構エフュージョンがあったものですから、一応中にやっぱりさっきのステロイドの話じゃないですけども、ちょっと注射してみましょうか。伊達さんすごくいろいろ治療たくさん受けられてたので、もうすぐステロイドですよねなんて言われちゃって、なんかすごく私もさすがだなと思ったんですけど、ちょっとそれ出していただいたら、痛みがその後動きも良くなって、全体的に良くなったんですよ。だから多分そこだけというよりは、関節内の問題もあって、どこまで言っていいか分かんないんですけども、ディスプラジアとかいろいろちょっといくつか見つかるものがあったので、それをちょっと拝見させていただいています。
なのでいろいろ一難去ってはまた一難で。
僕は一つ安心材料はですね、伊達さんはさっきも言ってありましたけど、私は絶対心が折れませんからっていうのを最初から宣言されててます。こんなアスリートは珍しい。絶対私心は折れない。そう言っていただけると心強かったですよ。
本当ですか？
大体心折れますね、途中で。
やっぱ折れるものですか、トップアスリート。
折れる人いますよね。
トップアスリートは折れてる場合じゃないでしょ。
いやでも先生、
でも心がダメになってくる人こういうのしかね。
男子はなんか特に
女子よりも手術に限らず。
まあそうですね、そこはそうですね。まあ最近はやっぱりこう年齢とともに体を動かすことが大好きな私にとって動かしすぎるとやっぱりどこか痛みが必ず出てくる、もう本当に次から次へと何かが起きるんですけど、やっぱそこのこのやりすぎないやらなさすぎないのバランスっていうのが一番難しいなっていうのを感じている今日この頃です。
もちろんどうぞ。
北澤大学の高平ですけども、先ほど桑先生の話とちょっと少し近いところもあると思うんですけども、私、日本テニス協会の維持委員をさせていただいて、そのメンバーの先生方も今日たくさんいらっしゃるんですけども、女子のWTA からの依頼で、先ほどのジャパンウィメンズオープンも私、そのドクターもさせていただいたりしてますけど、伊達さんが引退した46歳ですかね。
46ですかね。47、46、47ですね。
で、当時我々まだ若い時じゃないんですけど、年齢が低い時にナブラチロワ選手がすごい年齢までやってたなっていう印象があったんですで、調べてみると38歳ってなったんですね。相当なすごいことで多分最高齢なんじゃないかなと思ってますけれども、やっぱりそのコツと、さっきのお話にも共通するところもあるかもしれませんが、なぜそういうのができたのかっていうところを知りたいですし、それを今度ジュニアの方たちに、これからの方たちへのやっぱりどういうふうにそれを進めて当然いくんでしょうけども、大体昔はあれですね、アメリカの選手なんかも20歳とかそのぐらいで女子はもう大体もう引退っていうのは常識の中でもうすごいことをされたんだなと思ってますけど、もしよろしければそのあたりも教えていただければ。
はい、まず一つは26で引退してブランクがあった中からの37で引退が46、7ぐらいだったっていう、この26から37までのブランクがあったっていうのは大きいというか、事実としてあるっていうのが一つなんですけども、今おっしゃっていただいたように、80年代90年代っていうのはプロっていうのは、大体みんな高校卒業してプロに転向して、キャリアが大体10年ってテニスは言われていたんですけれども、ただ今はキャリアが非常に長くなってます。でスタートも昔で言えばヒンギスが14ぐらいから出てきた時もありましたけれども、今もやっぱり定年ガウフっていうアメリカの選手も14ぐらいからトップレベルで活躍するような時代になっているので、スタートがまた早いっていうこともあるんですけども、同時にキャリアが30代でも活躍する選手、アメリカの選手では大学を卒業してからプロに転向して活躍する選手も増えてきているので、30代でも十分に戦えるっていう選手が多い中で、キャリアがフェデラー、ナダルにしても非常にキャリアが長かった。でそこはなぜそうなってるかっていうと、やっぱりフィジカルがすごく科学的になってきている。そしてこういうドクターとの連携っていうものも非常に昔よりも良くなってきているっていうことがキャリアを伸ばすことにつながっているのではないかなというふうには思います。はい。
すみません、京都から来ました。今、京都の音羽病院で、整形外科してます奥田です。テニスを代表チームとかいろいろお世話になってました。2つ教えてほしいことがあって、1つは、先ほど伊達さんが今のプロジェクトとかで構造を見たりとかいろいろ早めにお医者さんに行くようにっていう話を言っておられたんですけど、多分僕一番初めにこのテニス協会の方の仕事に関わった時にはシューチャレとかにも行かせていただいたんですけど、シューチャレの時にはあんまり言い過ぎるとみんなが弱く育つからやめてほしいって修造さんに言われたことがありまして、どっちなんかなっていうのが一つの話です。でもう一つの話が、テニス協会のチームはすごく須貝先生、黒田先生、高平先生、みんなすごい先生がいっぱいいるので、僕とか中間の先生は、中間の僕とかは診断をつけて、それで手術の偉い先生に相談するっていう方針を持ってるんですけども、 なかなか時間を設定して、トップのアスリートの人は初めから上の選手に行ければいいんですけど、トップじゃない中間ぐらいの選手の時には、外来時間めっちゃかかるんですよね。ワンストップで一応終わらせてあげようと思って、僕頑張っていろんな検査の手配とかもしてやるんですけど、やっぱり1時間ぐらい検査の手配もしたりしてかかっちゃうと、もう他の患者さんとかスタッフの人とかたくさん重なると叱られたりするもんで、あの辺りどれぐらい時間があるのかなと。今日も明日行っていいですかって言って、明日行って診断つけて、他の先生にも相談してきますから、診断書書いて、紹介状書いてくださいって言われたりすることもありますんで、そのあたりどんな感覚なのかなっていうのは、選手に直接あんまり話をしたことがないので、その時間の取り方とか、そのあたりの情報の集め方っていうことを2つ教えてもらえたらと思うんですけど。
情報の集め方。
伊達さんも多分いろんな先生のところには関わられてて、でみんなで情報を持っててです、今日から明日から手配ですけども、そういう選手とかもみんなどの先生に行けばいいのとか、みんな情報を持っておられて、でも一番初めにここで診断つけやすいから、ここでとりあえず聞いてとかってステップ持ってはる。
どこまでこの場所で話していいか、話したら良くないことがあるのかちょっと分かんないんですけど、全部 OK ですか、ここだけの話で。私は菅谷先生も黒田先生も紹介していただいたのは、普段マッサージをお願いしている、もともとJISでマッサージに入られている、マッサージセラピストの方がいらっしゃるんですけれども、高平先生の紹介ももちろんその方からなんですけれども、私はその方を信頼しているので、自分が何か体にそのマッサージ針を超えたところで何か必要っていう時には、その方に実はこうって言ったら、その方もやっぱり必ずまず画像を撮ったらっていうことも言っていただけますし、肩だったら菅谷先生、膝だったら黒田先生、股関節だったら高平先生っていうアドバイスを言っていただける人が私にはいます。それが一番で、それで現役の時に遡っていくと、テニスの選手ももうさっきも言ったんですけど、どうしてもツアースケジュールがもうずいぶん前から、もう2ヶ月3ヶ月前から決まっているので、それに合わせて練習トレーニングをピーキングを合わせて遠征に出てって試合やって日本帰ってきて、また一旦リセットさせてまた出ていくっていうようなのを繰り返しをするので、急に何かそこに体の異変が起きた時にやっぱり出発するまでに画像も撮っときたい。でそのためには紹介状が欲しい。明日紹介状を書いてくれる人っていうことをやっぱりかなり無理にお願いした経験も多々あります。昔今であればJISのドクターに書いてもらうということもかなり、トップ A グループ A チーム B チームとかに入っていればそこのクリニック使えたりするので、そういう対応 MRI とかも対応してもらえる時代になりましたけれども、ファーストキャリアの時とかはそういうものがなかったっていう中で、自分のこのつてだけでやらなきゃいけないという時は無理にもう診断書をとにかく書いてください、こういうふうに書いてくださいっていうのはその試合出場するものをしないってなると、メディカルでやると罰金がないんですけど、私たちはそういうのがなくエントリーをやめるってなると罰金がもうすぐ伴って、ランキングによっても罰金の金額が変わってくるっていうのがあるので、診断書にこういうふうに書いてほしいっていうふうにお願いすることはありました。
テニスとか各競技の、特にテニスとかのルールを僕らが知っておくっていうのが大事っていう、
そこもやっていただけると選手側としては助かる部分が大きいかなと。
あと一番初めの話で知りすぎると困る、あかんって言われた、松岡さんがジュニアの人にいろいろ情報を知りすぎると強い選手、
ちょっとその意図がちょっとよくわかんないんですけど、なんでしょうね、想像するに。
風邪とかで薬をこんなんあるよとか、こんな治療があるよとかいうのを言うと全然考えなくなるからっていう意味で言われたのが、もう20年代のチーム入った頃なので、僕は2003年とか4年の頃に修造さんにそう言われて、松岡選手に言われて、 じゃあどうやってメディカルを手伝えばいいかなと思ったことがありましたので。
ちょっとね難しいんですけど、私だったら自分の経験としてやっぱり一旦いろんな人の、それぞれの立場の、意見アドバイスっていうのを受け入れてやっぱり自分自身が選べるように私がもし松岡修造さんの立場だったら一旦は聞いてそういう考え方そういうことがあるんだねでも最後に選択それをやるかやらないかっていう選択を自分でしたらっていうふうには私なら言うかなとは思う。
じゃあジュニアもそういうふうに育てていけばいいということですかね。
私はそれがいいかなというふうには思ってます。はい、すいません。
先生どうぞ。
よろしいですか。大分から来ました総帥警官のそうですけど、今の高平先生とか今の質問の奥平先生と一緒にテニスのスポーツ科学委員で携わっていて、現在も70過ぎてテニスしてるんですけど、ちょっとこのアスリートマネジメントの話はしっかり出ましたので、ちょっと違うことでお尋ねしたいんですけど、僕かなりもう年取ってますので、ぜひここでちょっと皆さん方も年取ってる方は覚えてると思うんですけど、ウィンブルドンのブラフトのですね、それ全然違う話で申し訳ないですけど、ぜひ伊達さんをお会いするたんびに聞きたいなと思ってたんで、そういう方もおられると思うので、あえてお伺いしますけど、5-1ですか、5-2だったですかね、ベスト4にかかるところで、勝てたんですね、絶好調で、伊達さんが。で、グラフがもう負けるという時にね、日没延期というふうになったでしょ。明るいんですよ。僕テレビ見ててね、あれと思って、何やこれはと思ったんですね。で、再試合っていうか、翌日、グラフがまた調子を取り戻したからとか知りませんけど、私の旦那が負けましたけど、その時にね、伊達さんは不平不満が何も言ってないのに感心したんですけど、その時の心境ですね、あれ僕は今思ってもね、人も全然明るいんですよね、夕方。あれは納得いかないと思いますけど、僕は勝った人もしょうがないんですけど、どうなんでしょうか。
ありがとうございます。よく記憶に留めていただいてありがたいです。はい、当時はですね、今はウィンブルドンのセンターコートには開閉式屋根がついているので、途中で雨が降っても屋根を閉めて試合が日没10面ということになることはもうなくなったんですけれども、私が戦った1996年は屋根がなかったので、その日は朝から一日雨がずっと降ってたんですよ。それで WTA ってテニスの協会の方から「もう今日は試合ないね」って言われてたんです。で私ももう今日はないなと思って、もう頭の、心のスイッチも入れないだらけた状態でもう今日はないな、キャンセルが出たら帰ろうかなぐらいに思ってたんですけど、6時半、7時ぐらいに1試合目が、サンチェスと誰だったかな、レイモンドっていうアメリカの選手だったと思うんですけどが意外にも早く終わっちゃったんですよ、雨が止んで。で7時半ぐらいにやるって言われたんですよ。で7時半からで日没が大体9時、9時半、9時ぐらいからだんだん暗くなるんですけど、入るって言われたんで、急遽バーって準備して、試合をやってワンセットオールになって9時ぐらいだったんです。で9時から1セットやるには時間がやっぱりちょっと足りない、可能性が高くなるっていうところで、ワンセットオールになった時にスーパーバイザーが私の横から歩いてくるのが見えて、スーパーバイザーが出てくるともう決定権が彼にあるので、もう覆らないっていう判断を私の中ではしてしまったのと、その前からセカンドセット私が追い上げる時にグラフがもう主審に何回ももう訴えてたので、なんとか止めたい、彼女は止めたいっていうところで、ナンバーワンステフィー・グラフなんで 戦闘類になったら大会側も中断する方がいいだろうという判断を下したんだろうなという広い目で私は見てしまったところがあったんですけど、その後、イギリスのバージニア・ウェイドさんっていう、過去の、チャンピオンとかも「君がどうしてあの時にクレームを言わなかったんだ」って「あんなままやってたらあなたは勝ててたのに」っていうのはずっと、そうやっていろんな人から言ってもらったことはあったんですけど、客観的にこれはもうスーパーバイザー出てきたらもう言ったところで変わんないなって諦めちゃいましたね。はい、そんなことです。
素晴らしい気持ちだと思います。ありがとうございました。
そろそろお時間が迫ってまいりました。麻生先生の長年の懸案であった質問を聞けたところで、やはりこの本学会のテーマの、アスリートマネジメントにまさに伊達さんが出してくれたスライドですよね。あそこの5つの話、あれは非常に皆さん心に染みてるし、みんな、やってるよって感じですかね。
そうですよね、きっとね。はい。
そこが一番重要だから。
やっていただいてるとは思いつつ、引き続きアスリートの思いをもう一度お伝えしたかったなというところです。はい。
深く、指導深く胸に刻めるので、これからアスリートに接していこうと思います。では、本当、1時間の間、ありがとうございました、皆さん。このセッション終わりにします。最後、大きな拍手をお願いします。
ありがとうございました。以上をもちまして。
すみません。この後全員懇親会、イブニングセミナーが進んで全員懇親会なんですけど、伊達さんも全員懇親会に参加してくるそうなので、我々早めにイブニングセミナー関係ない我々は早めにちょっと懇親会場に行ってちょっとぼちぼち始めてようかと思いますので、もし伊達さんに個人的質問がある方がいらっしゃれば懇親会場の方においでください。以上です。
ありがとうございます。それでは以上をもちまして座談会を終了とさせていただきます。本日はご参加いただき誠にありがとうございました。お忘れ物などないようお気をつけてお帰りください。
お疲れです。完璧やった。
慶応の、多分ちょっと少しシャックが勉強されてる。あれは
い
肩を聞いて帰ります。大好物なんかでも全人婚姻審会に出てもいいかなと思って。いやいやいや、ちょっと
How far away is it?
It's 10 minutes from walk.
Okay.
Yeah. Their hotel.
Okay.
Their hotel is within the park. The other side.
Okay.
We are here in this Shiba Park. Their hotel is right there.
Let me just take a picture.
Prince Hotel. So we are here front, this blue, and the other side of the park is a Prince Hotel.
Prince. Okay.
So you can go through this Shiba Park to the hotel side. So basically, the walking distance is like 10 minutes.
Okay.
700 meters.
Okay. And it's called the Prince Hotel?
Prince Hotel. So you can maybe if you have a Google map, then then their hotel is Prince Hotel Tokyo. Just yes, Prince Hotel Tokyo.
This one.
Yeah, this one on top. So,
okay.
Then directions and walking. So,
okay.
So
Okay,
10 minutes
perfect.
from here.
Okay, perfect.
Yep.
5:30.
5:30.
Early.
5:30. Yeah, very early. Maybe a little rain, but Austin said it doesn't matter. Rain is okay.
Yeah, rain.
He can run.
Right.
Yeah. So we are there.
So I've got a question for you.
Yep.
So this, my kids love this.
Godzilla, yeah.
Right.
Uh-huh.
So how do I get here? What's the best way to get there? Take a taxi?
Shinjuku, yes. I think the taxi is easier.
Easier. So I go to the front, and what do I tell them? Do I just show them that?
Yeah.
They'll know?
Yeah. Then you can show them the address and see the Godzilla.
Yep.
Show the Godzilla. Then they'll take you there.
Okay.
Yeah.
I can do that. โอปอกลับมาแล้ว ตอนเย็นเหรอวันนี้ไหมที่ผมมีที่มันมาถ่ายในไทยก็จริงว่าเป็นไม่ใช่เป็นหมูเป็นเนื้อเป็นเนื้อโดยที่ออกมือถือที่ไปที่ตอนเข้ามาบ่าย2ที่เขาอยู่พิมพ์อยู่ชิบูย่าแล้วลงไปก็คือน้องฟังปุ๊บคนไปที่ห้างปุ๊บไม่แดกทุกอย่างแดกจนน้องแอมจะไปที่ไหนกินได้แค่นี้ที่เขียนกินกันปกใจแดกทุกวันเลยรวมกันเป็นไงล่ะเข้าไปเลยลายมันเกิดมันเสร็จถึงแล้วก็มาทำเองก็มีอร่อยแบบจริงแต่ว่าต้องคาดใจไม่ได้มาไม่กี่วันคือมาที่เนาะแบบมาพักผ่อนบ้างเราไปสั่งมาร้านเพราะฉะนั้นอย่าไปเสียเวลามากเริ่มเดินหน่อยก็ไปซื้อน้ำพริกไทยกันนะปิดตรงนี้ไปแดกที่ไหนมาทำเองมาญี่ปุ่นมาม่าก็อร่อยละลายคือที่ไทยตัวหลาทำเองทุกวันทำเป็นเลยติดตามบอสในสตอรี่ดูวิธีทำดูตอนเสร็จแล้วแต่มันก็เพลินเลยนะมันก็เป็นแบบผู้พันตัวไปเลยกลับบ้านเลยที่บ้านรอแดดคือว่าคุณไม่อยากกลับบ้านแล้วเราดูแบบกูไม่ได้กลับบ้านแล้วไม่ว่างเกินแล้วหมดเลย
So it's time to start the evening session. Please sit down. So welcome to the evening seminar, the biological augmentation in rotator cuff repair. I'm a moderator of this session, Nobuki Yamamoto from Tokyo University, Sendai, Japan, and co-moderator is Professor Jsoa. So we have four speakers today. The first speaker is Professor Jsoa. He talked about the mind-generating indication in 2025. Please start.
Thank you, JC. Thank you, Nobu. So I'm going to cover my indications for the Regenerative bioinductive implant in 2025. We've had this now for the last 3.5 years. I'm just going to go through what my indications for this are. We know that the incidence of failure of rotator cuff repair due to non-healing or re-tear is high. And as shoulder surgeons, we've always been looking out for options beyond just mechanical repair. We've been thinking of how do we biologically improve our repairs. And then came along this bioinductive implant, Regenerative. This is a type 1 collagen patch that promotes biological healing. It's not a structural graft and therefore cannot be used for its mechanical properties. It facilitates new tendon-like tissue growth and therefore changes the course of rotator cuff disease progression. And that, for me, is the most attractive part of using this implant. I'm going to go through what my indications today for this are, and I use this primarily in 3 situations.
The first is tendinopathy, the second is partial thickness rotator cuff tears, and the third is full thickness rotator cuff tears. And I'll show you examples of each. So let's see tendinopathy first. So this is a 40-year-old male. He's a recreational badminton player. He has right shoulder insidious onset pain since the past 2 years with no specific injury. That's his radiograph there. In April of 2023, he went to a shoulder surgeon who saw this. He had some effusion, gave him a corticosteroid injection in his subacromial space that gave him pain relief for some amount of time, and then this is what his MRI looked like in April of 23. So with this ultrasound-guided injection, he's feeling a little better, he gets back to playing, and then within a few months, he's back to square one. He's back to his pain, and he comes to me in Jan of 2024 with this painful shoulder. The rotator cuff itself seems intact. He's got a large subacromial spur there, he's got some bone edema in the greater tuberosity, he's got this bursitis there. We decided that this was time for surgery, and in that surgery, what do? We go down and this is what we see. He's got a significantly degenerate cuff, a lot of fraying on the bursal surface of the cuff. His articular surface was intact. And when we see a scenario like this, which is a lot of avascular tissue, poor biology, I think this is for me a primary indication for putting in a patch and helping this patient with his biology. So the first thing I do is debride off all of the loose tags and flaps of tissue that are there from the cuff. And I think that by doing this, you're at least getting off all of the mechanical, dead rotator cuff tissue, which is going to come in the way of healing. And once that's done, I check that I've got no further sort of impinging tissues, it's stable. I decided to do a subacromial decompression with an acromioplasty 2. As you'll see on the MRI, he's got a significant spur there, and I felt that getting that off was important. Now once I've done that, I've got these stable flaps, and I'm trying to decide, is there something that I should do to suture these back? But since I was going to put in a Regeneten implant, I just left these alone. The Regeneten implant comes on the bursal surface thereafter. And I typically like to position this so that I'm covering the entire muscle tendon junction and bring it right down to bone, and that's my implant there completed. So I normally would put it with 2 or 3 bone anchors and at least 3 or 4 of the soft tissue resorbable anchors. And when we look at the MRI 6 weeks following surgery, you can see that that's the implant still visible out there, but all of his changes of tendinopathy have decreased. And then when we look at his 1-year MRI, you can see that he's got a nice, healthy-looking rotator cuff tendon. He's been back to playing since almost the last 7 months, and he's been asymptomatic. So I think in certain cases of tendinopathy, it's very useful. The second is partial thickness rotator cuff tears. So this is a 25-year-old male. He's a competitive fast bowler in cricket, and he presented to me with a right shoulder partial thickness rotator cuff tear of the bursal surface with a slap lesion. And again, he's been injected twice, has had no relief, and therefore comes to me. I'm showing you this case because this is the only case where I did a relook arthroscopy, and I want to show you what it looks like. So this was the pre-op on the left. We had achieved a repair with Regeneten. 6 months down the line, he returned back to sports and has an injury, and when he had that injury, we went in for a relook. So I'll show you what the first surgery was. So of course, besides the slap repair, I did a repair of his bursal-sided cuff tear. It's a very small, partial thickness bursal-sided tear. I put in 2 sutures, brought those sutures out on the lateral row, and did my repair. And then on top of that, I've put my Regeneten. So again, classically, 6 soft tissue anchors and 2 or 3 peak anchors for the bone. And when I look at this 6 months down the line, this is what it looks like. It's completely resorbed Regeneten. You really can't see any of the implants there. Those implants, even the peak implants, we couldn't even observe any of the peak implants there. I think with the synovialization that takes place. So that looked like a really encouraging resorption. And we can see that that's caused a good thick rotator cuff. So I think on the whole, for partial thickness cuff tears too, it's useful. What about articular-sided cuff tears? So this is a 23-year-old female. She's a competitive javelin thrower. Right-sided partial thickness rotator cuff tear on the articular surface. And you can see that she's also got this cyst out here. And she's been injected at least 4 times in the past. And then by the time she comes to me, she's got this degenerate undersurface of the cuff that I need to debride. And once I debride that, I'm left with this significant loss of the tendon. The question is, what would I do at this stage? I would go ahead and just put in a regenerative patch on the top, on the articular surface. And sometimes it may seem a little counterintuitive. You've got a defect on the bursal surface, but I'm on the articular surface, and I'm putting the patch on the bursal surface. You can see how this behaves. So this is the MRI at 1 week, and we can see that that's the regenerative patch out there. By 3 months, you can still see it there, but there's been a creeping substitution, and that footprint is slowly getting covered, and by 6 months, it's completely covered. And there is a little bit of an inflammatory sort of response at that 6 months when the patch resorbs, but that's completely gone by 9 months. A good-looking tendon at 9 months, and when we see the 2-year post-op MR, you see that that's a nice healed rotator cuff. She's been back to throwing since almost a year and a half. And you can see that that's the articular part which we've patched on the top, and it's completely covered that footprint, and it's a good-looking tendon. You can see that that's the track that we make for the PEEK implant. And what about full thickness rotator cuff tears? So for full thickness rotator cuff tears, I use it for specific indications only. And those indications are basically tears that are complex and degenerative, or if there's tears at the muscle tendon junction, or delaminated tears, or for patients that have a failed cuff repair. And I'm going to show you a few examples of these. So take this patient, for example. This is a full thickness tear, but it's a small tear. But you've got significant tendinopathy within the entire tendon. So this entire tendon has a lot of degenerative change in it. This patient has already received multiple injections. And so in this case, although it's a small tear, to improve on the biology, I'm going to repair it. So we're seeing this from the articular side. I'm going to debride it first, repair it, and then once it's repaired, I'm going to put the regenerative implant on the bursal surface. So even if it's a small tear, there's a lot of biology deficiency in the form of tendinopathy. I'm going to be using it. What about muscle tendon junction tears? So take, for example, this patient here. This is a tear of the rotator cuff, a large spur, a flipped tendon out here. This patient's in significant pain. Again, when I go down, this is what it looks like. So you've got a degenerate cuff, lots of flaps, a large spur. Those are the flipped portions of the tendon, and those flipped portions of the tendon are largely avascular. I need to debride that. Once I've debrided it, you can see that I've lost a significant amount of the tendon. There's an issue of biology here, and he's 54. I think that if I was to just go ahead and repair this, my re-tear rate is going to be anywhere close to, I would say, 30%. So yes, I can reduce it. I can bring the deeper layer back to the medial edge of the greater tuberosity. And the superficial lamination, the bursal area, again I can cover that. And so I will take end-to-end sutures here in the posterior aspect of the cuff. And I'm going to repair this tear. But if I just repair it, I suspect that I'd have a really high re-tear rate. And so in a case like this, where I've had an issue of biology, I've got some deficient tendon, there's a muscle tendon junction tear, I would rather put in a bioinductive implant. So I put in the regenerative thereafter, and that's the regenerative bioinductive implant that's been inserted. And let's see what the MRI looks like. So again, at the 1 week post-op, we can see that that's the regenerative implant sitting there on top of my repair. This entire area gets filled up by 6 weeks. So 6 weeks, we can still see that that's the implant out there. and the area in between is getting filled up with tissue. By the time it's 3 months, this implant is just getting resorbed. That's the time that there's a mild inflammatory response out here, but the healing's taken place. And then by 6 months, you've got a really nice, thick tendon, no tendinopathy. And this gives me the encouragement that this patient is probably not going to have a re-tear. And then by 2 years, you can see that that change is still there. He's got a nice tendon, no tendinopathy. He's not lost any tendon. And so I think in these difficult scenarios where your re-tear rates are going to be high risk for re-tear, for me, is an indication for putting in the bioinductive implant. I also use it for all of my failed cuffs when I'm doing a revision cuff repair. I would always use an inductive implant like this. So again, this patient with a failed rotator cuff tear that I'm going to be able to repair. Once I've repaired it, if it's even a medialized single row repair, I'm going to put in a Regeniten implant, and this would be my specific indication for this. So my last 3 years with Regeniten have been quite encouraging, and with these promising short-term clinical and radiological results, I think it's useful for indicated patients. Thank you.
Have a discussion on Jsoa. And now you have a 3-minute discussion. So, in India, the insurance covers the Regeniten.
Yeah, so if you have a private insurance, then in India, Regeniten gets covered by that. But if it's the government insurance or you're going through government healthcare, then they'll pay for everything but for this. So I think that's a bit of a challenge right now. Therefore, we need to use it for indicated patients where we think it's going to make a big difference. I think in a high-risk failure case, using a Regeniten and reducing your re-tear rates, we know from Miguel's study, which is a randomized control study with your large rotator cuff tears. If we were not to do a Regeniten, the radiological re-tear rate is going to be about 25%. But by putting in a patch, a bioinductive Regeniten patch, you're reducing this down at least 3-fold. So for me, a re-tear and a re-surgery is going to be very expensive. So in any high-risk situation, I'd rather use it.
Is there any question from the audience?
Do you do, for pasta, do you do any microfracturing or any, you do microfracturing and then put it on top?
And then put it on top. So I'm trying to do everything I can from the biology. So I'm going to debride it on the undersurface. Typically, a lot of these patients have cysts, so on the bone that's exposed, I'm going to take a microfracture, decompress the cyst. I think that also helps. You're trying to get innate biology there. And then I put the bioinductive implant or Regeniten on the articular surface just to help with the whole biology and healing process.
Regarding your bone anchor, the PEEK, some of the surgeons, for example, some of them you don't need to use them, especially for your tendinopathy patients. And some of them just use one because it's non-absorbable, it's PEEK, it might dislodge and then it might cause problem. So what's your thought on that?
For me, I think it's important that you've got a very stable bioinductive implant there. If your implant itself is not sticking onto the rotator cuff, it's unstable and you've got flaps that are moving up and down with movement, I think there's a high chance that's going to shear off and fail. So I want a stable implant there. And Des Bokor, who started off with this, he taught me that the best thing to do is have this implant running right from the muscle tendon junction, cover the entire tendon, and come right up to the bone. So as far as possible, I try and put in at least 2 PEEK implants. To be quite honest, I'm not too concerned about the PEEK because the PEEK is bio-inert, so it doesn't cause any problem. My concerns are more with the soft tissue tendon anchors because those resorb, and when they resorb, they may cause some amount of inflammation. So I try and reduce the number of soft tissue anchors that I'm using on the tendon.
The case with articular side tear, you just debride, no repair, and put the Regeniten. So you think that also can be the indication for Regeniten?
I think that's a good indication. I think my presentation tomorrow, where we've done a comparative study of repairs versus just an isolated bioinductive repair, I'm going to present it tomorrow. I think we've seen that it's quite encouraging, and at least your patients are going to get back to their sports a little faster. So by not doing a repair, because as soon as we've done a repair, we tend to protect them. Whereas if we have done just an isolated bioinductive repair where you just put the implant in, your rehabilitation starts much earlier. So I think that these athletes can get back a little faster.
Thank you. Thank you, Jsoa.
Thank you.
Next speaker is Professor Jsoa. He talk about early experience with genetic in Korea.
Okay, thank you. Thank you for the invitation. Thank you, Smith and Nephew, for. I think this is not the. Sorry, wrong slide. It's on.
So Jsoa, please come up stage until the Jesse is prepared. Jsoa. So we have some time until the Jesse. Oh. Okay. Sorry, he can present.
Work out. I've been sitting all day. Thank you for. I have no conflict of interest. Maybe I need some. And I remind you, KSCS in March in Busan, and APCAS in Seoul, Incheon in September. So just remind you that I wear the orange hat when I'm doing Regeniten. So Jsoa is doing that. And so I'll just go over very briefly the papers. There's about 20 papers now. Jsoa already mentioned it incorporates 6 months. It looks like results of tendon-like tissue. I just pointed out a few key papers that Des Boker said it increases 2.2 millimeters tendon-like tissue. One of the couple of studies by Michael Rubens-Iban is saying that it reduces retail rate up to about 3-fold. It's a high tendon healing rate compared in a double row in large to massive tears. Des Boker recently published that it has a lower retail rate, 13% time versus 37%. This is the recent paper they published. Honestly, the number is too good, but in my mind, because their retail rate for control is 25% in a medium to large, which is, from my perspective, is a little bit too high. But anyway, they have a very good, they lowered this retail to 8.3, and this holds up to 2-year follow-up at 12.3% to 35%, which is like 3 times better. There's no clinical difference at that time, but if you have a retear, there is a clinical difference, which is very, very obvious. So I think my indication is kind of same with the Jsoa's indication. It's definitely useful in revision rotator cuff. Type 2 and 3 repair, meaning, I'll show you a little bit later, like tendinopathy, any tears that you repair. There are severe bursts of partial tears. Like I think the Jsoa, the case you show, the first tendinopathy, I consider that as a burst of partial tear. And then I even now putting out in subscapulous repairs. So it's still evolving. So what I meant by type 2 and 3 repair is that when by repair, if your supra and infra comes somewhere halfway between greater tuberosity or just barely touching the greater tuberosity is type 2-3 repair. Try to use that in all 3 cases. So this is the large tear, and that's the defect. So if we can patch this, will be a good indication. This is another type 3 repair. There's the defect. So if we patch that, then maybe we can have better tendon healing at that portion. Some of the partial tears, like this kind of cases, so it looks as if we can repair it mostly. So I try to repair like this, and then that's the tendon defect. And then if this is the before, there were Regeniten, which we did all patch augmentation like this, but now we switched from patch augmentation, which takes a lot of time, to this. So in revision cases, this is a male 34. You can see there's a defect there, and try to get rid of all the tissues. So most of the revision cases, the tissue are not that good. So once you take out everything, and then you repair. Currently, I'm doing most of the cases all repair and then augmenting with the Regeniten on top of it. So that's my repair, and then you just saw Jsoa showing you this. I'll share a little bit of the technical things that's going on. And honestly, from my point of view, this is like 2 days after Regeniten, and with the swelling and edema, it's a little bit difficult to really see where the tendon is. It's very thin. But if you can kind of guess where it is, it's somewhere there. So this is, and there's another case, like the case that we saw from Jsoa there. It's like very, very poor tendon here, small tear here, poor tendon here. These are the good indications for, so it looks like this if you see the tendon. And from my point of view, I mean, there is a temptation to just put the tendon Regeniten on here and just do what, just leave it. But I always think that repair is a little bit more stronger than just putting a Regeniten tissue there. So I think these cases are very good indication. Recently, I've been doing it on anyone who said they want it on their repair. So this is a subscap small tear here. This is from the Versa view. He just came back for 6 months. It looks like this, the crocoid there, Regeniten on top of that repair. This is another subscap tear, a little bit large. So this is the entire footprint is exposed. After repair, that's the Regeniten on top. So what's my surgical experience? So please keep in mind, never this pretty. You always get frustrated that it doesn't look like that. I mean, the picture is so good, but we can never get a really nice picture like this. So don't get frustrated. And I saw Jsoa's case, so it's kind of same with me. So the portal, initially when I was first doing this, I thought a lot about the portals and how to get the graft in and how to get the soft tissue staples in. And so if you really wanted to have a really nicely sit on top of it, then you really have to think about this. It takes a little more time, because when you have your graft, when you do your repair first, that's the anterior margin of the supraspinatus. That's where your Regeniten wants, and that's where your staple wants. This is the perfect ideal solution, but eventually that's not doesn't happen that way. It's not the perfect world. This is a little bit too medial. Sometimes the graft goes from anterior to posterior, or the graft comes from, depending on your portal, it comes from posterior to anterior. So initially I tried to get this perfectly on the lateral border, but eventually what I found out is whether it comes from posterior, or this is high portal, so it comes from posterior, or it comes very high. You'll see it in this, that's the horizontal, it comes very high photo. It's a little bit more difficult if it comes very high photo, especially on the left shoulder. My viewing photo is from anterior, which makes this a little bit high. And eventually, I tried to put it a little bit more perpendicular, more horizontal, but then I realized that instead of doing this, I'll tell you later that using the soft tissue staples, usually that's my anchor photo right there, but the soft tissue cannula has to be a little bit higher up to make that medial staples. And you can see that it's a little bit high up. And this positioning, you need to position your staple cannula prior, see if it really works very well to see whether to get the whole 4 corners or 3 corners. So that's kind of, you need to a little bit determine before. And one of the tips was that put the cannula and then, because it kind of rips, put the cannula gently and then you just press it on your staples. That was another tip. So eventually the common medial position, one of the issue is that because you keep putting medially, your staples are medial, everything goes medially, eventually your pads tend to go a little bit medial. So watch out for that. So you need to go a little bit, first you make that stitch and you cannot go out to become a lateral. And even if you try to salvage it, it's a little bit more medial than you wanted. So these are the couple of cases that I'll want to share. These are small to medium-sized tear. Usually tissues are not as good, just like what we saw in Jsoa's case. Tissue's not good, so I usually repair all of them, and then try to put Regeniten as we saw. This is a little bit more lateral, so you have to make sure it's a little bit more lateral. This is the first day MRI. This is about 5 months. You can see the tendon tissue is very nice. Another case is very similar there. I think when you have these kind of poor tissues on a bursa side, these are like perfect cases that gives you the feeling that you really need something to augment, but you don't want to spend another 30 minutes to an hour doing patch augmentation with some dermal allografts. So that's their cases. And as you can see, you can kind of guess that's the tendon, but sometimes it's very difficult to see where it is. I try to make that AP and medial lateral and height as accurate as possible, but eventually what happens is you can go in anywhere like this and makes it a little bit difficult. So one of the tips was that first put 3 or 4 staples and take it out. So this is from posterior to anterior. You put 3 or 4 staples and then you take out, and then you can use these kind of staples to make it come more anterior. So that's one of the tips that I recommend. And you can use any cannula actually. This is the cannula from the company, but you can just use any cannula that works for you best, because sometimes this cannula does not reach where you want it to put. And do we need peak? That was my question. Do we need peak staples? And sometimes, if you have a defect, yes. But I sometimes don't put peak teeth, and I usually try to put 1 peak. And this is what it looks like 6 months. I'll show you a vast number. This is the pre-op, repair, Regeniten at 6 months. This is probably not that good looking MRI. This is medium tear, repair, Regeniten. This is a little bit better looking MRI. This is another medium-sized tear, repair and Regeniten. This looks much better MRI. This is another bursa tear, Regeniten, repair and Regeniten. The MRI looks very nice at 6 months in many cases. This is a large tear, repair incomplete Regeniten, and the MRI looks very nice. So, although we have, I don't know if we have less repair, but MRI looks very nice. This is another small tear, Regeniten repair, and then the MRI looks very nice. So far, I did about 100 cases. We just had a celebration for that. We looked at, among them, we had 6 months follow-up with about 37 cases. We looked at, with the control, without, we did a pre-op evaluation and we tried to put a control on it with the same tear size and repair. And you can see the tendon thickness, although this was measured by 2 independent readers, was about 2 millimeter thickness, which is kind of somewhat the same result with Despoker, but this has to be proven a little bit more. And currently for retail rates, we had retail in both group 1 each, so that didn't really change, unfortunately. So in summary, surgical technique is quite simple. Some minor tips may help to make it more simple. I think the indication is expanding if the patient can afford it. Hopefully it helps to reduce re-tear. I think that's my key interest. If it reduces the re-tear to like a half, that would be even great. Enhance tendon healing, preserve repair tendon for a long time. Thank you very much.
Thank you, Jesse. And in Korea, the Regeniten is covered by the insurance?
No, currently it's not covered, but Koreans have so all the Koreans have a national insurance, so it's covered for the surgery. But for some of the products like Regeniten or MRI, it's not covered. But many of them, at least patients that I have, many of them have a private insurance, which covers 100% to somewhere around 50%. So those people who have private insurance are willing to go through the surgery more. I don't know if you know, but the price of rotator cuff repair for a patient in Korea is so cheap that even if they don't have insurance, they can pay anything. That's personal opinion.
Is there any question from the audience? Yes, please.
I have a question about subscapularis repair with Regeniten. You do Regeniten on top of the repaired subscapularis, and then after post-operative rehabilitation protocol, do you restrict any range of motion, on pronation, spination, or arm internal rotation?
So honestly, the Regeniten is quite expensive. So I wanted to sit it for at least 1 or 2 weeks. Other than that, all the other rehab protocol is same with the rotator cuff protocol. So probably for that subscap repair, which wasn't big, I would have moved immediately. But since I did Regeniten, I tried to move them 1 or 2 weeks later, just to have them sit on it. I don't think we need peak anchors, but I think if we let it heal, it's very thin. It will try to stick to the tissue as early as possible. I don't have a second look, so I'm not sure.
Thank you very much.
I have never used for repair of the subscap. Which bottle are you using to press the...
Very good question. You can either use, so I have 4 portals. That's basic portals, which is anterior posterior, and there's 2 portals lateral. One is superior posterior, one is inferior anterior. And usually it works with the inferior anterior lateral portal. But sometimes you might want another, from the anterior portal to that portal, there is a big space in between where I put the, I tried to do tenodesis anchor. That's my biceps, right in front of the biceps groove, there's a tenodesis anchor portal. I might use that to put the graft on. It's first it looks a little bit tricky, but once you do one, I think it's not that difficult.
Yes, please.
Thank you for your great presentation. I was wondering about your indication for subscapularis tear. Is that because like subscapularis tear is susceptible for like radial risk? Or is there any other reason for regenerating like indication?
Well, that's a good question. Usually the subscap tear has less re-tear rate than supra or infra in my series. So I have many subscap repair studies, which is less than 5 to 8% re-tear rate versus supra infra, which is sometimes 10 to 20%. So it's more logical to use it in supra infra if it's torn together. If this is an isolated subscap tear, if the patient wants an augmentation, I said why not? So if I have a supra and a subscap tear, which has about the same size, I would go for the supra instead of the subscap. Because subscap, from my point of view, has less re-tear rate than supra.
Okay, thank you. And one additional question. Even for a small tear or medium tear, which is highly likely to heal, would you consider to put Regeneten if the patient has several radial risks, such as age and diabetes or so on?
Not only that, but all these small to medium-sized tear have some tendon loss. From my point of view, I think they usually have tendon loss. There is no tear that doesn't have tendon thinning or loss. So even small to medium tears, although their re-tear rate is around 5 to 10% in some series, very low re-tear rate. I think even if we can reduce that to 0% or maybe 1%, that's worth it. So it's the same thing, if the patient can afford it, I think just putting on an extra 5 to 10 minutes of surgery would be no problem.
Okay, thank you.
Thank you, Jesse. Let's move to the next speaker.
Okay, so I was supposed to be introducing Japanese doctors. So the next speaker is from Nippon Kokan Fukuyama Hospital. And the doctor name is Hisayoshi Kato. He will talk about indication and challenges of Regeneten collagen implants for rotator cuff tears. Insight from over 1 year follow. Please, thank you.
Thank you very much for introducing me. I would like to express my sincere gratitude to Dr. Jsoa Chairman and Sniffing Company for giving me this opportunity to present. Today, I will share our experience with the Regeneten implant, focus on its indications and limitations. Regeneten has been available in Japan since 2023, so far about 2 years now. Recently, the number of cases using this implant has been steadily increasing. However, it still remains unclear how we should use it and how effective it really is. I would like to share our experience from clinical cases. Its primary role is act as a biological scaffold, and over time it is replaced by tendon-like tissue, which reinforce the repair, but the graft does not provide immediate mechanical strength. As surgery, the implant was placed like this. 1 year later, it is completely absorbed, only the bone stapler remains. A Regeneten implant offers several benefits. It relieves pain, improves shoulder function, and may lower the risk of tears, supports reliable healing, allowing early rehabilitation and return to work. Since June 2023, over 5,200 patients have been treated at about 400 hospitals. Monthly usage continues to rise nationwide. This video demonstrates a surgical procedure. The Rogerten implant is inserted through the lateral portal. Here the assistant is holding the implant while we fix it proximal with 2 to 3 staples. We carefully release the implant from the guide and secure the distal side with bone staple. Finally, we use the remaining staple to finish the fixation. In my own practice, good indications include large and massive rotator cuff tears, as well as basal side tear and calcific tendinitis. In the USA, about half of the cases are full thickness tears. In Japan, in 2024, 90% were full thickness, but by 2025, partial thickness tears increased to 30%. This shows a gradual shift in indications. This case had a rotator cuff repair 20 years ago and early tear occurred. The calf condition was poor, but still repairable. Since full coverage was not possible, the repair was augmented with regenerating implant. Post-operatively, the course has good, with marked improvement in both range of motion and clinical scores. In massive tears, shortened tendon and advanced fatty degeneration lead to poor outcome. Indications are thin or short tendons and incomplete coverage of footprint. This procedure is not indicated for rotator cuff tears that cannot be mobilized to the footprint. In this case, augmentation promotes healing of damaged rotator cuff. Between August 2023 and July 2025, 398 cases were treated, 92 with regenerative. In large and massive tears, we followed 22 patients for over 1 year. We compared these two groups. This slide shows the regenerative results. And the regenerating group include more severe cases with a high GFDI and more patients in stage 3 and 4 retraction. Constant score and range of motion improved significantly after surgery. No significant difference between the two groups. The repair rate was 9.1% in both groups, with no significant difference. Tendon thickness increased significantly after surgery and was maintained up to 12 months. At 12 months, the regenerating group showed greater tendon thickness. Effusion in both the glenohumeral joint and subacromial improved significantly after surgery. However, there was no significant difference between the two groups. Regenerating group included more severe cases, no significant difference was seen in clinical score, repair rate, range of motion, and effusion. Only tenderness thickness was greater in regenerating group. This is a rare case. Repair occurred 2.5 months post-operatively after farm work. However, since the implant remained in place, the tendon gradually regenerated. At 20 months and 12 months, calf had healed. This is a 19-year-old male with rheumatoid arthritis and advanced fat degeneration. Despite the use of Jsoa, the primary repair failed in his case. This case highlights the importance of patient selection, and we should be cautious in cases with advanced fat degeneration, rheumatoid arthritis, or elderly patients. Since April 2024, however, we have not observed in retailers. There were 12 cases of bursitis and calcific tendinitis that could be for more than 1 year. We apply it when there is superficial layer deep or severe thickening, while the deep layer is still intact. The main goal is allow early rehabilitation and a quick return to work. Here, the calcium is deposited inside the rotator cuff. Monthly inflammation is observed. After removing the calcium deposit, the superficial layer shows a partial defect, while the deep layer remains intact. Here, we left the superficial layer and repaired and placed the implant to cover the defect. By 2 months, tendon-like tissue appeared, and by 6 months, it was nearly completely remodeled. And the regenerating group, active motion starts at 4 weeks. We evaluated the following 5 items. Results. Both groups showed significant improvement in constant score and range of motion, but there is no significant difference between them. Note here in either group, there is no significant difference between 2 groups. Abduction strength improved in both groups, with no significant difference between them. In the regenerative group, the tendon thickness increased significantly after surgery and was maintained up to 12 months. The thickness was consistently greater in regenerative group. The outcomes were similar between the 2 groups, except tendon thickness, which was significantly greater in regenerative group. And despite starting rehabilitation earlier, there was no problem. Articular tears may not be a suitable indication for regeneration, in my experience. But since the number of cases is very small, this remains uncertain. So I say that the articular tears remain controversial. The regenerative implant reduces stress concentration. It lowers intertendinous strain and may improve tendon healing and durability. Previous literature also support this finding. Volker reported that the tendon thickness increased by about 2 millimeters, and 92% of patients had good results at 24 months. With tears mainly result from failure of primary repair, not from the implant itself. Regenerative is not a substitute for primary repair. In our series, the 2 retained were good carrier way forward. This study evaluated the safety of regenerative implant in ARCR. The implant did not significantly affect post-operative inflammatory responses or increase the risk of infusion. In our study, the regenerative proved to be a safe procedure. The limitations, a small sample size, short follow-up, possibly bias in patient selection, and the learning curve. In large and massive rotator tears, as well as basal side rotator tears, calcium tendinitis, clinical results were good. Repair was there. Tendon thickness increased post-operatively and maintained up to 12 months. Range of motion, abduction strength improved, and no additional complication. Thank you for your attention.
Okay, nice talk. Any questions from the floor? Unfortunately, your results are very nice, except there's no difference in repair. And I think one of the key interests is to reduce repair with this Regeneten. Why do you think there was no difference, or, I know it's a difficult question, but.
Yeah, it's very good question. Actually, there's no difference between two groups. But in larger muscle tears, the Regeneten group really includes worse conditions, but the repair rate was small. And so, Regeneten implants suitable for larger muscle tears, I think.
Are you not using it since your study does not show medium size, small to medium, you're not using small, medium?
Sometimes I use this medium size. For narrow thinning and flying tissue, I did.
But not all cases?
No cases.
Even the patient wanted?
What?
If the patient wanted, there's no tendon is good.
Yes.
Good repair.
Yeah.
But the patient wants it. Do you?
I don't ask the patient, but for me, I want to be put the
because some of the Korean patients, they said they want Regeneten.
Nowadays, that's too expensive.
And I recently had, so I didn't start doing any non-repair Regenetens, like tendinosis patients, but now the patients said they don't want to repair, they just want Regeneten. And so, is there, I don't know if you have the same experience, but is there a patient that comes said, just put Regeneten, but no repair? Do you have that experience?
It's important. Primary repair is very important, I think.
Okay, thank you very much. We'll go on to the next speaker. Next speaker is Jsoa from Jsoa University with my clinical experience and indication for Regeneten implant. Please.
Thank you, JC. And for the arthroscopic rotator cuff tear, if we using SCR tendon transfer or exmedialization, probably to ignore the repair or rotator cuff is repairable. And however, the repair rate does not become 0%. So that important to prevent post-ARCL pain, functional disorders, important to prevent revision surgery is important. This is one case before ARCL for the massive rotator cuff tear. 3 months later, the repair is good. However, 6 months later, the repair happened and he had a pseudo-paralytic after ARCL. So that we want to prevent in these cases. So our strategy in recent trend of rotator cuff tearing in Japan, the standard, if the lymphatic infiltration is not severe, the standard ARCL. However, the little bit severe fatigue generation, if the over the 65 years, probably the reverse shoulder is recommended. But however, under the 65 or so, ARCR with augmentation such as SCR, or recently the muscle advancement is becoming popular, and pec minor transfer, partial repair, or the metallization. So retear rate previously reported was 5 to 57%, and it depends on the tear size, tissue quality, fatty degeneration, muscle atrophy, and timing of repair, and patient factor that is also important, DM, smoke, organ disease, so that the decreased retear rate with augmentation. So augmentation for ARCR is some kind of autograft. These are long head biceps or fasciolata, or in this session we can use regenerating. And the biological augmentation such as a PRP or DMAP or microfracture, so that the additional augmentation using plastic sheet is effective or not. So we must evaluate. So my use for regenerating, for the partial thickness tear, the regenerating only, or the take down to complete repair with ARCR with regenerating, or the full thickness tear with using ARCR with regenerating. And my practice, most of the cases, a full thickness tear. So advantage of using regenerating is induction, regeneration, tendon-like tissue, and good clinical outcome even with isolated regenerating for partial thickness tear, and the reduced retear rate after ARCR, even in the large to massive rotator cuff tear, and persistent increase in rotator cuff thickness and functional improvement. And my usage of the regenerating, I use viewing from the posterolateral portal, and tendon staple is inserted from the anterior portal, and the anterolateral portal is the insertion of the regenerating and the bone staple. So the most popular position of the regenerating is probably the anterior side, and at first the most major for the tendon staple using an anterior portal and 2 or 3 tendon staples inserted, then throughout the devices, and after that 2 or 3 bone staples inserted to the greater tuberosity, and then the rest of the staple inserted. This is a viewing from the one case, the viewing from the posterolateral portal, and inserted even in the anterolateral portal, and the cannula is inserted from the anterior portal. And at first, 2 or 3 tendon staples inserted from the anterior portal.
ว่าไงไม่อะยังอยู่งานอยู่เลยใช่ เก็บไปเลยเดี๋ยวไม่รู้เขารวมตัวยังไม่มีสัญญาณอะไรเลย
Then pull out the devices and next bone staples inserted to the greater tuberosity. In my practice, almost all the cases I use bone staple to the greater tuberosity. Normally the 2 bone staples inserted. At first the anterior side, next is the posterior side.
มันมีไอ้เนี่ยสปีกเกอร์ยังพูด
Then after the remove the devices and the cannula is another cannula is inserted in from the anterior portal, anterolateral portal. Then the rest of the tendon staple to the posterior side.
ดังนั้นเดี๋ยวไปไหนแล้ว
Inserted the rest of the 3 or 4 staples from the posterior side. And this is the regenerating after 3 months after. Most of the cases we can see the low intensity of the regenerating. However, some cases has iso intensity cases, and some cases has kids are high under the regenerating. I think that it's a little bit fluid fixation, and sometimes we can see the synovitis. But normally the good cases we can see that 6 months later a little bit higher, but 1 year later the good healing is achieved. This is a synovitis at the 3 months after, but it healed after 6 months. And this case is another one, is a synovitis happened at 6 months, but it healed after 1 year. And this is my critical outcome follow-up, more than 1 year, 206 cases. And for the partial thickness tear, the classification is 30 cases, small case tear is 60, and medium size is 67, large is 49, and massive tear is 70 cases. And the clinical outcome throughout more than 1 year is significantly improved in the natural motion clinical outcomes. How about the retear rate? The small case, small tear, only 1 cases of repair, and medium size is 3 cases for the 4.1%, and large cases are 7 cases, so that 14.3%, and massive tear is 2 cases for the 11.7%. So the total read is 6.3%. I think that it can decrease the repair rate. How about the effect for the tendon thickness? I evaluated the tendon volume for the 3 slices of oblique corner average of 3 slices, and evaluated 3, 6, and 12 months. And the tendon volume significantly increased. And how about according to the tear pattern? The tear pattern is divided in a crescent, U-shape, and L-shape and L-shaped tear. And this is one case of the anterior L-shaped tear with a triple roll repair with regenerating. At first, the subscapularis repair. Then after the posterior side, using a triple roll repair and the LHP augmentation, the reduction anchors inserted in the greater velocity and triple roll repair. At first, the reduction anchor, the repair rate, and over the breaching anchor. Then after the regenerate is inserted to the anterior portion with the same manner. And this is the demographic data of the compare with or without regenerate. The U-shaped tear is and the L-shaped tear, P-shaped tear. It's a little bit different in the number of the cases. How about the repair rate? The U-shape for the U-shaped tear, the repair rate is 13.7% for the not using. And using, if you use, the repair rate is 10%. For the L-shaped tear, not using the regenerating, 22.2%. However, they're using the regenerating only 7.7%. And for the PL-shaped tear, if you cannot use the regenerating, the 50%. But if I use the regenerating, only the 9.5%. So that there is no statistical significantly different, but a little bit lower the repair rate. How about for the post-preflop tear? The post-preflop tear is reported by Lederman, and it reported that the high repair rate and hard to repair anatomically, and the suture bridge technique is higher in the repair rate. So that the triple roll repair is useful, and stroke generation of the tendon stump is a problem. And this is the case of the post-preflop tear. At first, the repair is using a triple roll repair. And the reduction anchor is also inserted in the greater velocity. Then the repair, and after that, the cover the regenerating over it. And this is right side is the MRI after the surgery, the before the post-preflop tear. After the 1 year follow-up, a good healing is achieved. And I use it for the only 50 cases, but there is no repair rate right now. And how about the regenerating after the 3 months? I show you that before that the low intensity is a good one, and some cases has a iso intensity, and some cases has a high intensity between the tendon and the regenerating. So the most of the cases has a low intensity, but some cases 4.59% is the iso intensity and high intensity in the, under the regenerating. And sometimes we can find the MRI that the erosion of the greater velocity. And this is the more than 1 year follow-up, about 206 cases. We can see the 41 cases of this situation, but no correlation with clinical outcome. And how about the repair cases? And for the, right now, we can find that the 30 case of the repair and 6.3%. For the U-shaped and L-shaped and PL-shaped tear, down 9% of repair rate. And this the right side is the repair cases, and after 6 months we can find the short classification type 2 repair. And finally, reverse shoulder arthroplasty do in the 3 cases for the patient with 87 years, 80 years, and 60, 90-year-old. So that, but I cannot find a very different characteristic of the repair right now. This is one case of the repair case, 80-year-old female, and she had a right anterior sutural tear, and using a bridging suture and the tenotomy of the LHB. And she had spinocerebellar degeneration, so that she had a weight bearing shoulder. So after the 3 months, the strong pain with consulting treatment does not heal. So after the MRI showed that the synovitis and the granite fracture of the anterior side and the erosion of the greater velocity. So we irradiated the liver shoulder arthroplasty for her. And how about the complication? The previous paper showed that the regenerative shoulder severe contracture in 8 cases and some kind of synovitis happen. So that there is probably the risk of synovitis and contracture. And this is one case on the operation after ARCR with regenerative. This is a 66-year-old female, and she had an anterior L-shaped tear, and I used a triple-row ARCR. After 3 months, the swelling and puncture and culture showed a negative no infection. The MRI showed that this kind of synovitis in the subacromial space. And this is the tear of the anterior L-shaped tear. And using the same manner with the triple-row repair and regenerative coverage. But after 3 months, this is the operation surgery, the little of synovitis, and probably this is the stop the pregnancy and remove the bone staple and the tendon staple. But the tendon healing is very good, so that she had 1 year after the surgery, the good healing in the rotator tendon. And for the how about the irreparable latch to massive rotator cuff? For the massive rotator cuff, our choices is a partial repair and transfer. And recently, the Japanese doctor wants like to do the muscle advancement technique and SCR and the liver shoulder practice. And we cannot use the allograft of Achilles tendon, so the trapezius transfer is not popular in Japan. So the recently reported from the Kyoto group, Dr. Morihara and Dr. Furukawa showed that the oral arthroscopic deviapathic procedure or the muscle advancement technique. And also the Australia group showed that the arthroscopic muscle advancement technique, and they show that the low repair rate. And one another surgery is the X-medialization technique from Dr. Mizuki reported, and cut the medial side of the humeral head and repair to the resected side. And this is one case of the massive irreparable rotator cuff tear. And the 85-year-old massive rotator cuff tear, and he had a bilateral shoulder pain. And I did the left side liver shoulder arthroplasty before, but he's not satisfied for the liver shoulder arthroplasty, so that he desired for the rotator cuff repair. But the MRI showed that severe fatigue degeneration of the tendon. And this is the one case, and right side shoulder, and the massive rotator cuff tear and severe retracted tendon. After the muscle advancement, for the this is the scapular spine medial side and the release of the scapular nerve. Then after we can repair and for the release from the infraspinous 2 and remove the greater velocity and repair using a bridging suture. But we cover the greater velocity so that the regenerative over the repair side and cover the greater velocity. And after the surgery, the MRI showed a good healing. And probably the Dr. Suenaga's group reported that the regenerative covered the exposure to greater velocity, showed that the hematoma-like tissue make a new tendon, and I think that it's good for the make a regeneration of the tendon. And how about subscapularis? There's no paper in for the subscapularis. The JC told me that using the subscapularis, but I only use only 2 or 3 cases, so the clinical data, I have no data for the subscapularis, but probably it will be good for the degenerated subscapularis. Further investigation is necessary, but probably it will be good. So lastly, the augmentation regenerating indication is a poor tendon quality of anterior superior side, such as the anterior L or the PH shape and U-shaped tear, and if the partial repair. And such as a degenerative tear, such as a phospholipid tear, is one of the indication, and higher risk of the repair, such as a large to massive tear. But probably that's still controversial, and we need a further investigation. So that with using regenerating right now, probably more and more cases, probably we can finish the 5 minutes. So sometimes hard with the large CS bar cases and narrow space of SAD. So sometimes ASD is useful. And one of the problem is cost issue. And regenerating is covered by government insurance in Japan, so that it's easier to use it. But we need to clarify the benefit of the regenerating, and we need to examine the further investigation. Thank you for your attention.
Thank you. Okay, we're slightly over, so just maybe one question from the floor. Okay.
Thank you for the question. I have a question about the thickness of the tendon. You show that over time the thickness is increasing after 3 or 6 or 12 months. Do you have the data after 1 year?
1 year, the probably is same with the little bit tendon volume is a little bit increased after 1 year. Then there's no difference in the 16 and 12 months.
Thank you.
Okay, I have 5 questions, but I'll skip it and ask them later. Okay, thank you very much for all speakers for giving a wonderful session. Do you have any closing comment?
最後にですね、アンケート用紙に QR コードが書いてあるのがあると思いますので、ぜひ記入してお帰りください。ありがとうございました。